John, can you send me the YouTube link?
Send you what?
The YouTube link.
Yeah. Hold on. I'm working on that right now.
Okay.
Like John, if you can you see what is the
Send you what? Yeah. Hold on. I'm working on that right now.
Okay.
Okay, I'm putting the YouTube link and the Karad meeting thing.
John, is it possible that we have their video maximized because we can see a grid view of all of us? So let's put it to the speaker view, I think.
Okay, well, the speaker's not on. You're talking about hello, Nilesh, can you we can't hear you. You're muted. We can't hear you. Or you're not muted. The microphone's not working. I
think the person from the Dr. Knowledge have to share screen.
Has to change. Nilesh, are you there?
No, I think instead of a share screen, it has to be on the speaker's view because sharing screen was.
No, he's not getting any sound. That's why it's not going to him. I think the microphone is not working right. If he gave sound, the camera would go to him.
So, John, do you have that option in which you can have only their screen shown?
Hello. No, I have to. I can't override the option of go. Well, I can override it, but we don't.
Yeah.
Want to. We don't want to. We want
Hello.
to.
Hello.
Yes. Hello, Nilesh. Is that you?
Hey, John.
Yes. Okay. There we go.
Can you hear me?
Yeah.
Yeah. So what Nilesh is doing right now? Can you see the field right now?
Yeah. Yeah. From a distance, from your where you're at.
Can you see it right now?
Yeah, I can see some hairy skin. I don't know where.
Yeah. John, what are you seeing, man?
Okay, now I think I'm seeing the brain tissue, the brain area.
Okay.
I got to narrow it down.
Zoom out, zoom out. Zoom out.
You have to zoom out.
Right.
Yeah, that's pretty good. That's pretty good.
Temporal muscle.
That wasn't a bad shot. You saw it, Ike, right? Can you see it on your, do you have a camera there? Like a smartphone, you can see what you're showing us?
Right. Yeah, that's so.
You know, Ike?
Yeah.
You know, you can see what we're seeing if you have somebody has a smartphone there. You can check on the view to make sure the view's okay. You can
That's
like
what I'm doing.
Yeah,
no, the view is not okay. It's coming like this.
Okay, that's what Ike needs to do. That you see that, Ike, right?
So you need to make his screen the main one. I mean,
right.
You should not be seeing us. You should not be seeing the rest of the people on the platform.
Yeah, I know what you mean. Yeah.
So what? Can you hear me, John?
Yes, we can hear you.
Yeah. So what Nilesh is doing is he is exposing the frontal rim, the orbital rim, and the zygoma. So that is the first step to doing an FOZ craniotomy. So we are doing a one-piece FOZ craniotomy to start with. We will do it our way. So we were exposing the orbital rim, and after we expose the orbital rim, we're going to combine the OZ with the frontotemporal craniotomy in a one piece mini OZ, and then also cut the horizontal process of the the zygoma and cut it so that it is still attached to the temporalis muscle, and through the groove we are going to take the temporalis muscle down so that we get access all the way to the base. That's what we're going to do. That's the first step. Once we do that, we will get on to the craniotomy, orbitomeningeal band and stuff. So this is a detailed way of doing it, so that any doubts or anything we'll be talking about it. And in between, we'll show you some videos where we do the same thing in cases like paraclinoid aneurysms or transcavernous techniques. All that we will keep on showing you. Abida, you want to take? Abida is here.
Hi, John. Hi, Hira.
John?
John has slept.
John is still seeing that some other hairy.
Oh, Abby, you made the trip okay.
Yeah, I made the trip okay.
Oh, okay.
How are you?
I am fine, Hira.
You drove 6 hours to get to this section.
Yes. So when are you coming?
Soon. I hope we get straightened out with Krishna to televise well from there. I hope we can do it.
Yeah.
People coming to watch? Distillery. If we get that fellow. Okay, go ahead. Go ahead all the way to zygoma. Yeah, and detach that muscle all the way from zygoma. No. Here. From this. Yeah, from here. Keep on detaching it from the zygoma. That's right. You want to do commentary? No, Abida.
Are we live?
Yes.
Okay. Yeah, so Nilesh is now dissecting the temporalis muscle of the zygoma. He has reflected it from posteriorly and going all the way up to the zygoma, and he's dissecting it off the zygoma now. To get a complete expert.
This is excellent. This is excellent, Abby. This is exactly what we need.
Yeah.
Your commenting.
Great, John. So on the undersurface of the temporalis, you can see some vessels and nerves that come with the, subperiosteum, just above the periosteum. So if you're subperiosteal, you're going to preserve all these layers, so you can preserve the nerve and vascular supply of the muscle.
See, you don't see any smell or anything.
Yeah.
That's a good thing about you can help.
So now you can see the anterior part of the zygoma, the frontal process of the zygomatic bone. And now he's nearing the root of the zygoma, the posterior aspect. Zygoma, bear it from posteriorly. Yeah, remove from there. Fascia se cut mar. Upar, zygoma pe. Nahi, the way you're doing it, no, from back only. Yeah. Now reflect it again. Okay. No, his hand is in the way. No, it's okay. Yeah, now it's better. So that's the root of the zygoma now. His hand is just covering it. You'll see it in a minute. Yeah. So now he's separating the temporalis from the inner aspect of the zygoma, as you can see. The temporalis muscle going into the infratemporal fossa. Yeah, it's being seen. Huh? No, it's being seen. Just a minute. Yeah, okay. Yeah, okay. Yeah, so now the whole zygomatic process can be seen. You can see the Nilesh point out frontal process of the zygomatic bone, and then the zygomatic bone, and posteriorly you have the root of the zygoma. Okay? Yeah. Yeah, enough. Orbital rim is exposed? Yeah, okay. दिख रहा है change if you want हाँ Okay, I think Nilesh is almost ready. Drill, we can get the drills ready. Oops. हाँ उधर कैसे रहेगा zygomatic करना है ना रुक जा You're recording this? You're recording. नहीं नहीं microscope view से? Okay.
ते स्कोपच ऍडजस्ट करा बरं का त्याच्यावर. कारण सरांचा हात आणि डोकं मध्ये येणार आहे.
Ah.
ओपन करून
What you can show is you can show the operative view, the microscopic view. Is that being relayed? वो दिखा रहे हैं ना अभी?
हा मायक्रोस्कोप ओपन केले की मग त्यांनी स्कोप मध्ये बघू.
Cut कर.
प्राण गेला कट कर. हेडफोन लाव.
Cut कर.
यस.
So that is the posterior margin.
Can they hear you?
Hello.
Can you put this here?
Yeah. Boss, can you put it on my neck? I don't like it on my ear. No. Neck. Right. Thank you. Yeah. So, can you hear me, John? John, can you hear me?
Yeah, we can hear you.
Yes, we can.
Okay. So, what I'm doing is I'm doing some. I'm mobilizing the area that I need to expose. I'm mobilizing it so that for the fronto-orbito-zygomatic approach, I'm making sure that I dissect everything away so that my approach is easily done. Do you have a bigger, that periosteum type of dissector? No? That's okay. Okay. Give me something that, yeah, this is a knife. Yeah, thank you. I need it like that to go. Everything is okay, Nilesh? I need a periosteum actually. Do you have any dissector which can do that? Something which is sharp and I can take. Ah, that's right. Brilliant. Yeah, brilliant. Okay, so the step is to take this thing inside without disrupting it. So you have this periorbita, you must preserve it. Otherwise you have this very difficult fat coming into your way. Once you dissect this, then you can go ahead and by the way, the nerve and the artery that comes here, supraorbital trochlea.
Or both will come.
Yeah, so that you really don't need to, because you're Craniotomy can be lateral to that. So you really don't need to go ahead and take it. So this dissection is very important for your one-piece OC. You can see that and dissect that, keep on dissecting it. Put a small gauze piece. Yeah, that's right. And then you dissect on that. No, dissect. Yeah, patty also is fine. Yeah, not this cutter, the craniotome. Yeah, that's right. That's right. So you have the.
Okay.
How do you like it?
Slide, looks light, no?
Huh? See? Yes. Yeah, thank you. And see the foot pedal and all that? Thank you, Yash. Thank you. Thank you. Now, this is one of the best drills I have really used. I mean, so we're going to make a V cut on the zygoma and retract that along with the. Yeah. Okay. Yeah. Let's show it. Shashwat, can you be in charge of looking at that? Right.
No, not yet, not yet.
Yeah,
Nilesh, your
sure.
hand is in it. Yeah, that's right.
So I am cutting off the posterior margin of the zygoma very gently in a V cut using the B1 without the guard. Yeah, suction there. Oh, that suction is not working. Yes, good. Irrigation. So, yeah. You have to break through the zygoma. And be careful not to get into the joint, the mandibular joint. So here also you make a cut. So you need to see if it's mobile. If it's not mobile, then inferior part.
Zoom out.
Right. So this piece is mobile now. This piece is mobile, and I can take the entire zygoma, entire temporalis muscle, once I dissect it, I can take it along with this piece so that I get absolutely good base. Okay, so everybody is understanding this part? So once this piece is mobile, I can dissect and keep this muscle all the way down, and I can get excellent exposure of the base. This is a simple trick. Yash, you can, brilliant drill, brilliant. Okay, so we are going to dissect the muscle a little bit more so that we can. So in the anterior part of the temporalis muscle, you have a fat pad, and then this is very useful for you to help with your reconstruction and stuff. So now you can take the entire muscle through that groove, pull it down gently, and then you can take a stitch there. Yeah. Maybe 2 is required. Not much force, just enough force. Yeah, go ahead, tie it and then take it down. So what is happening is this extension is going off. So put this, yeah. Put this. That's the beauty of being on wooden blocks. You can change it the way you want it. I wish surgery was also this easy. Huh? Yes. Yeah. Oh, good. What would I do without you? Huh? Right. So one stitch here also. Right. The gauze piece. Right. Another stitch here on this side. So you can see the entire orbit, the frontal region, the temporal region, and the zygoma exposed. Zygoma is taken down.
Zoom
Shashwat?
out.
Yeah.
Little bit zoom out. So then you can zoom in. Yeah, now focus.
So you can see
Yeah.
that is the orbit. That is the orbital process of zygomatic bone.
Yeah.
Okay. And then you have the pterional region. So you have the temporal region, frontal region. Zoom out. Zoom out.
Yeah, okay, that's better. That's better.
Yeah.
Yeah.
So little bit more distance back.
Yeah.
Ah, this is much better. Yeah. So you can see now you're taking off this patty now, putting the first hole here. Again, that Manman, beautiful, that perforator.
So that's your key.
That's a key bar hole. Come, Nilesh and, Shashwat, you want to change and come in? Right. So, go ahead. Nilesh, put in a bar hole here. Put in a bar hole here. Two bar holes. One is the keyhole, and then is the other is just at the posterior limb of the zygoma. We make one. Okay. So in an OZ, you have two bar holes. One is this bar hole. One is the second bar hole, and from the second bar hole, you come all the way like that into the orbit. Okay. This is the first cut. So two bar holes. First cut is like that. Now the second cut is with a B1, you go straight down, okay, and then connect to the keyhole, right? That is your second cut. And your third cut is going to be a drilled cut, not with your B1, but with your drill. You cut all the way from here to here, right? And your last cut is on the orbital roof. You can use a biting or a chisel, okay, on the orbital roof, so that the orbital roof breaks. So you must understand the things which hold this flap, the OZ, would be this and the orbital roof, and of course this bone. So we are going to take out everything. So two bar holes, 1, 2, first cut, second cut, third cut, fourth cut is orbit. Okay, we take it out. We do a very small OZ, but I want posterior part of the OZ because we are going to combine Dollings, Kawase with Dollings. So we will need to have a little bit more posterior. Okay, so that's what we're going to do. Nilesh, you think you can do it? Right, go ahead. Can you, yeah, I will keep on with there's nothing attached to the mic, right? I mean, it's not like I'm a cow who is tied to something, right? Yeah, I will. Yeah, you have she has the mic. She has the mic. So, I must say something about this drill system also developed by Manman. This perforator and this drill system is one of the best I have seen. And I have not allowed them to go ahead with the with anything else for the last 4 years, but it's one of the best systems that I have seen. This perforator is battery operated. You know, yeah, go ahead. Yeah, yes, good, excellent, right. Yeah, the burr hole is complete now, beautiful. So you can see the difference between the frontal dura orbit and the temporal dura. So it's a brilliant keyhole. Yeah, we can zoom in and show it.
From top, superior.
You can see the band of the orbit and the frontal lobe. So this part needs to be drilled out. So that can be okay. That is okay. You can see the orbital roof and dissector to me. So you can see this is the orbital roof. I can distract the orbital roof nicely. Then I need to drill out this part later on. That we'll do later on. Another one here, another burr hole here. The same thing. Yeah, careful. Yeah, go ahead and bring it here. Right. Yes. So this feature of reverse rotating, we've got it because then it can easily take the drill out of any sticky places. So now we are going to make a cut all the way like that. So before that, I need you to make with a knife the path. Or you can even take out this pericranial flap, dissect the pericranial flap and bring it all the way. So take this pericranial flap, zoom out, and then, yeah. No, not this. Cut, yeah, yeah. No, cut here, cut on this line, on this line. Yes. Yes, excellent. Yeah, and then turn it here. Turn it like that. No, turn this is what you're going to take out. And then turn it here. Yeah. And you're going to develop this pericranial flap. No, I think you have taken away the pericranial flap. So no problem. So what you do is from here you make your cutter, take your cutter all the way like that, and then come here. Cutter now. Right. Yes. Gently. No, yeah. So it can be small. So like that. Okay. You don't have to go big. Come like that and like this. Careful. Yeah. It's very powerful. It's very highly torquey. You got something on the cutter, so that will not cut. So you probably need to disengage that. Yash, could you help us disengage that? Yeah. During this time, you can peel it off and... Right. Good. Excellent. Yeah, that's enough. So you can come all the way like that and to here. What happened? So we can make a small craniotomy, and with this small craniotomy, we'll be all the way, we'll go up to the basilar, everything, okay? Small craniotomy, this much. We'll do the entire transcavernous and yes, go ahead. Yes, go. Yeah, use your cutter. Don't, yes, yeah, come. Turn now. Turn now. Turn like this, come here. Come under the superior temporal line. Here. You need to come here. Gently. There's no hurry at all. Here. Finish. Yeah. Irrigation. Yeah, come. 1 second. Here. 1 second. Stop here. Stop there. Yeah, right. Give me that dissector. Yeah, spatula. So what you need to do is, yeah, you can take the phone and just answer it. Yeah. Hello. അച്ഛാ ഞങ്ങൾ ഡിസെക്ഷൻ തുടങ്ങി കേട്ടോ അച്ഛാ. അപ്പം അച്ഛാ അതിന് വേണ്ടിയിട്ടാണ് കേട്ടോ. ഞാൻ വിളിക്കാം കേട്ടോ. ഞാൻ അച്ഛാ വിളിക്കാം. ഞങ്ങൾ ശരി. ഓക്കെ. You can come all the way till you can come. Till how much ever you can. But you have to turn here, okay? Thank you. Gently. Okay, it's stop it. Right now. Huh? Yeah, so no, don't worry. So, come back from here towards this region, okay? Give me the suction. Once you visualize it nicely, so you come back from the orbital roof. You can use it with another cutter also. So, yeah, come back from the orbital roof. Hook it towards the orbital roof. Yeah, that's right. Yes. Always use a spatula to, yeah. Come back. Yeah, come back. Yeah. Gently. Now go beneath. 1 second. Yeah. So, yeah. Just move the microscope out of the way. We will do it and then we will. Yeah, that's right. Otherwise, you. Yeah. Yes. Okay. Just give me that. Give me that foot pedal. So we are. Right. So we come back again. Yeah, come all the way back. Connect that. Aram se. No need for hurry. Yeah. No need for hurry. Aram se. Give me the spatula now. Right. So give me the suction. Yes.
We're kind of losing the picture there.
Huh?
Kind of losing the picture there. Okay, that's better. Okay.
Right. Yeah. Go ahead now. Yeah. Go ahead. You can't do that. Don't worry. Okay. Don't worry. Don't worry, it's very thick. So what you need to do is you need to take the guard out of the B1, and then let me try for a minute. This is extremely tough. Yes. Yeah, thank you. The orbital roof is like ivory. Okay, suction. Now we take out this B1. Yeah, and I need suction and I need very good visualization there. Yes, so what you do is suction and excellent visualization there. So you do it with the microscope. Yeah, hold this for a minute. Let me be comfortable. The microscope has to, yes. Yeah. Yeah, I need magnification, man. Yes, yes, thank you. I can see that now. So the suction is really, really weak, man. So I'm breaking off those bone bits. There is no way the suction can get in there. Yeah, yeah. Do you have a smaller section? Yeah, that's brilliant. So that is broken. You have just one piece here. It's not working now. Irrigation now? Irrigation. Good, excellent. This is how you should visualize, okay? Uh-huh. It's broken, I think. Okay. So always when you have a trouble, then always get under the microscope rather than trying to do it by force. Force is what will get you into trouble. Force is what will get you into trouble, okay? In neurosurgery, the only thing which can get you into trouble is impatience and force. So whichever sticky situation you are in, use the microscope, use higher magnification, and just cut it off. So what you're going to do now, Nilesh, can you do this? Cut it all the way up to here, gently, without using much force. If you use much force, it will kick. Protect the orbit. Okay. All the way up to here. B1, do we have the B1? Do we have the B1 guard?
Yes.
The B1 guard will protect it. Now let's take it out. Take this, the gauze piece. Yeah. So the B1 guard will protect it. And then we're going to do the last piece of drilling. Okay, so we just all right, that is done. That cut is done. And the last cut is, you give us a 8 millimeter bar. So this is done. This is done. The orbital roof has to be cut now. And then we raise this flap, okay? 8 millimeter burr, and then you burr it. You gently drill it off. I'll show you the line through which you have to drill it off, and then we are done. So that is your FOZ. And that is the first step that you will do in a skull base craniotomy. And if you miss that craniotomy, if you miss that this portion, then believe me, the rest of your 12 or 14 hours is going to be miserable. So this first 1 hour
Need to be centered.
I'll look at it and then do it. So zoom out completely so that you can see the entire thing. Huh? नहीं, मैं खड़ा हो जाएंगे. I'm not that tired. So 0.6 में कर देना. पूरा, I have to see the entire skull. Point 0.6 में कर देना. Focus now. 1 second. One second. All right.
Focus is here?
Yes, focusing. So you can see the clear that, and then we are going to use, again under the microscope, very, very carefully. People think that skull-based craniotomy, I can go like I am in a highway. No. The moment you position the case, then starts your diligence, which means you have to be slow and diligent. Whatever starts ugly usually carries on ugly and finishes ugly. And converse is also true. Whatever starts off good, carries on good, and finishes also good. Well, of course, you cannot avoid disasters and things which happen. But generally, be in a view to, be as good as possible, meaning no hurry, no force. Right, dissector now and check the whole thing. Check if dura is exposed. Check is, give me that drill once more. Yeah, there is a little bit of bone to be taken here. Yeah, suction there. Right. So we see on the keyhole where everything is exposed. So, okay, on the keyhole we have to, Suction. Suction. Excellent. Suction. Suction. We're going to see if this thing is mobile. So do you have anything for moving it? Oh, no, that will break. Yeah, periosteum. Well, the stout is, it will remain stout, but it will not be a scissor anymore, I guess. It's moving. That's because the orbital roof will be attached to it. Now you need to, yeah, the stout scissor is working, I guess. Yeah. So come. Gently keep on dissecting it out and then, okay. Here, but be very clear. No blade. Okay. So here also fracture it and then keep on dissecting it out. Shashwat is here. Go ahead, Shashwat. You both of you guys go ahead. Yeah, give me the stout scissor. Yeah, so Shashwat, go ahead. Come, slowly raise. The dura is intact? It's intact, it's beautiful. It's attached, but it's intact. The orbital roof is really tough. Generally, the orbital roof is not that tough. Yeah, go ahead. Gently release it off. Yeah. Yeah. Dura has to be intact and then slowly take it up. Is the brain very tight?
It is stuck there.
Yeah. So fracture it here, that is the best way to do it. So you do it, what you can do is, what has happened is between these two, there is no connection. So that is a whole problem. So take that stout scissor. So one of the best ways is to put it here and fracture it like that, okay? You put it here and fracture it gently here. Come, take one blade and fracture it there like that. There's no need, you can fracture it, see? That's fracture, fracture it like that, okay? Gently fracture it, the orbital roof, fracture it, that is all. Once you've done the bone work, yes. The orbital roof will come as one piece gently.
We can fracture out.
Yes. Yeah, that's fracture and goes off, yeah. Ideally, you should put a drill and fracture that. So first stage over, big claps. Now orbitozygomatic approach out, orbitozygomatic piece of bone out in a single piece. John, can you see this?
Focus out. Yeah, okay. It's visible.
Yes, we can see it.
So that is the orbitozygomatic piece out. Okay, that is the orbitozygomatic piece out, single piece. Okay, and you can see the exposure that it gives you. That is the exposure that it gives you. See, right. So you have. Let me just go to 0.6. Huh? Right. So give me the dissector. So you have the orbit there, the frontal lobe there, temporal lobe is here. Okay. So temporal lobe, I'm going to dissect the orbitomeningeal band and stuff. And this was what we took out. So single OZ, single piece OZ. Everybody seen this? Any doubts or anything? They can ask. Any doubts or anything? Abida can answer them.
Yeah, John?
Go ahead, Amitha.
Any questions are there from the...
Oh, okay. Let me ask the panel. Okay. Any of the 30 panelists, would you like to ask a question or comment on the proceedings?
Go ahead and dissect this part now nicely and take out. So take out all this part. Okay. So that's what the temporal base for axial unlocking. For axial, can you show also this? For axial unlocking,
Yeah, focus on this.
on my hand, can you show this? Show me first. No, on me. So I'm going to talk about. I'm going to talk.
Anybody have a comment? Just jump in, okay?
Yeah. So what we are doing a combination of sagittal unlocking and axial unlocking. I'm that darker. Oh, okay. Right. Yeah. So what we are doing is you have the frontal lobe here, the temporal lobe here. Right. So you need to open this up. That is how you go into the skull base. Now, to open this up, you can do two things. Number one is take off the entire orbital roof and the sphenoid ridge, everything on your way. That is called the sagittal unlocking. Next is axial unlocking. So the temporal lobe can swing out. The temporal lobe has to swing out. For the temporal lobe to swing out, if you put the lateral boundaries of the temporal lobe intact and you ask somebody to swing out, it's not possible, right? So you need to take out the complete lateral boundary of the temporal lobes, which means you have to take out this entire thing all the way up to the base. First, dissect the temporal dura off nicely, okay? And then you go ahead and make sure the temporal lobe is in a position to swing out. So this is what Nilesh and Shashwat is going to do. Dissect this entire thing. Don't go into the orbitomeningeal band. So dissect this entire thing out, and then we go ahead and take out this entire piece of bone out. All right, go ahead, Shashwat and Nilesh.
John, do we have any questions?
Okay, any questions or comments from the panelists?
One of the panelists is asking us to show the cuts of the orbit, please.
The what?
Cuts of the orbit.
Okay. Yeah.
See, while they're doing this, you can...
Yeah,
so... you can focus on this.
Focus, yeah. Just here. Yeah. Just Shashwat, go ahead and show that. Hi.
So place it in the position how it is in the cadaver. Yeah. So that's your keyboard hole, and that's your orbital roof over here.
Yeah.
And so orbital rim, sorry, and the roof is here.
The posterior one,
Yeah.
lateral one.
Yeah.
temporal.
So when you make the cut, you have taken the whole orbital roof along with this bone
Yes.
piece. Can you see that?
Yeah, we can see this.
Now you can focus on that again.
Right. So you can take off this bone gently after. Yes, keep on taking it towards the temporal pole.
Near the sphenoid ridge, he's removing some bone now.
Yes.
Quite a thick bone.
Yeah.
That'll be there.
Don't go there because you might get into. Yeah. Okay, go ahead. Remove that bone. We have some very honored guests coming up. So Dr. Lawton will log in and he will talk about how to get into the base of the brain in a tight brain. So this is what he does in aneurysms. It's the same thing that we'll be able to do in trauma. So Hira, will you send Professor Lawton a link?
Yeah, sure.
Yeah, so whenever he has time, he will log in and he will tell us. Yuha might also log in. Yuha is traveling in Shenzhen, but as soon as he has some time, he will log in. Today is 6 p.m. Luis Borba will also log in and tell us about the skull base we can apply in trauma. So now don't believe all these trauma surgeons saying that, oh, in tight brain, it's impossible to get into the base of the brain, okay? Don't believe them, all right? They are not doing anything. So that's the whole problem, all right? They're just writing papers. So obviously it will be impossible for them to get into the tight brain's base. So when you're writing papers, you are pretty good at that. But if you are operating skull base in and out, getting into the base of a tight brain is, that is how you make a living. So you listen to these experts who can actually tell you how to get into the base of the brain in a tight brain, all right? So that is what we're going to do. We're going to show you how to do that. And also, we're going to have these experts to tell you, if there is a tight brain, what do you do? Now, all these things are not required in cystonostomy, all right? Don't even think that all these things are required. You just need a little bit of sphenoid ridge removal, as Dr. Nilesh here will tell you. And many young neurosurgeons who have been doing cystonostomy will also tell you that it is an easily doable procedure where you don't need any of this thing. We are doing the Dollings here. So, but if you know Dollings, if you know Dollings, then it's easier for your skull base exposure, much easier for your skull base exposure. Here we are going to the lateral rim of the superior orbital fissure. We are removing the superior orbital fissure so that we communicate. This is so that I can show you the orbitomeningeal band and things like that. Right. Right, let's get into transcavernous dissection now. I need to sit down now. Is there anything that I can sit down? Yeah. Give me the drill now. Cutting diamond burr. Or maybe biting perhaps. Just suction to me. Small biting. Could you remove off this? Yeah. the same thing. Dissector now. Dissector. So this remaining parts of your sphenoid, 1 second, I'll dissect it off for you. Shashwat, do you think you can remove it off?
Yeah.
Nilesh and you. So I'm going to dissect this thing off. Don't go deep, just bite it off, okay? Just bite it off, just. That's right. Go ahead. Yeah, that's right. Good. Right. Yeah, bite. Yes, bite it off. Yes. Yes.
Can I ask a question?
Yeah.
Yes.
Yes, please.
Yeah, okay. Dr. Shirag asks, is there a need to remove the zygoma regularly or single piece or separate?
There is no need to remove it. See, zygoma single piece or two piece is like your bikini one piece or two piece. It's your preference, okay? You want it one piece, you take it one piece. If you want it two piece, you take it two piece. If you want many pieces, you can take it many pieces also. All right. So it is just a preference. It is nothing to do with the efficacy. At the end of the day, you take it one piece and then you cause hurt to the patient. Don't take it one piece. You like it to take it as 5 pieces, you take it as 5 pieces. No problem. Okay. So my preference is one piece because I like it that way. So that is all. Otherwise, we'll get into a whole sort of argument as to one piece is better, two piece is better. You know, it will look like a bikini discussion. Right, let's take this out. I hope that clears it, John.
Okay.
Yeah, yeah, yeah. That's a lateral border. Right. So now we are seeing the orbitomeningeal band very clearly. Okay, very clearly. Right. So take this off. Okay, dissect. No. Dissect this part away from the orbit and then take this off. Yeah. Keep the right. Now dissect it. Now take it off. That's enough. Right. Take it off. Gentle bite, small bite, without getting the orbitomeningeal band into the picture. Yeah, that's right. That's right. Beautiful. Right. Okay. So we have seen the orbitomeningeal band there. Are you seeing it? That's the orbitomeningeal band. Okay. Now give me a knife. Now give me a knife. So cutting the orbitomeningeal band there. When you cut the orbitomeningeal band, you come to the lateral margin of the superior orbital. There is an artery there. Okay. There's an artery there. You can see the artery. Can you see the artery? Yes? That will bleed. Okay. Right? Dissector now. You're going to go down to V2 now. You're going to go enjoy some skull base views. Can we have high zoom, please? And focus. That's right. Excellent.
That's excellent.
So the brain is really tight here. So I'm going to, they have a larger dissector. focus there. Where is that? Yeah, that's better. No. Better. Focus for me. That's right. That's better. Although this optics is good, but the maneuverability is a little bit of a struggle.
I don't know if this is relevant, but Deepak Bengali says no cranial nerves on the lateralmost border of the superior orbital fissure.
Yeah, that's a comment rather than a question. What he said is
Okay.
right.
Okay.
Okay, there are no cranial nerves on the lateralmost margin of the superior orbital fissure. There are no cranial nerves. So now the brain is very tight. It's almost like doing a cystonostomy. Okay. We need to get into the plane. Now take this off now and let's get sutures now. Let's get multiple sutures in. Yes, right. To the base. The brain is formalin fixed and therefore it's a really tight job. That's okay. Slowly get our sutures in and then we will be able to. One second. Yeah. 1 second. Yeah. Yes. Right. That's one suture. Let's get it on the temporal side. See, I like sutures, huh? I don't like retractors. Retractors take your space.
You know, wife, I'm not a neurosurgeon, but Dr. Spexler mentioned that he doesn't use retractors at all.
Yeah. Well, I'm not religious about it. If there is a retractor which needs to be used, I'll go about that. But of course, I mean, there are people who don't like retractors at all.
Okay.
Again, it's a matter of perspective. I don't believe you should be religious or maniac about one special thing, whatever happens. That will unnecessarily create small troubles in your life. So there's no need for that. So you need to put in a, yes. My philosophy is to be flexible like water. As much. Okay, right. Yeah, let's get a stitch in. So with stitches, I'm slowly and gradually taking this tight brain. It's stone hard. It's stony hard. It's a really difficult job here. Try our level best. Slowly and We'll see how.
So we have another question here from Deepak Bhangare. He's asking,
Yes.
do you use curved scissors or knife for cutting the meningeorbital band?
Yeah, I use curved scissors actually. I used to, sometimes I use a diamond knife, but yeah, I mean, if that is not available, I use a curved scissors. Any micro scissors would be fine. Sometimes I use the blade also, depending on what is available. But my preference, of course, is the diamond knife, followed by the scissor, followed by the blade in that order. This will save you the morning workout, because otherwise you'll be retracting that stone hard brain and sitting down there. Yes. Yes. Yeah, cut that. Right. So let's have a look now. Right. Give me a dissector now. And you guys can see this bit of bone which is creating some trouble for us. So maybe that bit of bone, you can go ahead and remove it. Can you give me a 2 millimeter drill or something? Or by the time that happens, maybe you can bite this off. Keep on biting this off. Go in, and yeah. No. It's okay. It's okay. Bite now. All right. Take small bites. Right. 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 So you're going to dissect further. So that is the superiormost margin, the lateralmost margin of the cavernous sinus. You're going to see the V2 there. That is the V2.
Now he's close to this dissecting in the region of the superior orbital fissure.
Yes. That is the superior orbital fissure. That bone, that's the lateral margin. Give me the knife, the 15 blade now. I'm going to release this orbitomeningeal band completely for once. That'll allow me to see how it's beautifully releasing away and showing me the cavernous sinus. And then it will show me the anterior clinoid. Do you have a larger dissector? Okay, this is fine. So you're going to go, that's cavernous sinus for you. And that membrane that you see on top of the cavernous sinus is the true cavernous membrane. And this bone that you're going to expose right now, after the orbitomeningeal is cut, that is your clinoid process. Okay, so your clinoid process is going to be right here. That it was when it was attached, it was very difficult to visualize the clinoid process because you could not open this thing up. Now, the beauty of it is that you can open this thing up. So now let's get a stitch now here. You see now? Stitch now, yeah. Give me a large retractor there. Oh my God, this brain is really tight, okay? This brain is as tight as they come. It's not that we are... give me the drill, ready with a 4mm bar. Are you ready with a 4mm bar? Let me just, give me a dissector now. By the time they are getting it ready, so I want to dissect all the way up because we have to do the Kawase also today. Dissecting all the way to the V3. Yes, good. Yeah, give me that drill. A little bit of temporal lobe, I have to take it out. I mean, not the temporal lobe, the temporal bone. Yeah, that's the... this is not attached. Done? Yeah. Avida, are you seeing this drill? It's as good as you will find irrigation. See the torque of it?
Looks real light and
Yeah, it's very light and far better than all those Western drills. I mean, we have developed it. I'm very proud that we have developed it here, in India, and at the fraction of a price. That's what I like about it. And it comes with the craniotome, the cutter, the tumor dissector, everything. Yeah, change the section. Thank you. So we are getting into the base of this. This bit of temporal base is removed so that you can have a good vision right into the... So now a lot of people in ENT ask me, how do you get into infratemporal fossa? I mean, can you get into infratemporal dissector now? Can you get into infratemporal fossa from... You talk about all these approaches, endoscopic approaches, and they say, how can you get into infratemporal fossa? It's the easiest thing for us, you see. You drill this and you are into infratemporal fossa, okay? So anybody, ENT surgeons who are watching, please remember, open craniotomy is also a fantastic way of getting into the infratemporal fossa.
when trigeminal schwannomas, they extend inferiorly.
Exactly the point.
So maxillary mandibular division. So that portion. So actually, Professor Goyal had described a reverse skull base approach, meaning that you retract a little bit of the brain, and in the dilated portion you can enter the infratemporal fossa along the nerves, right?
Yes. I mean, Dr. Goyal has pioneered a lot of things in the skull base, and this is one of the approaches that I have. Last time when he was telling me, I mean, I was amazed and I was thinking the scope of things, the kind of things Dr. Goyal has done.
So this is exactly, you're taking the temporal bone up, and through that you can see the V2 from here, and from there the trigeminal schwannoma itself has made a route for you to enter.
Absolutely. I remember Professor Goyal one time telling that he likes it more than his wife, but I mean, I cannot tell that on air right now because he's going to kill me. Madam is going to kill me. Huh? Madam will, but I'm sure it is. He
She's
said
right
that.
there.
Careful, careful.
Yeah. I know. But we neurosurgeons say that all the time, that we really don't mean it, okay?
No comment.
John? Right. Another stitch here, perhaps, so that I can pull this back a little bit, because this brain is as tight as anything, you know. I mean, this is formalin fixed, and sometimes you think there is no way. But we will try our level best. We have seen the cavernous sinus, so I'm happy at least we saw it. Now let's see what we can do. Yes. Right. Dissector now. So we are going ahead and slowly dissecting. Suction there. Yeah, smaller suction. I hope all of you can see that after we release the orbitomeningeal band, you have seen that how easy it is for us to mobilize this cavernous temporal dura of the cavernous sinus. You see? So that's exactly what we are doing right now. So whoever was asking about the cranial nerves is all here. Now I can't, if I find a tight brain like this in a tumor, like Luis Borba will tell you, he'll go ahead and release some CSF. But unfortunately in this case, can't do that. I think this is one case where decompressive would work. The insistence. Yeah. It's a taboo, but I used it because probably if a patient is dead or you intend to do that, then maybe I should tell Randall. That's the only time you think about decompressive hemicraniectomy. I'm sure you won't like it. I don't care. Right. So, if Randall is listening, by the way, next month we have a beautiful meeting done by Corrado Lacarino. The guy might be listening if he's got up already. He's in Italy, so I don't know what time is it for him. And he's not an early riser as far as I know. So, no way. No, stitch to me. So if Corrado has got up, John, you're going to probably televise that as well because it's ICRAN, the World Neurotrauma Meeting.
Yeah, we've done it before.
Right. So,
well, you know, Corrado was here, but he mistakenly thought he was presenting at 9 a.m. So he had got up at 5:30. But he
God.
He went back to bed.
He went back to bed?
Yeah.
Just here, tight here. Okay, tighten it and gently tight. So can you see the 3, 4, 6 nerves here going into the superior orbital fissure? Then you can see the V2 going in there into the foramen rotunda. The membrane?
On the
Oh,
zygoma.
sorry.
Okay.
So you can see the foramen rotundum, and after I dissect a little bit more, you can see the foramen ovale there, and then we will show you that is a foramen ovale there. So that is a cavernous sinus 346, V2, and you will see the ovale also. This is how you dissect. Now we will go and go ahead and take out the remaining dural attachments, which will give you a good access into the clinoid process removal. So I'll show you that also. Okay, so this is no. You have to tighten it. You have to really tighten it. Okay, otherwise, yeah, that's right. You pull it and tighten it. So you can see the clinoid process, and then you can see a little bit of dural attachments there. Let me focus it for you. Another stitch here, another stitch here. Give me a stitch. No problem. Get us more and more stitches, as many stitches as you can. Okay, this stitch is what will do the job here. You can't put a stitch into the cavernous sinus. Oh God. Can you take this, because it's at depth, can you just hold it with another instrument and make sure we don't go into the cavernous sinus at all. Yeah, gently pull it gently out. I'll drive it for you. Okay, let me just hold it there. Yeah, that's right. Just leave it now. Right. These needles are huge for a depth job. Okay. Right. Right. So, fantastic. So now what you can do is hold the suction. My God, what a needle this is. Oh, definitely not meant for microsurgery. Imagine asking somebody to anastomose with this. No? I'm sure if you tell the trauma surgeons, they won't have any problem. You might be thinking why I don't like trauma surgeons. Huh? I don't really like them, okay? That's because for a century they've managed to keep the young neurosurgeons out of surgical room with all the papers and other nonsense what neurosurgeons should not be doing. And then what happens is, they keep guardianship of these so-called hallowed journals, where they think that if you get a publication in these journals, your life is done. The biggest lie on earth, okay? If you do good surgery, then your life is done. But if you get a publication and you don't know how to do surgery, your life is done for, okay? So, between a New England Journal publication, I'm naming the journal just as a representative journal. For example, imagine that God came to you and told you or told me You'll get the entire issues New England Journal you will get to publish, or you will know how to do an anterior clinoidectomy. Huh. Do you have any more switches? If you tell me New England Journal is going to have only my name for publications, nothing else, nobody's else, and you tell me whether I have a choice between that and learning how to do an anterior clinoidectomy, I'll definitely go for the anterior clinoidectomy. I will not even think twice. Okay? That is what is neurosurgery about. Don't ever mistake that. Huh? So, and some of these guys sit on top and then they don't allow publications. They think that the English language is bad. Of course, I mean, if we speak English badly, that means we are speaking another language which that fellow cannot do. So all this I have seen and I have suffered for many years, I know. And we don't deserve it, We really don't deserve it. So I want to tell this to the young neurosurgeons that how much ever you think publications are important, you don't know how to operate, you don't know how skull-base techniques are, you don't know how to do good microsurgery, it's not going to help you. You may have 1,000 publications. And when a patient comes to you, you cannot operate with your publications, you see. Do you agree with me, Abida?
Yes, I completely.
Yeah.
You have to learn to operate first.
Yes.
Publications will come. As first you learn to operate, and the publications will come.
Tie this, yeah. Yes, absolutely. No. That's why I want people like Lawton, Yuha, everybody to come in. If you see, my friends Franco and Corrado are here. Just tight, yeah, tight. Not very tight, not very tight. Yeah, just enough tight. Where is that? So that's the whole point. So remember, when you try to get your publications and all in, rather than that, go to dissection and learn your neurosurgery. That's what will make you a star, or that's what will help your patient, not your publications. This era is changing. We are in a changing era now, where 50 years of these publications have brought neurosurgery to its knees. 50 years of this stupid culture of publications has brought neurosurgery, especially in the West, to its knees. You see, what Professor Yasagil, Professor Spetzler, and other master surgeons have been able to achieve. I'm not saying they were not publishing, but they learned how to operate first and then they published. Can you imagine Yasagil trying and learning how to publish first and then going to operate? No. Okay? So, never ever be under that illusion that publications are more important than surgery. Never. Give me a micro scissor, please. So the entire cavernous sinus is slowly taking shape there for you. You can see the fourth nerve there. You can see the V1, third nerve is here. That's a fourth nerve. That's a V1. That is a V2. And I'm going to show you the V3 now. Can you put on some stitches and retract? Now you are seeing the Gazerian ganglion. That is a Gazerian ganglion, okay? And that's a V3. V3 is in a perpendicular direction to V2. Always remember, V3 goes perpendicular to V2. So that is your V1, fourth nerve, third nerve, and that's your clinoid beautifully exposed now. That's your orbit. So the cavernous sinus is getting exposed slowly, in spite of this being stony hard, this brain being stony hard. I want you to take stitches here, stitches everywhere there, okay? So that, and here, stitches here also, okay? Okay. Right, remove this bit of bone now. Let's remove this bit of bone. Can you give me a stitch now? Right, yeah. So people say I have declared war against literature. It's true actually. I don't want to deny it. Because I saw that the third world, I have seen my very good friends from Africa trying to publish in a journal which does nobody any good. But if you do good work and then publish, I completely agree about it. I completely agree. If you are doing good work, if you are a good surgeon, there are many good surgeons in Africa. They publish their experience. That will be fantastic because we will learn a lot. On the other hand, greenhorn fellow doesn't understand what is surgery. He's got 70 papers and he thinks he's a stud. He's barking up the completely wrong tree. Okay, so 1 second. You got some stitches? Right. Hira,
Yes. Hello.
you want to schedule somebody's talk or something now? We have a lot of talks, so I am done with the cavernous sinus initial exposure. Now we're going to go towards the clinoidectomy. Okay? So I'm going to show you the structures till now we exposed.
Okay.
Are you seeing very clearly, all of you?
Yeah, we can see this.
The screen is very clear. That is the optic nerve. I'm going to open the dura there. That is how I get CSF out. When I have a tight brain.
Even this tight brain is releasing some CSF.
Yeah, the tight brain is releasing CSF. Can you see that? That is a optic nerve. Can you see? Everybody?
Yes, it's very
This is exactly how, when we have a tight brain, very tight brain, this is how, and this is the clinoid process. The clinoid process is completely exposed there. Okay? And this will be the carotid here. That structure that you see here, focus for me, Nilesh. See, that's the CSF. Can you see?
And the membrane, he's cutting their arachnoid membrane separating the
I've gone
cistern.
intradural
Yeah.
already. Okay, that is cisternostomy.
That's your carotid cistern. Now that is in between the carotid and the optic nerve. No focus. Now focus on the screen. Yeah, not on the screen. You can't see in the screen.
Okay,
Yeah.
focus now. Focus.
You need to move your chair. Move your chair. Chair.
Okay, right. Thank you. She's the director. So, I mean, if she doesn't direct, things doesn't go well. So, that's the optic nerve. That's a carotid. So, that is intradural. And extradurally, you have the fourth nerve there, V1. Third nerve is, I have to expose it a little bit more. I have to cut the sleeve of the third nerve. I will remove the clinoid and then I will show you. Give me a micro scissor. So I'm going to cut parallel to the third nerve. Right. So you can see the third nerve coming in, entering intradurally. You will see that now. Okay. That's the third nerve coming in and going extradurally there. Okay. So let me remove the clinoid first. That's the carotid cistern. Everybody can see all that? That's the third nerve. This is the third nerve. Okay. It was intradural. Now it became extradural. Okay. So you can see the transition very clearly. So now go ahead and bite off this clinoid, boys. Nilesh and Shashwat, be under the microscope. Keep on gently taking out this. So I'll show you how we take it. Now under the microscope, go under the microscope. Focus and yeah. Keep on taking the clinoid process very, very gently. Okay. Go under the microscope and do it. Yeah, keep on taking out that bone very gently. Is Professor Goyal here?
No, he's not here yet. I did send him an invite.
I've not
Okay,
seen him.
please send him on Facebook. Please send invite to Professor Lawton. I mean, I think it must be a crazy time whenever he gets in. Victor Hugo
I just sent an invite to Professor Lawton, Professor Borba, and Yuha, and I'll just get back with Dr. Goel. Just let me message him.
Yes. Thank you.
Abby has a good connection to Dr. Goel.
Yes, John.
I'm not going to let you get away with it, Abby.
There's a bone bit. Yeah, that's right. Go in and take out. So you are doing an anterior clinoidectomy now, okay? So you see after the orbitomeningeal band dissection is done, you see how easy. There is a small bone bit on the lateral aspect just below the, take that out. Right, take that out. Yes. Now dissect the orbit down and then go ahead and take all that bone piece. Right. Right. What is your name? Aditya. You seeing it?
Yes.
You liking it? You must do all this very simple, okay? It's not very difficult. I'm telling you. This is the Dolenz technique. Needle holder is something is very useful. So many years, in my beginning stage in Nepal, that is one instrument I didn't have problem accessing. So I used to remove my tumors. If I have to crush a tumor without really moving it, needle holder is the best thing. If you want to remove ACP, needle holder is good. So that is why I like needle holders, not only for holding the needle. I like it because it has a huge force. Keep removing it, keep removing it, keep removing it. Crush it, don't pull it and remove it. Yeah, keep crushing it, keep on removing. Right. A needle holder has a narrow profile, so it can go into anywhere and it can crush, and once you crush, it's easy to remove. Focus your microscope. Are you focused? Okay, good. Keep on removing it. Crush. Once you see the optic nerve, extradural optic nerve, you know that you have removed all that clinoid process, okay? Laterally, you have to remove it. You see, we are not even drilling clinoid process. I mean, don't do this in a real case. But I just wanted to show you, if you want, it can be done. If you are careful like Nilesh, keep on crushing the lateral. Dissect that area, dissect that. Yeah, take off that bone, take off that bone. Yes. Yes, just let me check now. Okay, where you have reached, Karki. Let me tell you, this brain is more tougher than the trauma brains, okay? Let me tell you that. So I am going to remove the third nerve. This microscope is moving by itself, Rahul? Optofine people, this is moving by itself. I don't want an autonomous microscope. So that is the anterior clinoid process, and this is the mucosa. Sometimes the anterior clinoid process is pneumatized. Okay, so that is what happens. Don't think it is a carotid. So you are going to remove the lateral most portion also. Yeah, I want a needle holder. Crushing is the best, crushing. Don't pull. Pulling is always bad in neurosurgery, whether it's a tumor or anterior clinoid process, anything. Pulling is bad. Remember, young boys, remember, lesson learned from 14 years, okay? I'm telling you, the people who learned it for 30 years also will tell you the same. Suction there. No, this is so weak. Nilesh, couldn't you get a better suction? So we are now removing the last bits of the. Give me a dissector. Yeah, that's good. That's good. That's what we want. So you can already see the intradural carotid. Okay, intradural optic nerve. You can already see. Dissector now. So see, that's a clinoid process. That's a clinoid triangle. That's what I'm removing it out. That bone, it has to come out gently, always gently. Okay, see how it's coming out beautifully. Okay, dissect it off. That's the sharp tooth. See the sharp tooth coming out. Give me a needle holder now. I'll show you the sharp tooth coming out gently now. See, okay, that's a sharp tooth of the anterior clinoid process. Okay, now that's a clinoid triangle where you will see the extradural carotid, C3 carotid, carotid-oculomotor membrane there. Dissector now, and you. Now I'm going to show you the proximal and distal dural rings and the concept of this proximal and distal ring. It's very simple, you know. People complicate it so much. They draw figures of figure of eight and all kinds of pictures like in the ancient Indian text of Kama Sutra. They draw all these pictures so that as a resident you will not understand what the hell is going on, you know. So the whole point is, see, this is optic nerve, this is carotid, that is extradural carotid. So whatever is coming on from top of the optic nerve is encircling the carotid is what is your dural ring, if you want to call it that way. You have to release it. If you don't release it, obviously you cannot mobilize anything, right? So that is the whole purpose. See, clinoid process is getting out. Can you give me a forceps or something? Is everybody seeing this? Is everybody seeing?
John?
John, did you sleep off?
Yeah, no, we can see it.
Okay. So can you see the extradural carotid there? That's the extradural carotid. And that's the intradural carotid. That is the extradural carotid, intradural carotid. Extradural optic nerve, intradural optic nerve. I'm showing you the transition zone. Okay. And between the optic nerve and the carotid, this piece of bone. Okay, anterior to the turn of the carotid. See, the carotid is going to turn there. This is C2 carotid and its paracellular carotid is here. It's turning there, down. And anterior to that, you have a piece of bone between the optic and the carotid. And that bone is called, anybody can tell me that what is that bone called? The strut. The optic strut. So again, there is no need for all this fancy explanation. Very simple. Okay, very, very simple. That is the strut. So that is extradural optics, extradural carotid. So now let us cut that dural band, which is limiting us. Okay. Let us see how we cut it. So we don't want to call it proximal ring, dural, distal ring, and all that names. Okay. Just cut this dura. Be very careful because this band is literally incorporated to the carotid. So you need to use a dissector to separate it from the carotid and cut it. So what I'm doing right now is cutting this band and freeing the carotid. That is all there is. So I've cut this band, dissected this band laterally, and now you have extradural carotid and intradural carotid. That is all. And if I want, I can also cut and free this optic nerve as well. In some transitional aneurysms and all that, you need to do that. So that's all. Otherwise, you talk to this, you read these textbooks, you see all kinds of classifications. Okay, I'm going to cut that piece of dura off parallel to the, hold that piece of dura. So I can see the extradural third nerve and the intradural third nerve also. I'll show you now. Turn your forceps and hold it, yeah. Turn your forceps, turn your forceps. No, yeah. Yes, take it out, yeah. Yes. Focus now for me. So, third nerve. Can you see the third nerve? That's a third nerve. This is the fourth nerve overtaking the third nerve, going above the third nerve as the superior orbital fissure. Extradural carotid, intradural carotid, optic nerve. Fourth nerve, V1. Yes? Okay, I'll show you. Okay, let's review the anatomy again. Give me a dissector. Yeah, yes. So you have this last bit of clinoid stuck there. It's going into the sphenoid sinus, That's it. Yeah, give me a forceps or something. Yes. Man, this microscope is moving by itself. It's very good. Like it's better than Kainavo, It's, where it is moving, it's just moving. I can't tell you where it's moving. Yeah, that's good. So can you stay around so that you can... So that is your extradural carotid. That is your extradural third nerve. That is your intradural carotid, intradural optic nerve, and intradural third nerve. See, that is intradural third nerve. And that is a membrane of Lilliquist that I'm opening. Okay, that is a membrane of Lilliquist I'm opening. Put in a suction there, small suction please. Is everybody able to see everything what I'm showing?
Yeah, yes.
Yes.
Any questions from anybody?
No questions yet. I just heard back from Professor Atul Goel, and he's on his way. He's on the road. He's driving, so he can't join at the moment.
Right. Is that Afra?
Yeah, she's with me.
She might become a crack skull-base surgeon, I can tell you. Listening to all these beautiful skull-base lectures. Huh?
Yeah, she's looking at the image, the videos.
So I'm opening between the third nerve and the fourth nerve now. Cavernous sinus.
I'm sorry, you're muted.
You've been muted, I think. You're mute.
Yeah, I'm trying to unmute. Can you let him know that he's muted? Abby?
Yeah, John, I think we're unmuted now. Can you hear us?
I can hear you, but I can't hear I.
Say something.
Yeah, it's the same mic.
There we go. There we go. Okay.
That is not.
Whoop, we went back to mute again.
Oh. Somebody is playing games.
Okay, there we go. There we go.
Yeah. Can I have the scissors, please? Micro scissors. It's directed upwards. That's not something that I want. Yeah, thank you. One second. I'm just cutting the middle meningeal artery.
So can you make the center?
Yes.
Because it's not visible.
Okay.
Yes. Yes.
Cutting the middle meningeal artery there.
You can see it.
And then dissecting behind V3. You have to always coagulate and cut that part. So dissect it to me now.
So once you cut the middle meningeal, you'll get a
Plain.
posterior exposure of the cavernous.
Yeah, right.
Absolutely. So Gasserian ganglion, V3 will be more beautifully visualized.
We will give me that drill, please, so that we can remove the bone.
So we'll just remove the bone to make it flush with the middle cranial fossa floor.
Yeah. Somebody has to hold that drill for me. Yeah. So Krishna Institute, we have this lab. We are going to make it much better. We just started here, and I hope Abida will come ahead and help us with this. And we want to make a world-class lab here, where we can have all the young neurosurgeons and residents from India coming and doing dissections without, having to go and pay thousands of dollars abroad. So dissect it to me.
We're going to have a special neuroanatomy lab.
Yeah, we're going to have a special neuroanatomy lab here. This is the whole idea. Give me that scissors now. Middle meningeal is cut, and that you can see the lumen of that middle meningeal. And I need to cut along that line to get into this plane. Right. Some more of that. You're going posteriorly on the cavernous sinus, and you can almost see the Gazerian ganglion now.
You can almost see the whole cavernous sinus. See?
The entire cavernous sinus can be visualized there.
You have the V1, V2, V3.
Okay, now I want Nilesh and Shashwat to take a few stitches like that so that I don't have to retract. You can show the middle meningeal artery also. Take stitches there, and then after that, review the anatomy. You don't have stitches? Stitches, huh? Stitch, huh? कॉफी आबिदा के लिए 3-4 लाया है फैंटास्टिक हम ले लेंगे Go ahead, you guys sit and review the anatomy, please. That's a small thing sticking up, and can I just, yeah, that's right. Yeah, that muscle, no, that muscle was coming in the way, right? Yes, keep on pulling it such that the cavernous sinus is coming into view beautifully. Give me a nibbler. Yeah, so that this portion can be taken off. Right.
Okay, so we have a question here.
Yeah.
So Dave Manger, he's asking, how do you deal with the bleeding from the cavernous sinus in surgery when doing the peeling of the outer layer of the cavernous sinus?
Yeah, so what we are doing is a pericavernous dissection. So you must know that we didn't see any structures in the cavernous sinus till now. That is because we have kept the pericavernous membrane, the true cavernous membrane, right? So the true cavernous membrane has been kept. Now I'll open it and I'll show you the structures. And if you keep this true cavernous membrane, you really don't need to worry about your bleeding, okay? This is the modification we made. So you are going, instead of transcavernous, you're going pericavernous, okay? So that's the whole difference here. Now, if the cavernous sinus bleeds, it's a flocil or surgicel, and no panic. That is the main thing. No panic. Understand that the cavernous sinus is not like the carotid artery. Even if the carotid artery bleeds, there's nothing much that you have to worry about really. If you keep your mind in neurosurgery, you keep your patient. Okay? You panic, you are into trouble. So cavernous sinus is you put in a localized piece of surgicel, and then you relax for some time, listen to a song or something, and it stops usually. Okay, so if that is what you are asking, that is the answer. Please don't bipolar. Please don't do anything aggressive so that you also make a hole into the cavernous sinus, cavernous carotid. That will be a little bit more difficult. So cavernous bleeding, nothing to worry about.
Basically, there are layers of the cavernous. So when first layer will be in the where the V2 and V3 is intradural. So you're not going to have too much bleeding in that area. It's only when you breach the medial layer, that's when you enter the cavernous sinus. And whatever little venous bleeding that you have around this area can be very easily controlled with Surgicel. Right, Aib?
Yes, absolutely. So now you are at the anatomy. Have you reviewed? You've seen everything? Right from second nerve. Go ahead from second nerve. Carotid. Sorry. I'm so sorry. Yes, go on the higher zoom now. Okay. Right. Show on the center now. Show the second nerve, the third nerve. Yes. So the second nerve there, carotid there. Show each one of them. I'll show you. Yeah. Just you can have from there, that side. Show the second nerve. That is the second nerve. Carotid. Show me the carotid. That's a carotid. Third nerve. That's a third nerve. Fourth nerve. That's a fourth nerve. Go down. Yes. Fifth nerve. V1 and V2, please. V1 and V2. That is V1. That is V2. Okay. Everything seen. Show me the trigeminal ganglion, the Gazerian ganglion. Go. That is what? Where your dissector is. That is Gazerian ganglion. Okay. You can see the arachnoid there. And that arachnoid, if you open, then you can let CSF out in a case. But we have cystonostomy. We don't need to do that. And let out piddly amounts of CSF. Okay. What we did right now is enough. So it will. No, your retractor is on the fourth now. Be very, very careful. Okay. Please. Your retractor is on the fourth. Yeah, that's right. Gently take a stitch so that we can visualize the. Yeah, no problem. So everybody keep reviewing things. Okay. Everybody keep reviewing things, please. You also wear a gloves, pa. Wear a gloves, and then let's clean up all these areas. Huh? V3 will come. V3 will come. Yeah. V3 will come. V3 is. Yeah, V3 is there. It's just. So let me make a plane between the fourth nerve and move the fourth nerve up to the third nerve and open up the Parkinson's window. Gently shifting the fourth. And then you are going to see the carotid, okay? So gently, because this is cadaver, fourth nerve will be broken easily. So you got to be very careful. Give me a. Now I'm going to show you sixth nerve, okay? Sixth nerve. You saw third, fourth, V1, V2, V3, all that. V3 will come right now. So suction now. Small suction, the smallest suction that you can lay your hands on. I don't need it to suck actually. I don't need it to suck, but then. Okay, right, that's what I wanted, guarded suction. So I am slowly displacing the fourth nerve, opening the cavernous sinus. Some muck there. And medial to the fifth nerve, we will look for the sixth nerve on the C5 carotid. Okay, let me just displace that fourth nerve completely so that we have that nice window. First, I will displace the fourth nerve from the dura. So we have to identify where the fourth nerve is going in. Okay. So the fifth nerve, V1, that is the sixth nerve. Can you see the sixth nerve coming in? That. From the Doralose canal, it's going, see, that is the sixth nerve, okay? And the sixth nerve is going on the carotid. See, you can see the carotid, that is the carotid. This is the sixth nerve. Can you see the sixth nerve clearly now? There's obviously some muck on it. So you can see the sixth nerve coming in from the carotid, coming lateral to the carotid. That is the sixth nerve, okay? So the sixth nerve is always medial to V1. And the infralateral trunk arises from the carotid there in this region, and we will show you the infralateral trunk also. That is the sixth nerve. That which I am separating away from the carotid is the sixth nerve. Can you see the sixth nerve now? Very clearly. We are going towards the Doralose canal, okay? That's the fourth nerve. Fourth nerve I have separated there. This is the V1. That is the sixth nerve, okay? You're going towards the Doralose canal there, okay? What ligament is that? Grubus is on the top of the sixth nerve. So let me show you the C5 carotid, that is the paraclival carotid, okay? Right. So to see the paraclival carotid, you need to take this fourth nerve up. Can you focus there for me? One of the tricks when you panic, you must understand. See, this is the C3 carotid. Can you see? This is the C3 carotid, vertical carotid. That is a C2 intradural carotid, okay? This is intradural carotid. This is C3 carotid. This is C4 carotid, okay? That is the horizontal carotid. And now you will see the C5 carotid. That is a vertical carotid, paraclival carotid. And the C4, C5 junction will give you the meningohypophyseal trunk. So you can see that is the horizontal. You put in some water there and then let's clean it thoroughly. Lot of water there. Yeah. And let's clean it. Clean it. Yes. Clean it. Okay. So I was telling you that's a sixth nerve. Okay. And the carotid, extradural carotid, all the way from C4, C3, C2, intradural C2, okay? And let's shift our view to intradural. So that's a third nerve. That's a third nerve. That's a membrane of Lilliquist. Okay, between the carotid. This microscope is like an Olympic wrestling champion, It's wrestling me. Optics are very good, but it's like a wrestling champion. It doesn't. So you have the optic nerve, the intradural carotid. and we have gone extradural, intradural here. So we're going to dissect that third nerve root. That is the third root, sleeve, okay? So we're going to dissect the third nerve, open the third root sleeve. So you can see there, hey, when I want to move the microscope, can you just, guys, can you come and loosen that thing?
Yes, sir.
Yeah, I mean, this is the wrestling champion. I don't want him. This one also. Suction to me. So the optic focus for me. So the opticocarotid window is open. Membrane of Lilliquist is getting open. That's your basilar. Okay. Let me show you the basilar now. You are seeing the basilar artery? Very clear? That's the basilar artery. That big artery, what you are seeing. Can you focus there, Nilesh?
Yes, it's clear.
That's the basilar artery. So that's the membrane of Lilliquist open. So even in a tight brain, people tell me, oh, how can you reach the basilar? That's the basilar artery. Okay, we will go later. Once we open the dura completely, we will go much, much more better. I think it's time for my lunch. I think it's time for lunch. What do you say? We will have a talk or something. Now, can you, somebody sit and review? Abhida, put on gloves and sit and show them that. You and Shashwat. Everything is shown. Now, second nerve, carotid, third nerve, fourth nerve, V1, V2, extradural carotid, cavernous sinus carotid, sixth nerve, okay, basilar. Everything is seen. Now, after that, we have to go to the next stage now, where we go truly transcavernous. Okay, that is a different step. First step has been achieved, and I think all of you guys also should go for lunch or something. You know, it's not good to sit down all the time and watch these dissections. Also, maybe write a paper or or have some lunch or something. Okay, right. Abhida is going to review. Between writing a paper and lunch, always prefer lunch.
Okay, so we have another question, Professor Ripe, if you're there.
Yes, petrolingual. Fantastic. That's right.
Hello, Dr. Ripe, can you hear me?
Yeah, yes.
Okay, so we have another question. It's he's asking, what is your advice of doing anterior clinodectomy intradural or extradural?
Again, it is a matter of choice. So some of my very good friends who are excellent surgeons do intradural clinoidectomy. Now, what I do is I do extradural clinoidectomy. I like, even when there is a paraclinoid artery, paraclinoidal ruptured aneurysm, I always do an extradural clinoidectomy. I don't like intradural clinoidectomy. So that is what I'm comfortable with. I can show you many videos of ruptured transitional paraclinoid aneurysms. I do extradural. Now, people say there is no sense of security. That is not true. There is dura between you and the aneurysm. And dura is quite a tough membrane. So you cannot, if you are breaching dura, and if you go and screw the aneurysm, or you put pressure on the aneurysm when you are doing a clinoidectomy, then you have to learn a little bit more to do it. Now, my good friend and excellent surgeon, Professor Lawton, he does an intradural clinoidectomy always. So he's very comfortable with it. There are many other national and international excellent neurosurgeons from India and abroad who does intradural clinoidectomy. There's nothing, I cannot find anything wrong in that. Neither can I find anything wrong with my technique. So it is the way we are trained. Okay. Superman puts his underwear above his pants. We put our underwear underneath the pants. I don't think there's any difference. We cannot discriminate one from another. All right. So that's the whole thing. Whatever you're comfortable with. At the end of the day, do the clinoidectomy, where it is intradural or extradural or whatever it is. Yeah, so Abhida has gone intracavernous. Abhida has gone intracavernous. She is showing the sixth nerve where it is coming from. So the Doralose canal is what she's showing. I have to dissect the fourth nerve a little bit more, because the fourth nerve is standing out there. So maybe the fourth nerve also can be a little bit dissected. Right. Yeah. Yeah, so that what she's showing is this where the sixth nerve is coming in from. Sixth nerve is going into the Doralose there. Sixth nerve is going into the Doralose there. This is one area where petroclival meningiomas go in from the Meckel's cave. They go into this region. So you have to be careful about taking from this region, because you have the carotid also there. The C5 carotid is also there. Abhida, you like the exposure? What is the time, guys? Huh? 12. Yeah, maybe we can hang on for some more time. You can open the dura and show them the basilar and everything. Yeah, and then we can come extradural again and go into the go into the Kawase. Yeah. It's really, really tight, believe me. I mean, it's not something that we find very usually, but so Abhida is now going into the intradural carotico-oculomotor space. You can dissect the third nerve, go all the way, and then you can find the P1. Yeah, that's a posterior clinoid. Yeah, so the posterior clinoid. Yeah, that's a posterior clinoid. We can remove the posterior clinoid actually. And remove the posterior clinoid. You know that tumor cutter that we designed? It is the best thing to, why don't you attach your tumor cutter, small one? Tumor dissector, small one. You try this one and you will see how beautiful it is. The bone can be easily removed. 2 millimeter sagittal saw. And you can, once you remove the posterior clinoid, then you have excellent access into the basilar region. Yeah, this microscope is like divine. Keeps on moving itself, you know. The straight one. Do you have a straight one, rather straight?
You can see the superior hypophyseal.
Okay, show the superior hypophyseal. The superior hypophyseal, once you see the carotid ophthalmic, and then you can see the superior hypophyseal going medially. Yeah, beautiful. So you are in the interoptic corridor. You can see the superior hypophyseal coming up there. You have to focus there. Huh? Now you have to bring the field to the center. Yeah, maybe this one. Here, Abida, you take the mic, da? You take the mic. Here. Shall. No, I'll put it on your neck. I'll bring this thing.
Can you focus? Now can you see or it's still not centered? No, it's not centered.
On your neck, da?
Yeah. Just a minute. No, microscope is moving and doing all kinds of things.
We have no need to fear. Abatha is here.
John,
Yes.
focus please. Yeah, okay. So we are in the chiasmatic cistern here. Focus, cannot see.
Yeah, I'll focus. Yeah, right.
No.
Yeah.
It's coming. No, it's not yet. Huh? It's not focused here.
Is it okay now? Abida?
Little better, but not. Yeah, okay, I'll manage. Can you see it there?
No, you need to focus first and then we will manage first.
Okay, wait then. No. Yeah, just lose the microscope, please. Okay, now this should come. Focus karna. Focus now. Yeah, better. Focus. Can you see on the screen? We actually need to retract this portion also. Okay. It's focused on the screen. Okay, so here you can see all the perforators coming from the carotid. Here you can see the superior hypophyseal, and this is really a region of your pituitary stalk. If we dissect in this region, we'll be able to see it.
That's a really good picture.
Check. You can see the optic nerve, the carotid, and the third nerve. Optic nerve, carotid, and third nerve. Can you hear me?
Yes.
Right. Abida is showing the interoptic cistern where you can see the superior hypophyseal, and the optic, then the pituitary stalk there,
Yeah, yeah.
going posteriorly. Now, Abida, will you go into the opticocarotid cistern and show the basilar ones?
Okay, just a minute.
So this picture you can see the optic nerve, carotid, third nerve, fourth nerve, and V1. And
Focus.
once she is
Here it
gone
is.
down,
Here we are.
that is the basilar.
Here
That
we
is the
are.
basilar artery.
Okay, and that nerve on the other side is the opposite third, I think. Isn't it?
Yes, the nerve
Yes,
on the other side is the contralateral
opposite.
third.
Yeah, it's the other side third. That's the basilar here. And that's your interpeduncular cistern.
Yes, absolutely. So
So-
we are showing it in the opticocarotid corridor.
And I think you can see the PCA coming out from it.
Yes, if you
can
go
see the-
laterally, but
yes,
we need
yes.
dural opening for that.
Yeah, okay.
Because
you
we
can
have
see-
opened the dura as a slit, just a slit.
Yep.
But you see, with the tight brain and with just a dural slit and some good skull base work, what you can achieve is remarkable, isn't it?
Yeah.
So now we will go transcavernous, where we will cut the third nerve all the way back to the interpeduncular cistern, release the fourth nerve from the dura,
beautiful
and
picture,
do a bit of Kawase.
Tell him to take a
and
photograph
Not
also.
much.
All the
do a
nerves
bit
are
of
there.
Kawase and go
microscope
completely
वाले को
transcavernous.
See, you can see here all the cisterns are communicating. See here
Yes,
the chiasmatic, then you have the carotid,
Yes.
then you have the interpeduncular behind.
Yes.
This will be a region of liquid membrane where my suction is.
Yes.
So all the cisterns are communicating in this region. It's like a confluence of cisterns here.
That is what we open up in cystonostomy.
Yeah.
When we do cystonostomy, that is exactly what we open up.
There's the basilar is beautifully seen now.
Yeah.
Focus. Yeah, that's it. Can you see it now? Yeah, that's a beautiful picture.
Yes.
That's the basilar there. And that's some parts of the liquid membrane here. Yeah.
So that's anatomy. Second nerve, carotid, third nerve, fourth nerve, V1, basilar. So that is your extradural and intradural exposures of the important structures. So that will conclude our first session of dissection of the anterolateral corridor. We will put some lectures in. Hira, you can take over from us. And if you want to put some lectures on, you can. And maybe, Abida, we will go for lunch and be back. Okay? We would like to have lunch and then we'll be back. Thank you very much. Any questions or any comments or anything from anybody?
Do we have any questions from the panelists? We don't seem to have any questions, and at the moment there's no one from the faculty who has showed up in the panel. So I think we'll take a break here.
Right.
How long a break?
1 hour, John. 1 hour.
Okay, we'll see you in an hour.
Yes, John. Yes. John, maybe you should catch some sleep.
Yeah, I will. Okay, I'll see you in an hour.
Yes.
All right.
Pura cavernous is completely open. Beautiful, huh? Sure.
You see, in a tight brain, I managed to do that. Okay,
It's really tight, huh? It's quite tight.
It's very tight. Extremely tight.
Oops.
Okay, guys, we can go offline, please.
I'll निकाले बीच से.
Offline. And Hira, are you there? Hira? Hira, are you there? Hira?
Yes.
Hello.
Yeah.
Hira, do you want to schedule any lectures or something now?
I would have scheduled if I would have anyone online at the moment, because
Right. No,
at the moment.
during this time, the participants can go ahead and have a very good discussion. I mean, if anybody is on, amongst yourselves, you can go. I mean, Nilesh is one of Shashwat and Nilesh, can you stay here? We will come back from lunch and then you guys can go. So you can discuss with Shashwat and Nilesh. Deepak is here. I see that Deepak Bangale is here.
Yeah, Deepak Bangale is here.
Yeah. So many other guys are here. So you guys have a discussion on what we showed, and by the time we come back, we'll take it forward. Okay. And the team also, you guys can also go for lunch and stuff.
Hello, Dr. Deepak, are you there? So anyone from the panel? Dr. Nilesh, are you there?
Hello, yes.
Hi, yeah. So would you like to comment and open a discussion for all the panelists here?
Maybe we can discuss the anatomy.
Sure, sure. If you would like, you can share your screen or show any presentation you have, or you have an open discussion, please put on the video and we can have the discussion.
No luck.
Hey, Dr. Nilesh, can you hear us?
Yes, yes. Dr.
Yeah.
Shashwat is here. He is showing some anatomy here.
Sure.
Okay.
Just start.
Yeah. Shashwat is reassessing the cadaver dissection we have just done, and he
We have a question from the panel, and they want to know if there is any particular order in the opening of the cisterns. So I am assuming this question is directed to Dr. Ipe. Is he around? I think he's on the break. So Anurag, we will ask your question when he is back.
Is there any order of opening what?
The cisterns.
Not really. Yeah. For me, I am a guy who doesn't like any order. Whatever cisterns come first, open first. And if you ask me, sometimes I get into the interoptic, I open the interoptic. Open the opticocarotid. If the opticocarotid is comfortable, open the opticocarotid. Okay. But membrane of Liligus cannot be opened before these two. That will be disastrous. Okay. So open superficial first and then deep later, whichever your perspective is. Right.
Basically, you will come across the either the chiasmatic or the opticocarotid cistern if you are more basal and frontal, and if you're lateral, you will get the Sylvian cistern if you're intradural, and otherwise you will get the carotid cistern. So those are the cisterns that will come first in the picture, and you can open those first.
Thank you, Dr. Abida. So coming back to you, Nilesh, can you please explain what you are revising?
One second. This is called optic nerve, and after opening the opticocarotid cistern and enteroclinodectomy, we have already shown. So the enteroclinodectomy process. Yeah. So this is after removing the enteroclinoid process, we can see the dural rings, that is which has been described complicatedly in the literature book the Professor Ike already told. So after removal of the enterocranial process, we can see that distal duraling, where the carotid come out of the cavernous sinus, and this is the distal duraling. So the distal duraling, it has been cut here actually, and where the genu, the distal genu turn, so that is the proximal duraling part. Yes, that is the idea. So where, and this is the Nilesh is holding, that is called third nerve, enter into the supraorbital fissure, and laterally that you can see the fourth nerve, which is overriding the third nerve and enter into the supraorbital fissure. Yeah. So now in optico carotid and oculomotor triangle, so go inside in the suction. There you can see the sixth nerve coming out of the Dorello canal. Where is the suctions? Give the this one. Yeah. No, where is sectional doesn't turn out. Go to the V1.
We can see that. Yes. Yes. There's, now we can see the six now. Hmm. Yes. Yes. Hmm. Yes.
This is the distal genu, this is the horizontal part.
Hmm.
And from where you can get the meningohypophyseal trunk, but I am unable to see it here now. Okay. This is, and this is called V1. It's in the centers. For sure. This is the V1, and this is the fourth nerve, and this is the Parkinson space, and where the Parkinson first time described the carotid cavernous fistula operations, and this is the V1, and this is the V2. Where is the vagular, you can show?
You have to go from the opticocarotid system. Yes, sir.
Just don't
Yeah.
screw the fourth nerve. That's
Yes.
very easy to rupture. That's why.
Yeah.
Very, very careful with fourth nerve. Okay?
Yes.
Imagine you're doing it with the bladder, and that's the fourth nerve. Fourth nerve
Yes.
is right at all. You see
Yes.
that?
Yes. This one.
That's important. Yeah. Okay. You see the third nerve also. You can now dissect all the way into the interpeduncular. Gently, very gently. And cut the dural root sleeve of the third nerve, and then you can go into the interpeduncular system. And above that, you will find the take that arachnoid off. See, so your third nerve के ऊपर जो दिया है,
Yes.
take off. Very gentle. Don't reflect too much force at all because you will screw it. So very gently. Go here. It is just very gentle. Nilesh, open that membrane umbilicus, and then you will see the P1, all those things you will see. Cut. That's good. See that? Yes.
Hello. Hello.
Hello.
Dr. Nilesh?
Yes.
Yeah, Dr. Shashwat is there?
Yes. Yeah, we are here.
Uh, yeah, Deepak here. Can you show us the course of carotid, means compartments, which one is a horizontal portion and all was, and then this one, vertical segment and all?
It's new. Yes. One second, sir. We are showing it.
Yeah, sure.
Yes, retract it. Okay, okay. Retract. You retracted. Give. It's too much.
Yeah, this one is.
Is it? Yeah. Let me to laterally whether it's not getting focused. Or
This is optic.
This is supraclavicular part of the ICA, which Professor I've called is C2 part. And this is
Okay,
what we
sure.
have done is we have removed the anteroclinoid process here. Okay, we are unable to see it,
Okay.
and we have already cut the dural ring here. So after
Yeah.
cutting the anteroclinoid process and optic strut, we
So
can
you
see.
get completely remove the anteroclinoid process, or
Yes.
how much extent should we remove the anteroclinoid process?
No, we remove the completely. We remove the anteroclinoid process with optic strut,
Okay.
so that we can mobilize it
Okay.
better. Actually, yeah. So this is
Okay.
the transition zone where we called it a
Okay.
distal duraling. Still, you can appreciate it. I think so because
Yes,
this is
yes,
we
yes,
have already
absolutely.
cut it out. So then
Yeah.
we can go follow the distal, then which we call the proximal duraling, where the anterior
Duraling.
distal genu of the cavernous part of the ICA actually turn into supraclavicular
Yes.
part of the ICA. So that we called actually proximal
Okay.
genu. And this is called distal, we call proximal dural ring, and this is called distal dural ring. There is nothing to be confused about it, nothing so much. So then
Sure.
we can enter into the intracavernous part of the.
Okay.
This is very well appreciated. This is third nerve, and this is your
Third nerve.
ICA. Yeah. Then
Okay.
this is you see this is called genu where it is turning. This is a cavernous part of the
Okay.
ICA. Can you retract it
Okay.
like this? Yes. Retract. You hold it. Hold it. Section जा रहा है. This is fourth nerve. Yes. This is your distal genu. Okay, cavernous
Okay.
ICA. and where it is calling it up, where it is getting the clinoid part of the ICA and clinoid part of the proximal dural link that we have shown. This is the transition where it is getting the supraclinoid ICA, that's called distal dural link, and this is the genu, distal genu. Then if you come more proximally, this is called horizontal part of the cavernous ICA or paracellular part of the cavernous ICA, where we actually get the meningohypophyseal trunk lat. I don't think so I will be able to appreciate it here. And where you laterally will get the sixth nerve. You can very well see the sixth nerve. This is the horizontal part of the ICA, and this is called sixth nerve, which is lateral to the ICA, and which is going, if you trace more proximally, which is going, coming out from the Dorello canal. Ek minute. Just it is. Yes. 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 Now you can, I think, appreciate the sixth nerve.
Yes, yes.
Yes, this is the sixth nerve, and this is we have the this is the ICA, the horizontal part. We can the paracellular part of the ICA. I'm unable to appreciate the meningohypophyseal trunk, which should come from the horizontal part or the proximal genuine.
Inferiorly. Okay.
Yeah. Okay. Okay. So I think this one, sir. Okay.
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 Pectoral meningioma and
Yeah.
things like that, but otherwise it will be a small gland.
Okay.
You cannot tear it.
Okay.
Tear it, it's a hole from the carotid.
Yes. Okay, sir. So now we can trace the sixth nerve. I think we will go more proximally. We can go to the that is the Dorello canal, which is coming out of the Dorello canal.
Yeah.
It's the fourth nerve, which is very flimsy. I don't want to retract it more for tearing it out.
Sure. No.
So this is the I think, Dorello canal. You can see the Gruber's ligament above it, and yeah. And where you can see the posterior clinoid process here, and I think here opticocarotid space can come. We can feel it. Just let me focus it more. Okay. So this is the posterior clinoid process. I want to show it. What I'm palpating, you can see it very well. This is the posterior clinoid process where my forceps is here. And if you go more proximally, we can see the basilar artery. I just want to appreciate it. But no, I am unable to. I think it'll like this. Nilesh, can you retract it more to show the basilar? Retract the temporal one. Yes. Go inside. No. Keep it. Yes. Hold like this. Yeah. I think this is the third nerve, and which is going, we can trace it more by removing this arachnoid covering over the third nerve, and you can go to the interpeduncular fossa, which is just coming out. I think retract it more. Yeah. Yes. I think you can see it, the interpeduncular fossa here. Let me show the basilar artery. It is move. The middle manner, yeah. But I'm unable to show the basilar actually. It's not moving out. Focus. Now focus it. Yes. Trace the third nerve where we actually mobilize. Yeah. Well, this one. Yeah. This is now. It's a little bit like this. You can. This is the basilar artery. You can see. This is the basilar artery, and this is the third nerve. We can more tracing. Yes, like this. This is the interpeduncular fossa. I think you can see. Chalo, you want to show more? Chalo.
Hi, John. Are you there?
Mm-hmm. Acha.
Who are you looking for, Hera?
Yeah, we have Dr. Ahmad Al-Jiradi, one of Dr. Ives' fellow. He's joined us.
Okay.
Yeah, could you please promote him to the panel? And he can participate in the discussions as well.
बाइजल को अच्छी तरह से दिखाना पड़ेगा because frontal lobe retract नहीं हो रहा है. The frontal lobe is not getting retracted well. Oh, it is.
Hi, Dr. Ahmad.
So the intercordial artery दिखा. क्या करो? ठीक है. Very well seen. Show me the bifurcation. Bifurcation का देखो एक बार. All right. हाँ. Okay. उसका और ऊपर जाओ. हाँ. Yeah. Go to the bifurcation PCA. More. Yes. This is so. Go retract it more. Yes. Retract it more to the bifurcation. Basilar bifurcations. Yes. Now you can see the PCA. तो अभी तू ये कर. On the live now. Don't take all this. चालू कर बाद में करना. They will come na again. They will show. Can you show the intercordial artery branches of that ICA? उधर ही है, दिख रहा है इसमें. Laterally देख. हाँ, yes. What is it? This is a PCOM or intercordial artery? और जाके आगे press it out. Intercordial to last branch. It is the PCOM.
It might be PCOM.
Yeah, this might be PCOM, and it's joining to the PCA. Can you trace the PCOM? Yeah. Yes. Yes, this is PCOM. This is mostly PCOM. It is going posteriorly and attaching to the PCA post. Huh? Sir? Yes. It is going posteriorly and attaching. Trace it out to the PCA. Yes. You are damaging the port now. Yes. Now will be
You can see them. Which one is this branch? ठीक है छोड़ो छोड़ 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 छोड़ना This is the Gassan ganglion. नहीं क्या करेंगे बोलो ना म्यूट का म्यूट म्यूट करा म्यूट म्यूट करा फक्त
How are you, Dr. Deepak? Yeah.
Frontal corridor artery.
This is right. We're going to interpretance also you can see the SCA and EC also.
Yeah, because this is the transcavernous technique of
Yes.
operating. Okay, this is how I do my superior cerebellars and my basilas and all these. I'm using that. I go this way. This is a transcavernous technique. That's what I told you. You open the root sleeve. Third nerve root sleeve. If you open, you're done. Okay, and you're going transcavernous. All right. This is really a trans technique where you go transcavernous and getting this basilar aneurysms easily. Okay. You can open the extradal of third nerve sleeve also.
Okay.
Careful.
Yes, sir.
Now we'll go into. There's a lot of guys still hanging around.
Then come back.
Yeah.
Aditya, did you put now? Yes, Aditya, did you put now?
I go transcavernous and then I go sleep.
Yeah.
I go transcavernous and after that I'm going to sleep.
And
Then 4 o'clock we have a lecture.
yeah, where?
I can do it in my office also. I will get up after sleep and then do the lecture.
Yes, sir.
Organize 6
Once the webinar starts, the order is already prepared. One by one. Yes. But we will require your expert comments. Huh? हम इसमें एक बार आईसी बुक देखना है इसका आईसी
क्या करूँगी?
देखो बराबर है
क्या कर बैठे?
मैं नहीं कुछ कर नहीं बैठे हम लोग बैचलर देखना
जा या ऑप्टिक आया क्या?
ये ऑप्टिक आ गया कैरोटिड दिख रहा है
तो ना रिट्रैक्टर के बगैर दिखा
नहीं ये अपोजिट साइड का देखना हाँ ये अपोजिट ऑप्टिक है ये
हाँ कायजम आया
हाँ एक कायजम आ गया इधर ये आईसी अपना इसका
वो गंध हटा
ये आगे ये है अपना
पीकॉम उधर आएगा उधर
नहीं पीकॉम इधर दिख रहा है ये पीकॉम है ये पीकॉम है एंटीकोनोइड ये उसके जस्ट ऊपर ये दिख रही है ऊपर दिख रही है यस ये यहाँ से वो टर्न आ रहा है टर्न हो रही है उसके बाद में यहाँ पे दिखेगी नीचे अपने को कैवर्नस वाली हाँ नहीं अभी हाँ अभी चालू हो गया नहीं वो पता नहीं वो हीरा बोलेगी हेलो बोलेगी
चालू है तू भाई माइक्रोफोन ऑन है माइक ऑन है भाई
यस
बोलना सीखना पड़ेगा सर
नहीं ये देखो ये कैवर्नस आईसी है ना
कहाँ
ये
हाँ ओके
कैवर्नस आईसी है ये जा रही है पीछे
सेंटर में लाना
तो लैटरल हो गया
अभी एक कैवर्नस ऐसे जा रही है यहाँ पे फोरामेन लेसरम आएगा ना यहाँ पे
और पीछे थोड़ा टर्न हो रही है
हाँ
तेरा रिट्रैक्टर दिखना है हाँ लेसरम
मुझे अभी एसी एकॉम सॉरी एसी ने एम से नहीं दिख रही है
डिवीजन का
हाँ
थोड़ा सा रिट्रैक्ट
डिवीजन का रिट्रैक्ट करना पड़ेगा तो
थोड़ा सा ज़्यादा रिट्रैक्ट कर
हाँ सर
पूरा वाइब्रेशन करता है
लाइट हो गया था
नहीं नहीं,
10:7
यहाँ पे शायद बाइफिकेशन हो रहा है, देखिए यहाँ पे कुछ। अच्छा, ये फटा हुआ है कुछ तो। हाँ हाँ, ये एसी है। एसी एमसी, तो एसी यहाँ पे जाएगी, तो एक काम कहाँ पे मिलेगा? यस सर, यस सर।
Excellent, right? This cystinostomy is anatomy, it's anatomy for everything, okay?
Yes.
That's all you have to do.
Is the opticocarotid, then we can see the bacilla.
Window, basilar.
Yes, and
P1s, both P1s.
yes,
Careful.
yes sir.
See?
Yes sir. Both P1s.
P1s.
Yes.
one side the other side
Mm-hmm.
One relate to the third knob. Okay. The other side.
Yes.
Okay. Gloves.
So gloves, we have the unsterile gloves.
Only major two scholars
प्रमोद, हे साना लावा ना. आणि
Okay.
दूसरा माइक दे
Irrigation. Caesar.
Hi, Nivech. Are you there?
Ira,
Hello. Yeah.
She's dozed off. She's in Canada.
John,
Yeah,
John, yeah. John, are you there?
yeah.
Yeah. Okay, so we resume.
You ready to
hey
start?
John, we're back.
Yeah.
Okay.
Okay, what are we doing now?
I can't hear you, John.
Oh, you can't
John.
hear? Yeah, you can't hear? Yeah,
John.
yeah, I'm here.
Ira.
Yeah, I'm here.
Okay,
Hello?
give me a tumor
Yeah, I'm here. Can you hear?
drill or something.
Still
Can
can't
you
hear
hear
you,
now?
John.
I think they cannot hear us.
You can't hear now?
I can hear you, John. I think they
Oh,
cannot hear.
okay, okay.
So now you are seeing both the P1s very clearly. This thing is
Orbit is in the way.
orbit is
Nilesh, retract the orbit little down. This was spoon bring it up.
yeah. So one second.
Dr. Abida, can you hear us?
So that is the apex. No, this orbit retraction, I want it like this one. I think you can do that. I want this like opposite membrane of the lupus. Opposite P1, can you see that? Focus from. Can you see the third now, opposite third now also there?
Yeah.
It's a bit damaged, I think. That's all right.
John,
So-
can you hear us?
We can.
We can't hear you.
Yes, I can hear you. I can hear you.
I think they have a problem with the speaker.
Yeah, I can't hear him either.
इधर से जा रहा है आवाज, उधर से नहीं आ रहा है.
HP is unmuted.
John is
Yeah,
talking.
John, we can't hear. John, just a minute. We are just looking at the technical things here.
So PCOM, can you see the PCOM there? PCOM going and joining. This sector to me. That's a bifurcation there. You can see the bifurcation clearly. The third nerve is always above the superior cerebellar. So that's the superior cerebellar. And this here will always run above it. But now, let us go extradural. I need more sutures up here. Oh my God, I mean, how am I going to get this? Oh. Suction is not working. You know what? You need to open this up and do a temporal lobectomy and then close it. Okay. You think you can do that?
Yep.
I think you need to do a temporal lobectomy at this level.
Okay.
Because this is stone hard, you know.
Yeah.
You cannot. So open that, do a temporal lobectomy, open here,
Okay.
do a temporal lobectomy, and then retract the dura here so that we can go ahead.
Okay.
We can't hear them. So can you unmute them?
Oh, I think that I've been trying.
Huh? No, John is not muted.
No,
John is talking.
Yeah, I'm talking. But the
Yash?
dissector is not speaking, right?
You could not get a SIM card. Okay, you know what? Where's my phone, Gajay? Oh, no, my other phone. Come, Yash, come. Abhida is in. What I'll do is, no, you can use these rubber bands to cut, to retract.
Yes.
I'll give you my other phone. So you can put that into this and make a WhatsApp for that. Huh?
Now they have changed their norm. They require physical SIM card.
Oh, Aadhaar card.
Initially there was a handwritten form.
Ah.
Now it is all computerized.
No problem. So we will get one. I'll go get my Aadhaar card and come. But I have a SIM here. So I'll give that SIM to you. You can put that SIM in. Can you connect my iPad into the कजो है iPad का कनेक्टर है HD अच्छा ठीक है iPad कनेक्ट करना और उसका तो अभी शी इज चेंजिंग मैं जाके हियर tomorrow you have a C1C2 preserve. Yes, sir. Posterior tomorrow Abida will do a C1C2 exposure, and tomorrow I'll go and do a far lateral, extreme lateral combined together.
क्या किया?
बहुत ही हार्ड है। हेलो
Are we working on getting another speaker?
I'm trying to contact Nilesh. John, can you hear me?
Yeah, I can hear you.
Yeah, I'm trying to contact them, call them.
हेलो हेलो
I think I wants to use a smartphone as a speaker. Was going to get it. I don't know. All right.
right now we are just doing the temporal lobotomy because the temporal core is coming in the way and it is very difficult to retract. So we are just removing the temporal lobe.
Whoop, we lost the picture too.
No, John, I think they left the webinar at the moment. I think they'll come back.
Okay.
Yeah, they're not here. John, can you please put them on the panel? They are here.
You let the HP in.
Yeah.
Yeah. Okay, HP, you there? Okay, HP, you there?
Yeah. Can you hear
Okay.
me?
Yes.
Yes. Can you hear us?
Okay, we are going to come back soon. We're going to go ahead with complete transcavernos as well as the Kawase approach.
Okay, we can hear you.
We can't see the screen.
Yeah, we are coming there. We're coming there soon.
Okay. Whoop, we lost both audio and video. I guess we're just waiting, right, for someone to come back. Okay, here, what are we doing? Do you know? We're just waiting.
Hello.
Yeah, we can hear you. Okay, you there, HP? Still no audio.
So this is the, like the bone cues are developed by us. It's just a sagittal saw, dissector. Hold this and dissector to me. It's just a sagittal saw redesigned. So that is the covers a triangle getting exposed, and before that I'd like to take out some bone here. Bone now, did the same thing now. Can you see the bone getting removed here? This can remove tumor also, the same way. And you cut, you touch the dura, nothing happens. See that? It's safety thing. Something we designed with 1 month. So bone can be removed easily like that with this. Bone can be easily removed like that. Not only bone, this can remove glial tumors, this can remove hard meningiomas, and all the while preserving the. Can you give me the scoop? Scoop, can you give me the scoop, please? Give me the scoop. This is something which we designed at literally no price at all, you know. Scissor to me, scissor to me.
So which one you want? Large, small?
Which one? The scoop, small, large scoop. Large scoop. Dissector now. Dissector. This branch, can you see this band? What is that now? That's a GSP. GSP carotid, okay? We'll expose the carotid also. Can you? Some stitches. Right. Let's stitches. Scissor. Scissor. Yes. That's a tent. Okay, so stitches now. No. Okay, I just found it. Hold that one end. इतना ही है बहुत है लेके जाओ उधर तक जब तक
Hello, is the presenter there? Because we can't hear. So we're waiting for the presenter, right? Correct? We're waiting for the presenter. He apparently is not here with audio, correct? Can anybody hear me?
Yeah, John?
Oh, okay, you're there.
Yes, we're there. We're just trying to get the screen audio working.
Okay.
Yeah. Can you see us live or you can't see anything?
No, I can't see anything on the screen.
Okay, we're just restarting the computer. There was some problem with the audio.
Okay.
Just get back to you.
Okay.
Give me that scoop now. Do you understand now what we need? Yes,
Okay, I guess we're waiting for the setup of both the camera and audio.
I'm completely confident that unless the carotid is a bone structure, it's not going to go to the carotid. Sorry.
Still no audio or video.
Yeah, I mean, I need.
Oh, there we go. There we go.
Yes, John, can you see us now?
Yes.
Okay. So he's drilling the Kawase triangle now, bone over the Kawase triangle. We've already dissected the GSPN and pushed it down a little bit.
Needs to be unmuted. Oh, there we go. Okay.
You have to see the posterior fossa dura. Irrigation, lots of irrigation. Show me the dissected. That is a carotid, okay? That is a carotid which I am uncovering. That is a carotid. Not good to uncover it with a.
John, can you hear Ripe?
Yes. No, I can hear the drill, but I can't hear the voice. I can hear you in the background. It's not a good sound.
That's the drill.
Yeah, I can hear you well, Abby, but I can't hear Ipe well. Let me unmute the other HP. The other HP account has to unmute. That's probably why we're not hearing Ice's voice. Abby, do you have access to the HP account? That's not you, right?
I didn't hear it. Can you repeat that?
Yeah, I can hear this now, but
Can you see the screen?
no, I can't see this. Oh, wait. If I get the other screen,
Yeah.
I have to, okay, I have to feature that. Okay, and use your audio. Do you have audio?
Just a minute. Our audio is on?
Yeah, the video is okay.
Okay, let me check the mic.
I can hear the drill.
Can you hear Ipe?
No, I can't hear Ipe. I can occasionally hear the drill, but I'm not getting the audio from the account.
Hello.
Yes, I can hear that well. Can you hear me okay?
Can you hear me now?
Distantly, I can hear you.
Okay, adjust the mic.
I think
Can you hear me now?
Yes, but from a distance.
No.
It's not good.
Just give me the second.
Still no audio.
Yes, John, can you hear me?
I can hear you fine.
Can you hear her?
Okay. No, Hera stepped away.
John, can you hear Ipe?
Not really, no.
Hey, John.
I can hear you
How's
now.
that?
I can hear you now.
Can you hear me?
Now I can.
Okay, I think something to do with the mic.
Okay.
Guys, can you make sure it's heard? Drill now. Hold this up. What happened? Everything okay? Huh?
The people are calling. These two people are not went for lunch.
Yeah, it's funny. I can hear the drill, but not the voice.
तुम भी लंच के लिए नहीं गए ना नीलेश? Irrigation, lots of irrigation.
मॅडम 2 HP ला एकच आयडी लॉगिन केलं त्यामुळे तसं आलं की
So that's posterior fossa dura. We're going to come to the IAM now. That is IAM. Yeah, something is caught on the drill. Dissectomy. So what we're going to do is,
Hello.
we're going to make a
Hello.
intra scissor to me now.
Good audio.
Lobe.
Hello.
Yeah. Temporal lobe like that. Not seeing. Yeah. Cut above the fourth nerve. So that you can go there to the tent.
Whoop, we lost the connection. Okay. We're waiting for the connection to come back. Okay, connection is back. Okay, HP, you hear me?
So that's a root sleeve. You cut the tent here. This is the fourth now.
John, can you hear me?
Tremendous amount of
Yes.
retraction I need.
I can hear you and
We need
the
to take out this
dissector.
entire.
Just a minute. We can't
temporal
hear
lobe.
you, but I think you can hear us.
Yes. Yes.
Okay, boys, where is? Yeah, you think you can take out this entire temporal lobe right now? Okay, because see, you see the entire third nerve all the way down back. Can you see that? That's the membrane of Lilliquist. Okay, that's the membrane of Lilliquist, and then you have the fourth nerve going back here. Can you see? The fourth nerve. We will release the fourth nerve. So after we identify the fifth nerve and cut the superior pitosis sinus which goes above the fifth nerve, we will cut it off. But for that I need this temporal lobe. This is like stone hard temporal lobe. This is impossible to do anything with it. Okay, so go ahead. During that time, let me show a video from the iPad. Can you start the iPad, please?
Okay, this is going to be a challenge.
Oh. लेकिन उससे तो What is the point? No.
Okay, we're starting an iPad. Is that what
Show
we're
me.
doing
Put
here?
that thing on. Put that thing on the.
Yeah, does Manas have the iPad? Is someone coming in with an iPad?
Yeah. Me.
Okay, there we go.
Right. Can you see the videos?
Yeah, I
Can you see my screen?
I can see your screen. The video's not playing yet.
Right. So we're going to show you a. Why is the video not playing? The video is not playing.
It could be the connect. It could be the connection. If his connection's bad, it may
Okay.
not play. Try again. Yeah, try again.
Yeah, I'm trying.
Yeah. There you go. Okay.
You playing?
I think it may be. It's kind of stopped now.
Okay. Right, that's a paraclinoid aneurysm. Done with the same technique. Okay. So it's a transitional aneurysm there. You can see that.
Yes.
Same thing that we did today. We are opening with a diamond knife. As I told you, with a diamond knife, you're opening the orbitomeningeal band. I like to go under very high magnification. And I'm exposing the cavernous sinus. Same technique that we used today. So you're slowly dissecting and dissecting the temporal lobe dura away from the cavernous sinus dura. There's a moving, but nothing like heavy cavernous sinus bleeding or anything. So you can see the frontal lobe on your right side and the temporal lobe on your left side. See now I'm moving the third nerve away from the clinoid. Using a diamond knife further to.
Yes, sir. Speaker lama, speaker off. Same thing.
Okay, we lost the audio.
Can you see me? Can you hear?
We're gonna hear now. Yeah.
So we are drilling the above the orbital, above the optic nerve and above the clinoid. Clinoid is released now. Below that is aneurysm. So I'm going extradural completely. It's a ruptured aneurysm, by the way. Going completely extradural. Thinning the clinoid out. Thinning the optic, extradural optic roof out. Further drilling into the clinoid. You have to be very, very careful here. You can't even afford to push the dura or forget breaching the dura. If you breach the dura, that aneurysm is ruptured. Before you even open the dura, that's not a great scene. So what you're doing is you're just thinning it out with a lot of feedback from the drill. So now you're, see where my is the optic nerve. Where my suction is, that is the optic strut and the clinoid. So I'm drilling it further. I'm drilling it using a 2 millimeter drill. I'm drilling further. Now I'm using a 1 millimeter drill. Using a 1 millimeter drill to remove the remaining clinoid and the optic strut. Now I'm going to open the dura and you will see how easy it is. Once this is done, you can see the optic nerve. That is the optic nerve. Just like what we saw today. I'm cutting with a diamond knife the falciform ligament. You saw the distal proximal dural ring today. So that's what we are doing. We're releasing that carotid. So I'm drilled. I mean, I've removed that proximal distal dural. I mean, the distal dural ring I've removed. It's a transitional aneurysm, you must remember. Yeah. So now the aneurysm is completely exposed. You're ready to drill. I mean, you're ready to put your clip on. How is that?
It's okay.
You liked it? That sound?
Yeah, I don't know what that was.
I also don't know. So that's aneurysm all exposed. I think that was the background music of the aneurysm. Now we're all set, clip parallel to the C3. C3 and C2. C3 is going down there, and C2 you can see on my clips this side. And like that, you could just clip it off. So you can see the C3 going down, cavernous C3 going down there. The carotid is reconstructed beautifully. You need one more clip because there's a dog ear there. So you put that clip and the carotid is reconstructed. It's just the aneurysm that is clipped. So this is using this approach. Right. So we're going to get back to this again, the dissections. One second. Again, just gonna move it. Yeah, thank you. I'm going to remove the true cavernous membrane here. Yeah, take a good stitch. Suction now. Huh?
Hello?
Now I'm going to expose the superior pituitary sinus and then cut the tent off so that you can, superior pituitary sinus runs over the fifth nerve. So you can see the, come give me the scissors. The key, you cut over the fifth nerve. Can you see the fifth nerve coursing into the posterior fossa? That's arachnoid. That's a temple.
जॉन सरांना बोलायचं का जरा जॉन सरांना फक्त बोलायला सांगा.
John?
Yeah, we're getting interference from the other input. Okay, can't hear Ipe now. Okay, we lost Ipe's voice.
Cutting the tent.
Ipe's voice comes and goes. It's currently not working. Yeah, Ipe's audio is not working.
Sorry.
But then it'll stop working.
I need a suture on that.
Okay. We gotta check Ipe's microphone.
Can you hear?
You got a couple of microphones open. Now we shut them all down. Okay. We're getting the picture fine, but just no audio.
How is it now?
Yeah, distantly, yeah.
इधर आवाज केवल वाला दोनों वाला कैनवेट पाइएगा दोन एचपी चालू आहे त्याला दिसायला दोन एचपी
Okay. Abby or Ipe?
Yeah.
Yeah. What we do? Working on the sound of Ipe.
Can you hear me?
Yeah, distantly I can hear you, Ipe. Okay, I'm gonna pin your picture. Okay, now I'm gonna unmute the other HP. See what happens. I think one of the HP accounts needs to be unmuted. I think that's where the audio is coming from, but it's muted. There we go. Okay, it's open now. We should have audio. Yes, I can, but very distantly. Both Abby and you are distant.
त्यांचा आवाज तिकडे जातो आवाज थोडी डिस्टन्सली जातो म्हणजे त्यांचा आवाज लांब जातो.
No, the sound is not good.
He's trying to sort it out. I cut off that part of the tent usually.
Okay, the sound is back.
Can I have a forceps or something?
Sound is back.
Can you hear now?
Yes.
Is it better now?
Yes.
But your sound is gone.
Oh, my sound is gone. Oh
Yeah.
my God. That's okay. We don't need my sound.
What went wrong? Okay. Yeah. No, I'm good. Just releasing the fourth nerve a bit. Oh, that's a posterior fossa. Can you bring the microscope foot pedal here? Is the microscope foot pedal working? I don't think it is. Yeah. Hold this. No. Dissector. Yeah. So that's a 10 that has to go. Once that tent is gone, only the trigeminal, you can see the trigeminal coming in. And I have to remove. Give me that forceps, please. And yeah, that's far better. Scissors now. So in a petroclival, you need to find out the fifth nerve. Make sure you don't injure it by releasing this Meckel's cave dura.
Uh-oh.
Fourth nerve. The medial edge of the dura where the fourth nerve enters, I've left it. So you can see the fourth nerve all the way like that there. Between the fifth nerve and your sixth nerve, that is your sixth nerve, this ligament, you can take it, you can cut this ligament. It's a very important part of your petroclival meningioma surgery. Between your fifth nerve and your sixth nerve. So you can see the Doralose canal there. This ligament I'm cutting off. Okay. So fifth nerve there, sixth nerve into the Doralose canal. And it's a Gruber's ligament that can also be cut. And then you are freeing the fifth nerve there. So medial to the fifth nerve. See the brainstem there. The sixth nerve there. Can you see it going into the Doralo canal? You can see the Gruber's ligament. I'm cutting away the Gruber's. Cutting off the Gruber's ligament. So the sixth nerve is unroofed now. What ligament is this? Between the petrous apex and that is also cut. We have PCA there now. Superior cerebellar and PCA are there. Now I'm going to come from the other side. So Meckel's cave dura. I'm going to cut off the Meckel's cave dura. So you have a layer of dura here that you can get. If you cut this dura, you'll get the arachnoid. You'll get the CSF out. So that's V1. That's the sixth nerve, which is uncovered now. The ligaments above the sixth nerve has been completely divided. That's the rest of the Gruber's now. It's also been divided. You can see the sixth nerve there very clearly. Fifth nerve, sixth nerve, fourth nerve. Okay? And that is the carotid. Can you irrigate here, please? Irrigate there. Okay, now we go ahead and remove the Kawase completely. Remove everything. This is the petroclival meningioma anatomy. Fifth, sixth, Fourth, brain stem. Fifth nerve, root and rhizome. This is what you need to do in a petroclival meningioma. Okay, all of you. Now we are going lateral to the fifth nerve into the brain stem. Lateral to the fifth nerve. Come, let's show me the drill now. Hold the drill, please. Hold it here. Yeah, that's right. Yeah, thank you, thank you.
Okay, once again, we lost the sound. That's usually a sign of Wi-Fi.
Yes,
That's
John?
not. Yes, we lost
Okay.
the sound again. Can you hear me, Abby?
Yeah, I can hear you.
Okay. So we're using two inputs, right? Two HP inputs. That's the problem, right? Let me unmute one HP. See that?
Babar ko bulao, Babar.
Okay, there we go.
ही लीव मीटिंग करता
Lord Secretary.
मीटिंग का
Height of the? No, ठीक है. I'm having to look up like that.
We lost HP.
Yeah, sorry.
That may have been the sound. No sound, Abby.
So that is a V3. And this is the carotid canal. This is the carotid. This structure. And we have reached, this will be the posterior fossa dura, the cochlea. Drill now. Yeah, will you hold it up, please? We are going towards the clivus. We can even go a bit behind the IAM. You can see the IAM dura now. That's IAM dura. I have opened the IAM dura. So the IAM dura will lead on to the posterior fossa. That's IAM dura. You can drill above that to get to deroof the IAM completely. You must remember that all the semicircular canals are posterior to the IAM. So that's IAM dura open. You will see the facial nerve now. That give me a dissector, small dissector. That is a sorry. That's a facial nerve. Can you focus there? So that is a IAM dura there. That's a facial. Can you see the facial nerve there? This one, that white thing.
Yes.
John, can you see that?
We can see it, but occasionally hear it.
Yeah. Okay. So that is a facial nerve. Can you see that?
Yeah, it's good now.
I'll make it much more clearer. So I have to remove off this piece of the. Give me that scoop. Give me scissor first. So I'm cutting along the. Scoop is ready. Oh, it's impossible. It's too short, and it's too big. Okay, drill now. Drill now. Do you have a diamond? Hold this up. Do you have a diamond? Huh? Acha, no problem. Irrigation. Okay. Irrigation. Posterior fossa dura. That's a posterior fossa dura. Posterior fossa dura is cut. This ligament is cut. Scissor. Can somebody hold that? Yeah, hold that dura off.
No, darn it, the laptop was working. Okay, we're frozen. I don't know if anyone can hear me. We're frozen. The MP. Okay, well, you're off. Okay, he'll come back. Are you there, Abby? Are you there? Maybe Joanna, can you fix it? Abby, can you hear me? Okay, the presenter fell off, obviously. Okay, Abby, are you there? Is anyone there? I think the presenters are trying to get in. Yeah, there are some Wi-Fi issues, which everyone can understand. But if we're gonna do some broadcasting from this place, we gotta upgrade the game.
Hi, John.
Yeah. Okay, you're back. Hey,
It's me.
Joanne, how you doing?
No, it's me. No,
Okay.
it's me.
It's
I just
only
wanted
you.
to say
It's only
something.
you.
It's only me. How
Well,
are you?
you're important. Don't feel like you're not important.
No, I just came to.
Be
Now
proud
it.
of
I think it continues now. By the way, I can hear something. Okay, catch you later.
Okay.
John, can you see us now?
Yeah. I can hear you, Abby, but I can't see you yet.
Just a minute. Just a minute.
Yeah, there we go.
Okay. So he's drilled off the bone of the petrous apex, and he's now in the posterior fossa. So you can see the superior cerebellar artery there. He'll show it again.
So that is the seventh nerve. That's the IAM dura open. That's the seventh nerve. You see the basilar there. You see the pons anterior to the seventh nerve. Are you seeing the seventh nerve clearly?
Is anyone seeing the seventh nerve clearly?
See, I focused on the seventh nerve.
John, are you seeing it?
Can you see the seventh nerve?
Yes. Can you hear me?
Yeah.
That is the seventh nerve. It's the basilar. Okay. Ica, you will see there. It's the fifth nerve. You had a mishap, I think. This branch has got caught in the drill. So that's the superior cerebellar artery we'll have to probably clip off. So that's the pons, superior pons. That is the posterior cerebral artery. Just have to show you the sixth nerve. That's the sixth nerve. Focus this for me. No, not focus. Focus. No. Leave. Leave. Yeah, that's a sixth nerve. That's a sixth nerve. That's a fifth nerve. So that's arachnoid, where you will find the posterior cerebral artery will be within this arachnoid. Superior cerebral artery will go like that. The fourth nerve is here. So below the fourth nerve, the superior cerebellar will go. Above the fourth nerve, the PCA will go. We will find out the PCA. Need a lot of irrigation there. That's a third nerve. All right. You can find the fourth nerve, the sixth nerve, the fifth nerve, the seventh, eighth complex would be here, Ica and basilar. Okay. Ica and basilar is there. So, people have not slept off, then we've seen the entire range from second nerve to third nerve to fourth nerve to sixth to seventh, eighth, brainstem, fifth nerve, the ligament complex between the fifth and the sixth nerve cut. So go ahead, Nilesh, have a look at things now. Abida, you probably can scrub in and have a look. So extended Kawase not completed. Kawase completed along with Dollars.
Hello.
Yes, are you speaking?
Hello.
Yes. Can you hear me?
Hello.
Yes.
Yeah. John, can you hear me?
Yes, I can hear you now. I
Okay.
can't see you.
Can you
They're
see the
gonna take
screen?
one. I can take one or the other. No, I can't see the. I cannot see the screen.
Okay, screen. Screen नहीं दिख रहा. Just a minute.
There we go. I got the screen.
Okay, okay, just a minute, John.
Okay.
0 0 0 0. Okay. Focus. Yeah, okay.
Picture's good.
Yeah, okay. So we'll just review the anatomy again. The type is dissected. So let's suction बंद है. मेरे हाथ में कुछ दे. कुछ भी दे. Action दे. So we can start from here again. You have the optic nerve here, the internal carotid artery here, the third nerve here. Focus.
I'm sorry to bother you,
Can you
Abby,
see
but
that?
no, we cannot, unfortunately. There we go. We
Can I
got
see
it.
the screen?
Yes, we got it.
Okay, okay. Okay, so we start again.
Sure,
Here the
please.
second nerve. This is the second nerve here. Then this is the carotid artery. This is the third nerve. This is the fourth nerve. This is V1. Now as we move behind, there is the membrane covering the fifth nerve. If you lift this, you can see all the branches. This is the V1. This is the V2. This is the V3. This is the region of the Gasserian ganglion and Meckel's cave, which has been removed now. And you can see how it is going into the posterior fossa here. The bone here has been removed and entering the brain stem. You can see it beautifully here. This is the entry zone of the fifth. And then here you can see the seventh, eighth complex and basilar artery, which is here. Some part of the superior cerebellar artery you can see here. We missed the sixth nerve here. So after the fifth here, you can see the sixth nerve here. And we'll see the course of the carotid here. You can see that here. And on the carotid canal, yeah. So this is the region of the petrous apex, which has been completely drilled, as you do for a Kawase approach. And this will be a region of your cochlea. Yeah. You can't see the carotid, right? Huh? Where's the carotid?
Carotid is just lateral.
Can't see it. Yeah, yeah, okay. But I can't see it clearly.
No, I haven't cut the membrane.
Okay, okay, okay. So the carotid will be in this region here. In this region here.
No, lateral.
Yeah, yeah.
That is the
Yeah, okay. No, I can't see it.
You can remove that.
No. Okay. And I think that's the, go all the way down to the cisterna magna, I think. Yeah.
For one day enough this.
Yeah, I think so. And from here you can see the carotid and the basilar from this angle. Okay. You can see the branches of the carotid here. You can see the PCOM here. Yeah, anterior choroidal next to it here. Going posteriorly. That's the basilar there. Now you can see it more clearly. With both the PCAs. Yeah. I think the whole skull, the whole range is open now. Yeah.
You like this approach?
Yeah. Okay. Want to see?
Everything is seen up to 7.
Is the screen frozen? Well, no. Okay. Spoke too soon.
John, the plan is 4 o'clock I think is Hira here?
She stepped
Yeah.
away. Okay.
Yeah, yeah, I'm here.
My God. That is tremendous
Hi.
stamina, Hira. So
Okay.
we're going to start the lectures at 4, right?
Yeah. So we'll have
Uh,
Franco first.
okay. Franco Servadai, the president of the World Federations, will start off with his address.
Yes.
So after that, we'll have Hari Chandran. And then, Hira, will you just give a list of dignitaries who are going to speak? And 6 o'clock, Luis Borba is going to tune in. And I have my
Okay.
lecture sometime today, right?
Yeah, I think you are giving a lecture right after Franco.
Okay.
Yeah. So let me just give out a list,
Yeah.
and then yeah, just give me a moment.
That's a Pons, Nilesh.
Okay. How long from now are we going to be broadcasting the webinars?
45 minutes later. 45 minutes later. Starting
Okay.
45 minutes later.
Okay.
So now Nilesh and Shashwat, they're going to keep on doing the dissections. You're going to have food. So Shashwat and what is your name? Aditya and Shashwat will keep doing the dissections and discussing. And you guys are going to move to my office. Pramod, I'm going to move to my office, and once they are finished, you can shut down shop and then you can carry on. All right. Right. So,
I mean,
today anterolateral corridor has been done, and tomorrow we're going to Abhida is going to do the C1 C2 exposure, and once that is done, we're going to do a small craniotomy, and we'll do the far laterals, extreme lateral, and all the variations. That is the idea for tomorrow. And tomorrow will be the spine lectures, WFNS spine committee lectures on trauma.
that is, yeah, that is a little late in the evening. So
Yeah.
for today, we have Franco at 4. You will be after him, and followed by Dr. Abida. Then we have Manas Panigrai. He is going to be giving at around 5 p.m. Then we have Chandra Shekhar Dio Pujari. He's at 5:25. Professor Atul Goel after him. Then Raghunath Kandasamy. Then Hari Chandran. Then we have Sabarish, because it's going to be early morning for him.
Yeah.
And then we have Wang and Victor.
Fantastic. Right.
So I mean, if in case I just fall asleep, is there anyone who can look into the program?
I guess Nilesh would be able to chair the program. Nilesh
yeah,
will be doing the
because
chairing.
I'm not sure how long I'll be up now. It's 2:45 now.
Okay. Thank you so much, Hira. Thank you so much for putting up
No
with
problem.
this.
No problem.
And
I'll try my best to be up as much as I can. But if I fall asleep, I think Nilesh has to back up now.
yeah, sure.
Okay.
We're moving to the office right now very soon.
Sure.
Nilesh is also going to go for food, and Shashwat and Aditya is going to continue on with dissections for some more time till we start the other lectures.
I mean, I'll you can just call me if anything goes here and there, so I'll be there.
Right.
Okay.
Thank you so much. Thank you so much.
Bye-bye.
And thank you, everybody. Thank you for attending this. And I hope today you had a very good understanding of the anterolateral corridor. This is the anterolateral corridor, which is used for practically all ACOM, PCOM, IC bifurcation, transitional aneurysms, basilar aneurysms, superior cerebellar aneurysms, petroclival meningiomas, cavernomas, trigeminal neuralgia, whatever you can think of in your mind, this corridor can be used. You could even take out a small vestibular schwannoma. I showed you the 7th, 8th. I drill a little bit behind. This is the William House approach, middle fossa approach. So we've covered a lot of skull base, and we're going to come back tomorrow and cover it from posteriorly. Thank you very much. We're signing off from the dissections. We will be going ahead now with the talks. Franco's talk after 45 minutes. Be tuned in for that. Thank you very much.
Okay.
Thanks, John. So I'll catch up with you at around 4 so that we can set up from Dr. Ipe's office.
Okay.
All right. Okay. Bye.
Good night. Hey, Joanna, you still there?
Hi, John. Hi, John. Are you okay?
Yeah, yeah. Oh man. Oh, I tell you, these nights, I'm just, not used to these nights.
I can understand it.
Well, you know what it's like.
Yeah.
It's a different way of living. I mean, you've got to, you know, get sleep, like change your sleep hours to get ready. But that's hard to do sometimes.
Yeah.
And so you end up just keep going on without sleep. But
Mm.
it'll be all right. So now, do you really think residents get something out of watching something like this?
This is amazing. Yeah, I'm actually.
It's good.
Yeah, it's really good. I'm actually just sad because I don't have today the possibility to observe the whole thing because I'm at the current moment also on call. So that's why. But otherwise, really good. Nothing against.
It is
really
okay.
good.
That's
Yeah.
good to hear. So it's worth it. Okay.
Yeah, definitely.
Yeah, I was beginning to think that. Well, there's so many stoppages, et cetera, and problems with sound. We'll get better. We should have prepared better, actually, to do a sound check. But people never want to do that. They never want to check ahead of time. Because certainly I don't see a neurosurgeon going into an operation using a machine he's never used before.
That's true.
They take,
you have a point.
they work with it, they play with it, they test it. But it doesn't apply to broadcasting. It's the last minute. But we could have done much because obviously the Wi-Fi is poor. So they're really going to, if they want to, because I think I wants to turn this into a teaching center. They're going to need better bandwidth. Period.
Yeah, it will. If that is the plan, it will definitely evolve. There's no reason why that shouldn't happen. So
it
it's
will happen. It will happen.
Yeah, but
we'll
it's
just try
really
to push it along. We'll try to push it along.
Yeah, really nice idea, this whole thing. So really happy these sort of things is happening at the current moment still.
Yeah, well that's good. But people from other countries that can't go to labs, you think they'll get something out of this, right?
Definitely.
Good.
Yeah.
Good. Because the majority of people I think are watching probably don't have any access to labs.
Exactly.
And probably have never dissected a real brain. Probably most people, because there are not many centers around the world to dissect the brain. Now, I'm sure in Finland they had some good places to train, right?
There is actually there is. You're doing this quite early on pathology. You're doing it already. But I get your point that there should be more this sort of like a more bigger cadaver labs. Those are definitely needed.
Yeah, we definitely need them. Hello, Corrado. Good morning.
Morning.
How you doing? Oh, should I call you Louis?
Yeah.
Well, you two you're with your wife in the picture. He's in his wife with his wife in the picture, and when you look at it fast, I said, well,
Mm-hmm. And
that's why I got you confused with Louis, because on your what's up, the picture you have is with your wife, and he has a picture also with his.
You confuse me with Louis. Okay.
Yeah, because of the picture and what's up. It's just very similar.
Mm-hmm. Yes, it's very similar, but I'm not so similar to Louis.
Oh, okay. Well, tell him that. So how you been? When is your conference at?
My conference?
ICRAN, right?
ICRAN, yes. My conference should be next 15 minutes, not?
No. Don't you have a conference in Italy? A conference in Italy?
ICRAN is webinar, virtual, but it's not in Italy. I mean, the ICRAN is the WFNS Trauma Committee Conference.
Okay.
Is organized by Global Neuro.
Oh, okay. So it's the same as you had before?
Yes, the same that we organized from Naples, remember, 2 years ago.
Yeah, trauma. It was mostly trauma, right?
Mm-hmm. Joanna, good morning.
Okay, is anybody else here? We don't start for a bit, right?
We should wait for Franco Servadei.
Yeah. Okay, so I'll be back. I gotta step away, okay? Oh my God. Oh my God.
What?
Superman is here. Joanna, you get to meet Superman.
Joanna is there or not?
No, Young Hong Wang. He's from China. Young Hong, are you there? Hello, Young Hong. Oh, Andrea. Wow, Andrea. Another Italian neurosurgeon.
Hello, John.
Hey, how you doing?
I'm fine, thanks. How are you?
I haven't seen you in a while. Yeah, do you know Corrado? Corrado, yeah,
Yes.
Karina? Yeah, okay, there. Corrado,
Yes.
you know Andrea, right?
We know each other very well.
Very good. So things in Italy getting locked down again?
Yes.
Yeah.
Day by day, they close.
Yeah, I think most of the world is the same. It's most of us locking up again. And you're in northern Italy, right? Northern? You're up in Milan?
Yes,
area?
not on Italy.
John, my video cannot open.
Hey, Young Hong, how you doing?
Yeah. Good, very good.
Wait a minute, you're Superman. You should be able to do that.
You Superman also. My video cannot open, and I don't know what.
Okay, go to the bottom left corner of your screen. The bottom, it says mute and stop video. You see the bottom left of your screen?
Yes.
It says that there's a picture of a microphone and a picture of a camera. Okay, you have to click on the camera. You have to open it up. Do you see that part?
Maybe there's some problem.
Are you on a Windows, Apple?
Yes.
Which one?
Let me try.
Are you on Windows or Apple?
Apple. Windows.
Windows. Okay. Yeah, it should on the Zoom platform. It should be at the bottom left.
Yeah.
You see it?
Yes.
Okay.
But cannot open.
It cannot open?
Yeah. Let me try. Let me restart.
Okay.
It's John that mute me.
Yeah, we usually mute everybody, Corrado, that's not talking, but like background noise will bring the camera to your camera.
Hey, John.
Yes. Hey,
I'm here. So
good. Okay, Corrado's here, and I think did Franco come yet?
Corrado is here?
Yes. Hi, Franco is there.
Hey, I'm here. Yes, Franco, good to see you. we had a fantastic dissection where we showed the entire anterolateral skull base approaches along with the petrosectomies and all that. That was not very pertinent to trauma, but that was showing them how to go ahead with cystonostomy, the anatomy of cystonostomy. So we would wait for your, 9 more minutes and we can start your talk. And in the meanwhile, if you guys want to say anything, including Wang or you or Corrado want to say anything, you're welcome. So, the theme of this talk is about the whole conference is about trauma, past, present, and future. Now, I believe that microneurosurgery alone in trauma is not going to help. I understand that we need to have the best ICU measures also, which are going to help. So, but not all the fancy, but whatever can be done in the developing countries. So maybe Corrado can also help us with, Wang has been doing both together. So Corrado can help us with formulating a bit of a protocol where we do microneurosurgery as a proactive measure, not like DC. We do it as a proactive measure. Also, we can go ahead and get the best ICU treatment. So we have the best of both worlds. For that, future should be getting the best out of both worlds. Getting microneurosurgery also into trauma and I believe, as a surgical treatment, it's proven not to be very effective. So the conservative management developed a lot. So now that microneurosurgery is getting introduced into trauma, we can get the best of both worlds. That's what I think. So I would like to have your perspectives and your opinions on that, both Franco Corrado as well as Yong Wang. So, and every other panelist who are around, because this is the world's problem, trauma, and we need to deal with that.
Well, my opinion, I think you're right. We need, the surgical treatment of trauma needs all possibilities. Decompression, cystonotomy, hinge craniectomy, everyone should have one place. The problem is that at the moment, we don't have the right place for each surgical approach. In some areas, we do more one, in some areas, we do the other one. So we need to do it together in a way in which in low-income countries, we give the possibility not to replace the bone, avoiding it, not in every patient, in some patients, but we need a structured study which shows which are the indications for one, second, and third. I think Corrado is working on that. We are trying to get from Europe a funding, money to do that study. And Corrado will explain to you it's on the way, the possibility to get some funding for getting a real study on surgery on trauma, which opportunities and which techniques we have. Corrado, if you want to say something.
Yes, of course, there is a possibility to have a funding from the government for academic study. And as you know, the first problem is the indication, the selection. And so I think that we have to start to compare the cystonostomy with the decompressive craniectomy. But not in all patients, but in a subsetting of patients. Maybe we could start with the patient with temporal contusion or patient where the decompressive craniectomy could be indicated in an early stage. because we are agree, you and me, we are agree that cysternostomy is a proactive procedure, and so we have to search to compare cysternostomy with the patient where also decompressive craniectomy could be proactive. And first of all, and as you know, as I told you, we have also to define that cysternostomy is a safe procedure. And the safe procedure in hand of a skilled surgeon. Also, decompressive craniectomy needs a surgical skill. And we know the report in literature where the failure of decompressive craniectomy depending on a wrong procedure. The simple size of decompressive craniectomy has a dramatic impact of outcome. Also decompressive craniectomy is not a surgical procedure left in not skilled hands. So for the randomized trial clinical trial, maybe we should start with a setting of patient where we define the safe of cysternostomy and the effectiveness of the cysternostomy and the compressive craniectomy in that patient. Maybe the results of rescue SADH could help us in this selection. But I think that now the time is good to propose RTC. What do you think?
Yeah. See, RCT has to be done by somebody who is on the transition point from DC to cysternostomy. Whatever I feel right now, see, when I remember trying to tell Roy, trying to tell Wang, trying to tell Parthiban, telling them that, see, listen, cysternostomy is good and the decompressive is not good. I remember the reactions in the beginning. They were telling me, no, you cannot say like that, and DC is equally good. And now they are staunch believers. Now they have, once they've started cysternostomy, they if I tell them, okay, do a trial, I don't think anybody's going to go do a trial, because they, I mean, you can say in scientific language they are biased, but when you see a better treatment, when you see much better results, you definitely don't want to put your patients into a scenario where you're consciously harming them. So this is the problem. This is the problem with me. This is the problem with all the guys that we converted. Everybody, see, Roy, I remember how much of a staunch non-believer he was. Parthiban, Wang, Goi, Nikolai P, all the guys, even my two consultants. And here I have just joined in Krishna Institute, Karan. The two consultants here, they will present their experience. They have told me clearly they don't want to do any more DC. So this is the problem. So if you ask Andrea Girosa was with us. I mean, he's your boy. So Andrea, I think Andrea is here. And yes, if he will tell you why a randomized control trial will not work, because a randomized control trial, anybody who's comfortable with cysternostomy will not do a DC again. So this is my problem, and this is everybody's problem. So we have to do it with two others in an institution where one is doing a DC and one is doing a cysternostomy. This is what we are trying to find. So I would like, Dr. V.D. Sinha is also here, and Ramesh Nair is also here, and Andrea Girosa, if he's here, Andrea or Yong Hong Wang. I mean, I would like to know your opinions on what I just said, and then Franco and Corrado can go ahead and tell us what we can do for that.
You ready to start, Abe?
Yes.
Chandra's here too also. Okay, you just got here. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach, home of Neurosurgical TV. We have the honor of hosting the Krishna Institute of Medical Sciences Cranial and Spinal Trauma, Past, Present, and Future, headed by Ipe Cherian. Good morning, Ipe. We'll let you take over.
Yeah, today it has been an honor to have titans of world neurosurgery with us. So today, after the skull base dissection session, which started at 9 and lasted till now, where we went ahead and showed everything from second nerve to seventh nerve and approaches for everything from cystonostomy to right to petroclival meningiomas. We showed that. And then now we are going to host Franco, the WFNS president, Corrado, Dr. Chandrasekhar Dipujari, and all the Ramesh Nair and many more titans of neurosurgery. Vlad might join. Yong Hong is here. Yong Hong Wang is here from China. So all of these people, they'll be talking, and it's going to be an interactive meeting where you must understand that it's not like a basilative aneurysm which you see once in a while or something. Trauma is something that all of us see. All of us have experience. From the junior most to the senior most, we all have our experience. We all have our perspective. So it is going to be a very interactive meeting. And everybody, we are going to have friendly discussions. We are going to have, friendly arguments. And at the end of the day, the whole point is to learn from each other. To learn from each other, to understand the perspective of each other. And if somebody is not doing a cystonostomy, I'll ask them why when they tell me why not, I will understand, because all of us, every one of us wants the best for our patients. So now I invite the president of the WFNS, the World Federation of Neurological Surgeons. I invite Franco Sarvadai, a very good friend, and a very good friend, for his talk and his address, inaugural address on this meeting.
Good morning, good afternoon. As is middle of the day, for you is afternoon. To our Chinese colleagues and Japanese, it's later. So we are now used to this form of communication. Unfortunately, the pandemic closed all the borders, and we are talking via webinar. I don't think I have written an editorial for the Journal of Neurosurgery. I don't think that all this is negative. We have realized by speaking in many webinars that the webinars allow a lot of people who are not able to come to meetings, like they didn't have the money to travel. They didn't have the money to pay the fees for the meetings, to participate actively to the webinar. The webinar are democratic. Everyone can come from. I can read you a recent webinar we had on neurosurgery and COVID. I can tell you, I have in front of me the comments from Yemen, Tanzania, Vietnam, Cambodia, Sudan, Libya, and Syria, just as an example. In this country, you cannot travel anywhere, but they have the possibility to actively take part of the webinar. So we think positively. We will never forget this experience. When we start again meetings, one part will still be on webinar because we can reach all over the world. Trauma, which our friend Ipe Cherian put today as a topic, it's the first cause of surgery all over the world. In some low and middle income countries, surgery for trauma, combining brain and spine is almost half of the workload in neurosurgery. So it is important, and it is important in this period because we have to fight, for instance, in the European countries, to keep trauma surgery alive during the pandemic, because it is always a question of location of intensivists, of anesthesiologists, of neurosurgeons to open more and more and more facilities for COVID patients. But we have to understand that we have to keep our surgery alive in the field of trauma. We have to think that usually when we talk about nice surgical techniques, trauma is out. Because we think that trauma is not a surgical field. Actually, trauma is the most rewarding surgical field because we can save the life of patients who are in very bad conditions by using different techniques. What I said to you before, there are two issues here. One issue is the incidence of trauma, which I told you. The other issue is surgery for trauma. We do have the opportunity of decompression. Decompression has been shown to limit the mortality, but increase the morbidity with a large number of patients who are not able to take care of themselves, which are handicapped. This is clear for any kind of decompression, for trauma, for ischemia, for anything. Then we have new techniques like cystinotomy and like hinge craniectomy. Since trauma is more frequent in low and middle income countries, countries with limited facilities, we need to do randomized studies in these countries, or at least a part of these studies should be done there, where the conditions are different. But we have the data that only at the moment in neurosurgery, only 7% of all randomized studies are done in this country. All the others are done in US or Europe. So first issue, we need to shift our studies to the countries where trauma are. Second issue, no religion, that trauma care is not a religion. So I cannot, we cannot say that we have to do like this or this. We are open, but we need proofs. We need to show the people that we are enthusiastic. We want to cure trauma patient. And one method, it's impossible that the same surgery will be fitting every patient. We need to understand which is the best surgery for a subset of patients, where is best decompression, where is best cystinotomy, where is best hinge craniectomy. So we have to do studies who are not the usual randomized clinical study in high income countries where the resources are different. We need to plan a study who is fitting one part of the world where trauma is an endemic disease. And this is a task for many of us. We are very open and we want to do it. We want to show the world that we have in our hands different techniques for different solutions. And this is important. I wish all of you, unfortunately, I can't be with you only half an hour, and the first speech which I should do, Corrado will do it, obviously sharing with me the presentation. I will be with you about half an hour, 45 minutes, and I have other business in the hospital. Unfortunately, in Italy, we have new pandemic, very high number of admission in the hospital, and we are quickly reconverting again our activities. The disaster of March is again with us. It's different, but it's again. So we have a lot of things to do. But I wish all of you a fantastic day and a very good teaching. Thank you, Ipe, for giving us this opportunity.
Thank you, Franco. Thank you so much that you came. It's very
it's a very great honor to have the president of the WFNS coming and addressing the meeting. We, from Krishna, we are very proud that we could host you, and thank you for coming again.
Do you want to introduce Corrado?
Well, I'll introduce Corrado. Corrado is a dear friend. He is a giant in when it comes to trauma surgery. We differ sometimes, we fight nail and tooth, but Corrado is my brother. Make no mistake about it, okay? There are people whom I like or whom I don't like in trauma surgery when it comes to different perspectives, but Corrado is somebody I completely agree with, along with Franco, this group, because they've been the most understanding and the most helping people to get the change done, unlike a few others whom I would not want to mention. But and Corrado is going to host the ICRAN again next month, and we hope we can have a fantastic ICRAN meeting this time as well. So to one of my very good friends when it comes to trauma neurosurgery, Corrado Lacarino, my brother, please start.
Thank you for your works. Thank you for your words. This friendship starts in Rome more than 4 years ago. We fight before to discuss, and after we have a nice discussion. And now we reach a high level of according in many topics. Not all topics, but now we can work together. And so also congratulations for your new adventure in Krishna Institute, and hoping that we can work together also in this way. My topic is the epidemiology of TBI and TSI. This is my disclosure. And the epidemiology of traumatic brain injury is changing in this last period. And the falls now surpassed the road traffic incidents in the leading cause of this injury. And the main characteristics is that the population is older and usually fall. And so we assist mainly to contusion and chronic subdural hematoma. This is the changing of pattern of epidemiology of TBI. This is a cross-section analysis from Europe, from Andrew Maas group, and it's reported that 1/3 of patients have more than 65 years. And also a similar report from US, where the 26.5% of all TBI-related deaths has more than 70 years. And also in this case, also in US, 1/3 of TBI hospitalized population is old population, more than 70 years old. Also in Italy, we observed this pattern, this trend at the beginning of the last decade. And so the death due to traffic accidents is decreasing, and is increasing the death due to falls. So if we get an analysis of the global incidence of TBI, still road traffic injuries is the main scenarios. But it's clear that policy of prevention in high-income countries allow a reduced number of TBI due to road traffic injuries. And so we have to apply a similar policy of prevention to protect our old part of population to avoid these increased number of TBI for people with more than 65 years of age. And the same changing of epidemiological pattern is observed in spinal trauma. This is a 30-year review from US where it's reported that the motor vehicle accidents reach 1/3 of spinal trauma population, but the fall is reported in 20% of population. And what is interesting to note that the incidence of spinal injury is higher in the population older than 50 years. And also the incidence of spinal cord injury is high in this part of population. So they observed that the spinal cord injuries is reduced due to motor vehicle accidents, mainly for the prevention policy of traffic regulation, but the spinal cord injuries is observed in the elderly population. So similarly to TBI, there is a dramatic decrease of spinal cord injury rate in all the TSI population, and a similar decreased spinal cord injury rate for motor vehicle accident. But once again, for trauma not related to traffic accident, there is a worsening in clinical condition. And TBI is particular also when we, the epidemiology of TBI is particular also when we observe a particular environment, like in Iceland, in this 30 age time of observation, that once again, falls is an increased cause of TBI, TSI, with incomplete cervical lesion due to falls among elderly. But it's also interesting how in this part of the world, the TSI, the traumatic spinal cord injury due to sport like ice hockey, it has a high number of cases. The spinal cord injury incidence is the real problem. To calculate the spinal cord injury incidence in the traumatic spine injury is very difficult. Like is reported in this huge register of German Trauma Society, where a spinal cord injury is reported each 13 patients. But it's interesting to note that despite the high level organization of the German Trauma Society register, the incidence of spinal cord is not well understood. And the spinal cord injuries, when we analyze the papers about epidemiological data of spine trauma, the spinal cord injuries is the main issue reported, because if the patient are injured with spinal cord, are admitted in hospital, and so they could be much more better recorded. Like in this huge paper of from China, where the number of traumatic spine injury is increased in the period of observation. And it's interesting to note that when the traumatic spine injury affects cervical spine, so the patient has more complex and in the worst condition. Otherwise, usually the fracture is the main lesion reported in thoracic, lumbar, and sacrococcygeal vertebra with a low grade of spinal cord injury. China is an interesting region because we can observe even high income areas and also low or middle income areas in the same country as China. So it's different to see that the data is mixed, because the age of population is not so old, but is not so young like the low middle income countries. So the age range is from 20 to 60 years. But it's much more interesting to analyze the cause of trauma, because we have the same falls as the main cause of traumatic spine injury. But it's interesting that in a country like China, the causes is balanced among motor vehicle accidents, high falls, and the trivial falls is less represented. So in a country like China that can have a mixed environment like high-income countries and low-income countries, falls and motor vehicle accident are the two major causes of spinal trauma. And also here is mandatory to have a surveillance and policy of prevention, even for traffic, even in the industry for the work environment. Much more difficult in countries like Tanzania in Africa, where it's difficult to collect data. So, for example, in this report, they calculated just the patient referred to the place of care, and it is interesting to note how the age is lower, with the high grade of AIS grade A. So the patients are younger and are with a worse clinical condition and worse neurological condition. It is interesting to note how the limited resource has an impact on the management, on the treatment, and on the choice of which patient have to treat. Similar observation also in Ghana, where the elderly is very rare in spine trauma, but there is a high grade of ASIA impairment scale A. And once again, the road traffic accidents is the main cause of traumatic spine injury. So even here in this environment, the structural public education and enforcement for road safety measures are imperative. It's clear that the difference is the policy of prevention, because in LMIX experience nearly 3 times as many cases of TBI due to road traffic accidents. And the reason, because the people are younger, because the habit of life make a very dangerous risk of this population. So the impact of a limited resource on trauma system is the less prevention. And do the law help a neurosurgeon? Of course, this is a report from Taiwan, where is analyzed in 10 years the incidence of traffic accidents. We see how after 10 years there is a reduced rate of traffic accidents because after following the helmet use law and driving law, we can assist a dramatic reduce number of traffic accidents. Also in Italy, for example, when we adopted the helmet law, we assist a dramatic decrease of rate of admission for TBI in neurosurgery unit. This is a report of modeling with what will be the traumatic brain injury in Africa, and it's clear that the traumatic brain injury is related to traffic injury in all parts of Africa, with the consequence that they assist mainly to epidural and acute subdural hematoma. And for this reason, in this study, when we compare the compressive craniectomy for TBI in low-income countries and high-income countries, there is different. There is a difference in terms of mean age, with the difference is the younger people in the low middle income countries. There is a difference also in incidence with the number of decompressive craniotomy for months is difference much more higher in the low and middle income countries, and low number of decompressive craniotomy per month in high income countries. Is interesting to note that where there is the higher number of decompressive craniotomy in the report are more old. I mean, in the first part of the beginning of this century. What is clear, what Professor Servadei said before, that we have a discrepancy because we have a lot of paper published where the trauma is not so high representative. I mean, where the trauma, even traumatic brain injury, even traumatic spine injury is endemic, we have a low rate of publication. It is two papers from the group of Professor Servadei, where it's clear how is different the ratio between the volume of publication and the volume of the trauma. And the epidemiology so have an impact of clinical impact. So we can conclude that in high-income countries, the patients are older. Usually, the traumatic brain injury and traumatic spine injury is due to domestic faults and not for traffic road accidents. Contusion and chronic subdural hematoma are the main representative lesion, and cervical spinal cord injury is the main represented for traumatic spine injury. Differently, in low middle income countries, the patients are younger with traffic road accidents is the main causes. And when they fall, they usually falls during the work and not at home. And so epidural hematoma and acute subdural hematoma, so the emergency neurosurgery is required for TBI, while for TSI, we assist a much more worse clinical condition, a much worse problem to recover this patient. The crucial difference in epidemiology reflect a crucial different management because due to the limited resource, where there is a difference in time and surgery, there is a difference in monitoring. Of course, there is a difference of collecting data and to have a epidemiological report with high level. But this difference should take in consideration that it seems that low middle income countries cannot follow the guidelines, but it's well known that also in high income countries, these guidelines is a conflicting issue because we do not have a solid evidence for these guidelines. So there is just one solution, as we told before, and as Professor Servadei said, that we observe the life for the solution and we have to collaborate. We have to collaborate, and there is just clear evidence of this collaboration. WFNS established several full training centers. The consensus conference that are published in these last years, where the surgeons from limited middle and middle income countries and high income countries are put together to find a common solution, and of course also peer-reviewed journals encourage publication from LMICs. And all this kind of collaboration, we can also assist in the next big conference about trauma, is the ICRAN, and so we can continue to share our knowledge, to share our experience. Thank you.
Thank you very much, Corrado, for a fantastic talk. Now we must call Abida Shah for her talk on the microsurgical anatomy of cisterns. Abida, are you there?
Yes, I'm there. Just a minute. Just a minute. Yeah, okay.
Sorry. Can I say hello to everyone because I have to leave? Thank you so much and good work for everyone. Sorry.
Thank you.
Thank you so much, Franco. Thank you so much for coming.
May join you later. Thank you so much.
Yes, Franco. Thank you.
Okay, can you see my screen?
Yes.
Yes, we can.
Okay. So today we've seen a lot of dissection in the morning, those who were there, and we saw a lot of anatomy of these cisterns, subarachnoid cisterns, while doing the skull base approaches. And it is very essential to know this anatomy because it is essential for all skull base approaches, especially also for trauma, as Ipe says in his cisternostomy. So basically, the brain is covered by pia mater, above which is the arachnoid, and then the complete thing is surrounded by dura. So the subarachnoid space lies between the arachnoid matter and the pia mater, and it is run by a multitude of trabeculae, and that's why it has its name, arachnoidea, which means a spider, like a spider web. So that's why the name arachnoid. And basically all the cisterns of the brain, they follow the fissures of the brain, and ultimately all the basal cisterns open into some area of the lateral or the interhemispheric or the transverse fissure. So this is the main lateral fissure of the brain, which incorporates the sylvian cistern, and a lot of basal cisterns confluence in this area to join the sylvian cistern. Then you have the interhemispheric fissure, along which you have the callosal cisterns, pericallosal cisterns, and the lamina terminalis cistern in this region. And of course, on the medial side, you have another fissure, that is the transverse fissure of Bicart. And this fissure actually extends from the anterior perforated substance all the way back to the quadrigeminal area. And it is covered medially by the parahippocampus, superiorly by the pulvinar of the thalamus. And it has two limbs. It has a lateral limb and a medial limb. So basically it is a horseshoe shaped, which on the lateral aspect of the hemisphere appears as the choroidal fissure, and on the skull, on the medial aspect of the hemisphere, it forms the transverse fissure of Bicart, which has all the other basal cisterns. So these are the boundaries of the transverse fissure. As you can see, they are completely similar to the boundaries of the choroidal fissure. So medially, they are bounded by the, laterally they're bounded by the parahippocampus, the dentate gyrus, superiorly and anteriorly by the pulvinar of the thalamus. Then the median lip has the velum interpositum here, and anteriorly you have the optic tract, and about below that the anterior perforated substance. So as you see the cisterns in the transverse fissure, they all open into the choroidal fissure ultimately. And if you enter the choroidal fissure from the body of the lateral ventricle, you will enter the cistern of the velum interpositum, that is formed by the median limb of the transverse fissure. If you enter from the temporal horn, you will enter the ambient cistern. And if you enter from the atrium, you will enter the quadrigeminal cistern. So this is just an overview of the cisterns that follow the fissures. Now we look at them one by one. So this is a cadaveric dissection showing the frontal and the temporal lobes with the sylvian fissure in between. So the contents, the sylvian fissure is divided into two parts. You have a anterior part or the sphenoidal part, and a posterior or the lateral part which opens on the cerebral hemisphere. So once you separate the sylvian veins, you can enter into the proximal part of the sylvian fissure. So the sylvian fissure is divided by a series of membranes. You have a lateral membrane, a medial membrane, and an intermediate membrane. And these membranes separate the constituents of the sylvian fissure. So most superficially, you have the superficial veins, which lie close to the cerebral surface. Beneath that, you will have the M2 and the M3 branches of the middle cerebral artery, which are constituents of the middle part of the sylvian cistern. And proximally, in the sphenoidal part of the sylvian cistern, you have the middle cerebral artery as it turns in the region of the M1, region of the Lyman insulae, as it turns from M1 to become the M2 in this region. So this is your proximal sylvian cistern. Now you can see here very clearly that this is your carotid cistern, and the carotid cistern ultimately opens into the sylvian cistern. They are all bounded by a series of membranes that may be present in some, that may be absent in some. If they are dehiscent, then the confluence is very apparent. And if they are present, you have to cut them while you are performing surgery. So this image has been given to me by my very good friend Subdeep. And you can see this cadaveric dissection showing these various arachnoid membranes and trabeculations. Here you can see the lamina terminalis membrane, which forms the boundary of the lamina terminalis cistern. You have the optic nerves and the optic chiasm. This is the chiasmatic cistern. This is the carotid cistern. Here in the depth, you can see the Lilliquist membrane, which has again two parts, which I will discuss. So this is the mesencephalic part of the Lilliquist membrane. When you retract the optic nerves and the chiasm medially, you can see this membrane here, which is the diencephalic part of the Lilliquist membrane. And this is your region of your carotid cistern, and it goes laterally and joins the sylvian cistern. Once you open the Lilliquist membrane, you can see inside the basilar artery, and you can see how all these cisterns are interconnected to each other. This is the third nerve here. This is the carotid artery, and here you can see the basilar with its bifurcation. Looking at it, so to explain the Lilliquist membrane, I have used this image. Here you can see the dorsum sellae. So the origin of the Lilliquist membrane is from this dorsum sellae. There is one layer that traverses superiorly and attaches to the mammillary, in the region of the mammillary body, either premammillary or retromammillary. And this forms the diencephalic membrane. And there is a posterior limb which goes in this direction and borders the interpeduncular and the prepontine cistern. So it forms a boundary between the interpeduncular and the prepontine cistern. And this is the area of your Lilliquist membrane, which has two components. So here you can see the basal view of the brain, and you can see the various cisterns in this region and its constituents. So the first one that we see here is the carotid cistern, bounded medially by the optic nerves and the chiasm. Laterally, you can see that it joins the sylvian cistern. You can see the constituents of the carotid cistern here are the internal carotid artery. It bifurcates in this region, which I will show you in the next image. Also, you can see the origins of the posterior communicating artery and the origin of the anterior choroidal artery. All of this lie in the carotid cistern. So here you have a cadaveric view showing the this proximal part of the carotid cistern in this region. And here you can see how it bifurcates into the anterior cerebral and the middle cerebral artery. Here you have the optic nerves and the chiasm, and this is your oculomotor nerve. This is your carotid cistern. This is an intraoperative view showing the carotid artery in the carotid cistern. This is a patient with a ruptured ACOM artery aneurysm, and you can see the tense, angry brain and how much of the cisterns you have to open to reach the base of the brain. So this is another image showing the chiasmatic cistern and the lamina terminalis cistern. So medial to your carotid cistern. So here you have here is the sylvian cistern, here is the carotid cistern. Medial to it you have the chiasmatic cistern, and superiorly to it there is the lamina terminalis cistern. So the chiasmatic cistern runs between the two optic nerves, as you can see here. And the constituents of the chiasmatic cistern are basically the superior hypophyseal artery, as it runs to supply the infundibulum and the pituitary gland. Above the chiasmatic cistern, here is the lamina terminalis cistern, where the A1 enters and joins to become the ACOM with the A1 of the opposite side, and then forms the A2 arteries, which run to form the pericallosal artery. So this is an intraoperative view showing the base of the skull, the optic chiasm, the optic nerves. This is your region of the chiasmatic cistern. This is the region of the lamina terminalis cistern. So this is a view from the front. So you have, this is the optic chiasm. You can see the pituitary stalk that is going down. Here is the carotid cistern. In between this is your chiasmatic cistern, and just superior to that is the lamina terminalis cistern. The constituent of the lamina terminalis cistern, as you can see, is the ACOM and the A2 as they run superiorly and go over the superior surface of the corpus callosum to form the pericallosal arteries. Posteriorly here is the interpeduncular cistern, and this region here is the confluence of cisterns. So to look at the lamina terminalis cistern more closely, here you see the A1 of both the sides entering, forming the anterior communicating artery and going up to continue as the pericallosal artery. You have the recurrent artery of Hübner, which also originates in this region and travels laterally to enter back into the anterior perforated substance. So again, this is the Sylvian cistern, this is the carotid cistern, this is the chiasmatic cistern, this is your lamina terminalis cistern. This is an intraoperative view again, showing very clearly the trabeculations and the membrane that forms the lamina terminalis cistern. And once you open this, you can enter into the third ventricle. So the lamina terminalis cistern continues superiorly and becomes the callosal cistern, which has as its constituent the pericallosal artery as it runs on the superior surface of the corpus callosum. So you see this cistern mostly when you're doing an interhemispheric approach. You can see the craniotomy. The brain is being retracted off the falx, and here you can see both the pericallosal arteries running over the surface of the corpus callosum, and this is the region of your pericallosal cistern. The next cistern that comes in picture is the olfactory cistern. The olfactory cistern houses the olfactory tract and the olfactory striae, and it runs from the posterior orbital gyri to the medial surface of the gyrus rectus. And again, laterally, it joins the Sylvian cistern. Inferiorly, it will join the carotid cistern. Medially, it joins the lamina terminalis cistern. Now going posteriorly, this is the region of the brainstem, and this is the interpeduncular cistern. So this is the cistern that is bounded by the Lilliquist membrane. So this is the region of the mesencephalic part of your Lilliquist membrane, as I showed in the sagittal image. So the diencephalic membrane runs towards the floor of the third ventricle, and the mesencephalic membrane separates the prepontine cistern from the interpeduncular cistern. And the constituent of the interpeduncular cistern is the basilar artery as it comes about from the prepontine cistern to the interpeduncular cistern and then bifurcates into the posterior cerebral arteries. Also, you have the posterior perforated substance in this region, and all the perforators of the basilar artery and the proximal part of the posterior cerebral artery enter in this region into the brainstem. So this is the constituents of the interpeduncular cistern. Now going to more basal cisterns in this region, you have the crural cistern and the ambient cistern. So the crural cistern is bounded here by the anterior part of the uncus and the cerebral peduncle, and the ambient cistern is bounded by the parahippocampus and the middle part of the temporal lobe. It is bounded by the quadrigeminal plate posteriorly, the medial and the lateral geniculate body, and this part of the brain, of the midbrain. The constituents of the crural cistern are basically the anterior choroidal artery and the posterior communicating artery. So the crural cistern also has a membrane, an intercrural membrane. So in its superior part, you have the posterior communicating artery, and it's in the inferior part, you have the anterior choroidal artery. As you can see here very clearly, this is the posterior communicating artery as it's joining the posterior cerebral artery. And this is the anterior choroidal artery as it is entering the inferior choroidal point in the temporal horn. So again, the Sylvian, the carotid, the lamina terminalis, the chiasmatic, the interpeduncular, the crural cistern, and here in this region is the ambient cistern. So this region sometimes is separated from each other by a series of membranes, but quite a few times the membranes are deficient. So all these cisterns communicate with each other, and they form a confluence of cisterns in this region, which communicate with the interpeduncular cistern. Here you can see a more magnified image where you can see the carotid artery with its branches of the posterior communicating artery and the anterior choroidal artery. Here you can see portions of the mesencephalic membrane of the Lilliquist membrane. So mesencephalic part of the Lilliquist membrane as it separates the interpeduncular cistern from the prepontine cistern. You can see the basilar artery and its bifurcation. This is an intraoperative view from a subtemporal approach where you can see all the various structures, the internal carotid artery, the basilar, the posterior cerebral arteries, the superior cerebellar arteries, the third nerve, and the posterior communicating artery. There's another view again from the subtemporal approach showing how the cisterns communicate with each other in this region. So this carotid cistern communicating here posteriorly with the interpeduncular cistern, the crural and the ambient cisterns communicating in this area and forming a confluence of cisterns here. This is an intraoperative view of the ambient cistern. You can see the cerebral peduncle in this region, the tentorial edge, the fourth nerve, the third nerve, the posterior and the superior cerebellar arteries. So again, as I said, if the membranes are deficient, this is a view that you can see from an intraoperative skull-base approach, where there is all the cisterns are communicating with each other. So the chiasmatic cistern, more posteriorly the interpeduncular cistern, the carotid cistern, the sylvian cistern, and the ambient and the crural cistern coming in this region and forming a whole confluence of cisterns. Now we have seen most of the supratentorial cisterns. Now let's go to the posterior fossa cisterns. So this is the main cistern here in the median limb of the transverse fissure, and you have the velum interpositum cistern, which extends from the foramen of Monro here to the subsplenial space here, to the quadrigeminal plate. And the constituents of this cistern are the medial and medial posterior choroidal arteries and the internal cerebral veins, along with the two layers of the tilia choroida. And posteriorly, as they go, they enter into the quadrigeminal cistern, which is bounded here by the quadrigeminal plate, the subsplenial region, and the constituent of this quadrigeminal cistern is the basal vein, is the vein of Galen. So this is a posterior view from a supracerebellar avenue that shows the posterior aspect of the quadrigeminal cistern. This is the quadrigeminal plate with the superior and inferior colliculi, the pineal body, and this is the region of the quadrigeminal cistern. So these are the other cisterns in this region are, we've already seen the interpeduncular cistern, the prepontine cistern. You have the cerebellomedullary cistern, the cerebellopontine angle cistern, which I can show you in, this is an intraoperative image. This is a petroclival meningioma that was operated by Professor Goel, and the whole meningioma has been excised, and you can see the cerebellomedullary fissure, medullary cistern in this region, and the cerebellopontine cistern in this region. And the last cistern that we'll consider is the cisterna magna, which we usually use open when we are operating in the sitting position for a posterior fossa tumor. And this is the intraoperative view showing the opening of the cisterna magna, which makes the brain lax and makes the approach to the tumor relatively simple. Thank you very much. I hope this has covered anatomy of most of the cisterns, and thank you very much.
Abida, thank you very much. It was a brilliant talk. Any doubts or any questions? Anybody? Any questions?
Don't be afraid, just to say hi.
Yes, Ahmed says it's a fantastic lecture. Ahmed, I'm glad you are there.
Thank you, Ahmed.
So we will introduce, we'll call the next speaker now. Nilesh, you can,
Yes.
Nilesh, are you there?
Yes, sir, I'm here. The next talk is by Dr. Manas Panigahi on the complication of the decompressive connectomy and its avoidance.
Manas is a very good friend. Manas, are you there?
I'm there, but I'm having problem with my computer, so I just cannot open it. Can you hear me?
Yes.
Sure, sure.
Yes,
You can,
Yeah,
you can see it, and then when you're ready, you just let us know.
Yes.
No hurry.
Yeah.
The next speaker, Nilesh, the next speaker.
The next speaker is Chandrasekhar Devpujari, sir. We must ask him if he is ready with his presentation. Devpujari, sir, can you hear me?
Dr. Devpujari, are you there?
So he has logged in, but his mic is.
Yeah, there he is. Okay.
Yeah, here he is.
So can you see my screen?
Yes, yes.
I need to get some
I need to change my view because I'm not able to see my slide properly. Okay, I'm good now. So if I can start, I think there were 2 or 3 lectures happening before mine, and but I think Abida has given a very good anatomy talk and about the gravity of the problem and the changing epidemiology. So we'll get to a less talked about problem, and which probably doesn't endanger the patient immediately, and it's not therefore much talked about. And look at a little bit of epidemiology and what is the current status of imaging, various other diagnostic methods and management. So basically, I think we all know that India is unfortunately head injury capital of the world, and we seem to get quite a lot of CSF leaks. How they are managed, we do not have any comprehensive data, but the fact remains that it is a big problem, and we do see from time to time that patients reach a very bad state with their CSF leaks and resultant meningitis. So basically, for a CSF leak to occur, you need to have a breach or dehiscence in all the layers, including arachnoid, dura, and the bone. And most commonly, it occurs due to road traffic accidents, but it can also occur due to simple falls. And one of the main indications that is emerging is the our surgeries. I think a lot of skull-based surgeries have resulted into defects, but we are not going to discuss that today. The fact that there could be CSF leak following cranial trauma was known as back as 2nd century, and in fact this was related in 1795 to basal skull fractures by one of the Dutch surgeons, and radiological confirmation mainly in the form of pneumocephalus was seen in 1913, and the fact that CSF leaks are synonymous with the aerosol was also demonstrated at that time, and Dandy, like many other things, was performed the first successful closure. Thereafter, there has been a rapid progress. Keynes classified CSF rhinorrhea, talked about extradural approach. Schroeder talked about resolution of leak with lumbar drains, which some people still practice today. Dolman first talked about extracranial repair. A first endoscopic repair was talked about by Vigand in 1981. Most common post-traumatic CSF leaks occur either through sphenoid, ethmoid, or cribriform. And 80% of leaks come from trauma, and about 16% from surgical procedures. This is the statistics of, I think, 2002. And out of the traumatic leaks, about 50% are evident in the first 2 days, 70% almost in the first week, and rest of them are present in first 3 months. Very rarely you have reports that it could have happened as late as about a year. And the classification by Omai and McCoy between spontaneous and traumatic. So the spontaneous variety was described by them. And then we have been talking about management of these lesions. And basically you have to differentiate between the two, because there is no conservative management for non-traumatic CSF rhinorrhea. While in traumatic CSF rhinorrhea, there are certain indications where you could treat them conservatively. The sites of CSF leak could either be one of the paranasal sinuses when it communicates with the dura. It could be most likely in the anterior cranial fossa, very rarely in the middle cranial fossa, and very, very rarely the posterior petrosal leaks, but it's more common in post-traumatic, post-surgical leaks. These are some of the statistics very early on which showed the various sites of leak, which confirm virtually the same. There is also a classification between the anterior cranial fossa fracture, and what is understood is that more midline the fracture, the more chances of leak and meningitis, and multiple defects are not uncommon. Diagnosis is not easy. In the very beginning, it is fairly easy, but in a late stage or in when the patient does not remember the trauma. If it has been after a trivial trauma, it is very, very difficult to differentiate. And therefore, you have to look for certain things like the salty test, if the patient complains about the relationship with the position, etc. And in acute cases, you have to look about for the associated periorbital edema, if there is optic nerve damage, etc. Some of the tests which have been described well as confirmatory is the handkerchief test, the typical target sign. The glucose oxidate test, if you have more than 20 milligrams per deciliter, and beta transferrin is the highly sensitive and specific method, but it is expensive, not available everywhere, and therefore should be probably reserved in cases where there is confusion. And the percentage of glucose and chlorine concentrate has also been used by people as one of the reliable indicators. There is this paper which talks about the specificity. I think it is very good. However, though it is difficult to get, and therefore if you have a good imaging and definite history, I do not think you need to subject every patient to beta-2 transferrin. Classification according to the timing of CSF leak, you can get an early leak within the first week, delayed leak after a week or so, and very delayed, that is months and years of injury, and your management also depends on that. In early leak, you'll probably manage the patient primarily for the brain injury, and though if it is profuse, you'd probably tell the patient to be in bed, and the diagnosis is easy in such cases is, and bed rest, reduction of ICP, and avoiding all straining maneuvers is what you usually prescribe to the patient. And the main worry remains is the prevention of meningitis. So meningitis seems to be the main reason why CSF leaks need to be looked at very, very carefully. And one of the early series from Glasgow showed that in a series of 155 patients, early exploration did not decrease the rate of meningitis or morbidity. This is a later paper by Ejamel in 1990, which shows that it has probably helped by giving antibiotics to delay the surgery a little bit, but not a very convincing evidence there. In fact, we all know that traumatic CSF fistula adds on to the already complicated issues in the management of traumatic head injury and its prognosis. And the various studies, large number of studies from United States, over 382,000 routine admissions for about 4 years were studied. Closed skull base fractures in almost 20,000, open skull base fracture in 5,000, and you had almost 453 patients with CSF leaks, and almost 7.7% of them developed meningitis, while in Otoria, the percentage was much less in terms of development of meningitis, and they concluded that this is an independent predictor for recovery and morbidity of the patient. A recent study in 2016 in China has also shown that the rate of morbidity due to CSF leaks increases from 3.8% to 9% if you have a CSF leak in the patients. Should prophylactic antibiotics be used? I think this has been very heavily discussed in almost all meetings amongst many surgeons. And though the earlier studies have shown some benefit of prophylactic antibiotics, all the studies after the year 2000, including the Cochrane database, has not really shown any advantage of prophylactic antibiotics in these patients. You can read up about it in the recent health bulletin which has come out. And one of the most important thing that seems to be emerging is the fact that you can actually get into a more serious or resistant kind of meningitis. One thing which should probably be given is the anti-pneumococcal vaccine, but it is still not a common, but I think most of us are now using it in our patients while waiting for surgery. On acetazolamide, again, there are several beliefs, but a study undertaken by in a large number of patients at PGI Chandigarh has actually shown that it did not influence the resolution of traumatic CSF rhinorrhea. Lumbar drain insertion, initial paper in 2008 had actually shown that there was a definite benefit. However, another paper in this decade has shown that it has neither reduced or resolved CSF leaks before surgery. And in fact, even after surgery, keeping a drain has not helped very much. And uniform policy nowadays is, if at all you need it, it will be used for a very, very short time. So basically, the conservative approach consists of bed rest, laxatives, and intermittent or continuous lumbar drainage, depending on the belief of the unit. We do not do a lumbar drainage unless the patient has been repaired. Uh, and then imaging is important not only to confirm the leak, but identify the cause, aid in localizing where it is, and assessing the size of the defect. This can be done on X-ray, simple X-ray skull. If you see a pneumocephalus and you know where the fracture is, maybe you can treat it. Radioisotope cystoscopy was the mainstay before the CT era, but mostly nowadays we are dependent on HRCT, MR cystoscopy, and CT cystoscopy in case the leak is persistent and if there are no other signs of raised intracranial pressure. Our own protocol is to use combined high resolution computed tomography with MR cystoscopy, which are images are superimposed. And this technique was evaluated by some of our colleagues in Mumbai and published in AJNR in 1998, and very, very reliable technique with almost 96% reliability. When you do not have a definite site of leak, the fluorescein can help you during the diagnostic endoscopy, and you can probably proceed even with repair if you are otherwise prepared for it. In management, I think you have a low threshold of surgery if the fracture is close to the midline, if the bony defect is more than 1 centimeter, if there is a bony spicule or a fragment in between, and if there has been a recurrent or persistent CSF leak and evidence of meningitis. So basically, the central issue in consideration of surgical intervention is the risk of meningitis in attempting conservative therapy related to the operative morbidity associated with repair of a particular leak. And you will definitely consider surgery when the traumatic leak is failing the conservative management, if there has been an episode of active meningitis, or if you are definitely seeing a pneumocephalus. Timing of surgery is also a matter of discussion, though nobody operates immediately in the first 1 or 2 days. But if there is no signs of raised ICP, if the patient is otherwise stable, the surgery is usually performed towards the end of second week. Early surgery is especially indicated in penetrating injuries, anterior fossa surgery when you have other complicating matters like you have a hemorrhage which needs to be drained, or if you have compound facial fractures for which the patient has to go to surgery, if you have an associated optic nerve injury, if there is a large aerosol, if there is a brain herniation seen already, if there is a widely communicated fracture, or if there is a soft tissue wedged in between the fracture limits. One of the papers in a journal of skull base has actually shown that most of the cribriform leaks can be waited upon for the first 2 weeks, as almost 80% of them close, while the posterior wall of the frontal sinus leaks do not usually close and should be more closely observed for surgery. Delayed surgery may be required in patients who have failed conservative treatment beyond 10 days. A recurrent leak has occurred after the initial stoppage, or if there is a meningitis or abscess at any given time. The procedure is either intracranial intradural, extracranial, which is usually the endoscopic endonasal nowadays. Intracranial approach can either be extradural or intradural, and you may need to shunt very, very rarely. The main debate today is actually endonasal endoscopic versus transcranial approach. So basically, the extracranial approaches were described way back in 1990 with the idea that you do not want to get intracranially in these acutely injured patients and reduce your morbidity, and it has shown a reasonable kind of a success rate. And then while analyzing the different surgical approaches, it was very, very clearly observed that simple leaks can be repaired by endonasal approach, and only for complicated leaks, large bone defects, you should be using the intracranial approach. So in endoscopic, I think the principles are: you identify the leak, you expose and delineate the defect, create a raw area surrounding the defect, plug the defect with the fat, cover it with a fascia. Tissue glue is normally used in most centers today. And then you support your repair with either gel foam or Merocell, and you may use CSF drainage depending on your level of comfort in terms of closure, as well as management of your drain post-operatively. And the four basic approaches are: you go for the medial cribriform, where you don't have to do too much bone work except for maybe lateralizing the turbinates a little bit. A transethmoidal, for a lateral wall of sphenoid, you need to do a transmaxillary, transpterygoid kind of approach, and for posterior fossa, you need to do transmaxillary, much more complex approaches. And most of the material used are either fat or muscle. Fat is preferred by most people. If you are using a free repair, fascia lata is the most commonly used flap. In pedicle flaps, either you can use a turbinate as a flap, or you can use a nasoseptal flap, which has become more popular nowadays. And most of these are settled in place by fibrin glue. Dural substitutes may be used as one of the layers, but cannot be used as the main component of your repair. And I think there are various ways the repairs are done, but the most common is a multi-layer repair. And you use some kind of a sandwich repair, as we just talked: fat, fascia, glue, and then maybe a flap on top of that. May not be for every patient, but for a more complex kind of a approach. And most important thing is you need to make the area properly raw so that your repair fits in properly. This is one of the medial cribriform repairs. You can see the defect here, sorry, lateral cribriform. And you start seeing the small encephalocele here. The area around it is being made raw and seems to have reasonably healed, but obviously you can see some CSF leak when you start pushing it. And then a free fascia has been used, and here we have not used any flap. It has been stuck by glue only at the edges. You do not interpose the glue between the fascia and the fat. This is a medial cribriform. Here again, you need to create a proper raw area. You need to make sure that all the gliotic material has been taken care of, and then the fascia has been used to cover it completely. This is another which is almost going up to the back wall of the frontal sinus. These are debatable. Should you be doing transcranial or transnasal? This patient insisted and gave us a chance, and we could repair it fully. That's the mucosa being taken out with part of encephalocele, defect being identified completely, then being plugged with fat, and then free repair has been done. This is a lateral sphenoid leak. This is very difficult to repair transcranially, so it is best repaired by a transpterygoid kind of approach. I don't think I will take you through the video. We don't have so much time, and nasoseptal flap is the most common flap based on the nasopalatine artery today. Recent review of literature shows you that this probably suffices almost 90% of the patients where you can do this kind of a repair, and mucoperiosteal flaps are available either from turbinates or from the nasoseptal um, area, and therefore a need for transcranial surgery is becoming less and less. And the other obvious advantage is it is more appealing to the patients because of it is cosmetic, and there is in fact a very good visualization if you are used to using an endoscopic technique. The disadvantage which is quoted most often by many of our colleagues is that it is unphysiological. You never repair a break from below, but the proof of the pudding is in eating. And I think we know that it heals well and it works well for almost close to 85 to 90% of our patients. And therefore, the main problem comes is in a non-active leak where you cannot locate a definite kind of and you cannot just put a carpet of fascia in if you are going transnasal. One of the biggest series which had changed outlook for most of us, especially in Mumbai and I think most of India, is a large series of over 250 patients by Dr. Kirtane, one of our colleagues at the KEM hospital, who have shown 96% success rate in the first instance, and it has been improved to 98.8% on second attempt at repair. and I think that that has stuck with most of us, and it has given good success rate in many of our colleagues' hands, as you will see in a moment. A meta-analysis by Karao Schneiderman group in 2000 has also shown in 289 CSF fistula that their success rate was also 97%. And Yadram Yadav and some of our colleagues in India have again shown a large series where there is a close to 90% plus success rate. So basically, when we are talking about what to use, etc., people have studied different modalities of treatment, different ways how you pack the cavity, how you put the graft, and almost everything seems to work in hands of different people. And there has not been a definite kind of a recommendation which can be made based on this. Transcranial repair is usually required when you have pneumocephalus, large pneumocephalus, if you have evidence of increased intracranial pressure, if there are other neurological symptoms, if you see that the patient requires surgery intracranially anyway for either removal of a clot or for any other reason. Most of us will do a bifrontal craniotomy to do this, and this is an extradural kind of repair, back of the frontal wall, and back of the frontal wall can be repaired by extradural, but anything behind that is difficult to repair. Again, I won't take you through the pictures. For the posterior repairs, you must take a very good galliopericranial flap, and this can give you a very good closure right up to the anterior clinoid, and certainly it helps to have some glue ready. The most important consideration is a multi-layered graft reconstruction, because one layer, second layer, third layer, you will have all the three layers in such a configuration that you are unlikely to fail, like the typical example given of holes in the cheese slices, and they will not come at the same place. And using vascularized tissue flaps has certainly made it easy, especially for more complex repair. People are also talking about using bone now. Cadaveric bone is not favored, and there is vascularized rotational temporal bone flap and many other flaps which have been used. You are going to have a very nice lecture by Dr. Goel, who published some of his experience in 2000. And I have been guilty of not quoting it earlier, but I think he is going to tell you about it very soon himself. And there are other people who have written about using split thickness graft with temporalis muscle to cover these defects. In complications, I think the most common complication is formation of a mucocele, and therefore you need to exenterate and cranialize the sinuses very well. Like everywhere else, the minimally invasive approaches has also entered the transcranial corridor, and this is a paper by one of our colleagues Dr. Sinha, who does it in Delhi with endoscopic transcranial kind of a pterional small craniotomy and repairing defects intracranially. And Castelnuovo and some of the other European surgeons have developed transorbital approaches, which seem to be very promising. In very rare cases, we have had to do it only in malignancies of the cranial base that you need to use flaps. And this is one of the radial artery flaps which has been used in this particular patient. I'll just take one more minute for CSF autoria. Fortunately, less common. It is mainly associated with longitudinal fractures. And what is more important is that most of them close very well. The most important thing to remember is sometimes they can present as paradoxical CSF rhinorrhea, like what happened in this 7-year-old boy. He had a small kind of a defect in the cribiform, which was repaired at another place. And when he came to us with meningitis, we also first explored that. And when we saw that the CSF was actually coming from the inferior part, we realized that it was coming from the ear, and the CSF cystoscopy showed the defect in the ear, and then this was repaired by a transmastoid approach. Fibrin sealants have certainly helped in strengthening our repairs, especially putting our flaps in place for a fairly long time. And I think to sum up, I would just like to say that literature does not support routine use of prophylactic antibiotics, lumbar drainage. Almost all kind of endoscopic repair have had similar success rate, and most of the defects which are below less than 1.5 centimeters, and if you leave frontal sinus apart, I think most of the defects can be closed by endoscopic approach. Post-operatively, bed rest or not has also become controversial now. Many people are preferring that we mobilize the patient early, but we usually keep them in bed for about 24 hours, get them mobilized in bed for the next 2 days and get them out of bed by third day. Need for a shunt is extremely low. We have had to do only 2 patients after they have failed transcranial as well as transnasal repair. One of them was a malignancy. One of them was a sphenoidal encephalocele. And in most other patients, we've had about 270 patients by now where it has been successful. Almost 54 patients have had transcranial repairs. About 220 patients had endoscopic repair. So last word I would say is that what is most important in deciding a surgical approach is not only the lesion and the patient, the preferences, the expertise of the surgical team, and I think a good teamwork is required even for a proper management of CSF rhinorrhea. Thanks, Saib, for the opportunity.
Okay,
Thank you very much, Dr. Devpujari, for a fantastic lecture as usual again. Thank you for coming in. It's a great honor. Any questions from anybody, please? If Manas is ready with his talk, we can go with Manas. Otherwise, Professor Goyal, if he's around.
Actually, there is one question for Dr. Devpujari, sir.
Yeah, sure.
Yes, sir. Dr. Harshad Parekh is asking, occasionally we can't localize the leak site, especially in the spontaneous fistula by investigations. What do you advise for the repair?
In a non-traumatic case, I think it is very dicey. You have to be really very careful and demonstrate where the leak is. We have recently used fluorescein, intrathecal fluorescein to localize these defects on endoscopy. And in 2 of the patients where we could not locate it during the first maneuver, we managed to locate the defect and close it properly. But I am actually keen to know if anyone else has any experience in this. Dr. Ramesh Nair is here. I think he's probably can enlighten us.
Ramesh, please.
Yeah, sorry, I missed that part. What was the question again? Just one.
Non-localized spontaneous CSF leak.
Yes.
How do you tackle?
So we do have a cystonogram, CT cystonogram. Most often try to identify the leak, and also often it's an exploration to see whether there is any leak during the procedure in exploratory inspection of the cranial base. If you're talking about the anterior skull base defect, often CT cystonogram will be useful to get the leak origin. Apart from that, often the routine protocol will be to get a fine cut CT scan to localize the leak. But as you say, it's often when you don't have a positive finding on a CT scan or cystonogram, it's often you end up exploring and looking for any possible defect and then repairing it empirically.
Any comments from Manas?
No, I am just concentrating on getting my presentation in.
Okay. Have you been able to get it?
Yeah, I could manage.
Yeah, it's on the screen.
Yeah.
Thanks anyway.
Thank you, Devpujari, sir. We will continue with the Manas Panigari's presentation. Thank you, sir.
Yeah. Good evening. Thank you, Dr. IP, for organizing this and inviting me to give a talk on a topic related to trauma. I selected this topic of complications and avoidance in decompressive craniectomy as many of us do that, but I know that you don't do, but this will help in promoting actually your your concept that how many complications are there in decompressive craniotomy and how it can be better. And, complications of decompressive craniotomy. There are few papers, not many papers, on complications and analysis of complications following decompressive craniotomy. The incidence of complications is quite high. If you see at the incidence of complication, it ranges from almost 40% of the time people have some form of complication. And the commonest complication is subdural effusion. And the next common is cerebral herniation, external herniation, and followed by post-traumatic hydrocephalus. And 10% of them can also have sinking flap syndrome. Now, with this high incidence, is it worth doing a decompressive craniotomy for all the head injury patients? Now, this has been controversial. If we go back 10 years ago, there are a lot of papers where it was controversial whether it was helpful or not. Now, the trial, DECRA trial, which they published in 2011, in that the mortality was similar whether they had a surgery of decompressive craniotomy or no surgery, almost 19 and 18%. So there is no significant difference with decompressive craniotomy. Then is it worth doing decompressive craniectomy? Now, after the DECRA trial, we had rescue ICP trial, where it was a randomized evaluation of surgery for craniectomy for raised uncontrollable ICP, and they published in 2016, and we know the results of that. The results in 2016, they said that when at 6 months, there is a significant reduction in the mortality. In medical group, it is almost 48%, it reduced to 26%. And when it came to 1 year, the mortality came down from 52% to 30%. And the patients who were independent also, they increased. So this is these results are quite encouraging that some form of decompression has to be done. But all these results are better because we have been able to manage these complications. Like 40% of them still have some form of complication in the follow-up period of 6 months to 1 year. Unless that is managed or tackled well, the results cannot be achieved as what is depicted in rescue ICP trial. Now, what are the complications? The complications, it can be early or late. Early, it can be hemorrhage, or the hematoma can expand because of the tamponade effect is gone whenever the decompression is done. It can be at the on the site of surgery, or it can be on the opposite side. If the size of the craniectomy is small, there can be cerebral herniation through that. If the techniques are not good, you can have wound complications or like hematomas, or you have CSF leaks, or you can have infection if you're not good at asepsis, as most of the are done in emergencies, and seizures. Late, after 1 month, you can have subdural hygroma, you can have hydrocephalus, or sinking flap syndrome. Now, what do we do to reduce these complications? As I had explained this, the complications are highest, almost CSF-related, absorption-related complications are almost to the extent of 40%. That means every alternate patient whom we do surgery will come with some form of CSF-related complication. Now, this is one of the commonest complications of subdural effusion, either on the side of surgery or opposite side of surgery. Now, this develops because there is a defective absorption following surgery. There are many causes of this. One cause can be the basal systems are obliterated, so absorption is defective. The other cause is, the other CSF-related complication is developing subdural effusion on the opposite side. And if one sees this scan of patient, then one will always jump to doing a burr hole on the opposite side, assuming that there is a midline shift. And one can see here that not only there is subdural effusion on the opposite side, but there is an interhemispheric subdural effusion also. Now, when one sees this interhemispheric subdural effusion, one has to be cautious that one need not do only a burr hole, because it will not work, because interhemispheric subdural effusion is a harbinger that probably patient will develop post-traumatic hydrocephalus. So these are the patients probably has to be told that they may need a shunt, either a ventriculoperitoneal or a subduroperitoneal, rather than just doing a burrow and reducing the release, evacuating the subdural effusion or subdural fluid. Now, this case, which one of my colleague had done the surgery, she first did as a burrow tap. The midline shift came down. Patient was fine for 1 week, and again after 1 week, this is what happened. The patient again had developed hydrocephalus. Again, subdural reappeared. There is another scan which I don't have, where the hydrocephalus had significantly increased. So in this case, what we discussed and we did was not a ventriculoperitoneal, because we are confused that it might cause again midline shift. So we did a subduroperitoneal. You can see here the catheter tip here, and following the subduroperitoneal shunt, all the mass effect has come down and the patient improved in his condition. And now he's planned for a cranioplasty. So the development of interhemispheric effusion, subdural effusion, and hydrocephalus is a continuum process. They are not separate. So it's a combination of an internal hydrocephalus and external hydrocephalus. If one takes care of the external hydrocephalus, then it settles down. So one need not do a ventriculoperitoneal shunt in this case. So what are the factors associated where all patients who have a higher chance of developing subdural hygroma? As I mentioned, if a patient has intermittent CSF hygroma, then they develop post-traumatic hydrocephalus. Now, you can also have pure internal hydrocephalus, like this patient, decompensating was done on the right side, and he had a communicating hydrocephalus, or this patient who had a bilateral frontal decompensating craniotomy again developed hydrocephalus. One of the commonest reason for patients who develop hydrocephalus is that there is adhesion of the basal cisterns, and because of absence of loss of pulsatile flow. And the other reason is if the craniotomy is adjacent to the midline, that damages the arachnoid granulations. That impairs the CSF drainage into the serial sinus, and that is why they develop hydrocephalus. So one of the precautions is recommended that whenever one does a craniectomy, one should be away 2.5 centimeters away from midline, so that one saves the arachnoid granulation, so the patients do not develop hydrocephalus or CSF absorptive defect. If you compare children and adults, children are more prone for post-traumatic hydrocephalus. That's because they have lack of cerebral atrophy and they have a higher compliance of brain tissue. So if we compare the children who underwent decompensating craniotomy, they had a higher incidence of hydrocephalus, and 40% of them needed a ventriculoperitoneal shunt as compared to adults. But then before jumping to do a shunt, one has to be careful. One should always do a contrast scan to rule out infections. In this case, when it did a contrast scan, all the ependema was enhancing, and it turned out to be that this patient, the hydrocephalus was due to ventriculitis and infection. So it's always better to do a contrast CT and confirm that it's not infection-related hydrocephalus, and then plan a shunt, a subdural peritoneal shunt, or any procedure. As I told you, the precaution one has to take is, if one does either unilateral or bilateral, always leave the midline. At least 2.5 centimeters from either side of the midline. Like here, where we have done bilateral craniotomy, and then we have left almost 5 centimeters of the bone. This again preserves the arachnoid granulation, so the chances of developing CSF of either effusion or hydrocephalus can be reduced by taking this precaution. The second most common complication is hematoma or CSF leak. And hematoma has been especially more common in the past 6 months, when we did decompensating craniotomy in head injury patients who were COVID positive. And all of them had high dose of low molecular weight heparin. And this patient developed subgaleal hematoma at the site of craniotomy, as well as hematoma in the abdominal cavity where we had placed the bone. So this happened because this patient was on a high dose of low molecular weight, but of heparin. But patients who are given prophylactic dose in therapeutic non-COVID patients also, they can develop this. So if a patient has tense scalp flap or a tense abdomen, one has to look for this hematoma, look for coagulation abnormalities and correct that. And this was the patient, COVID patient whom we had to evacuate the hematoma because the patient had worsened. The third most common is the CSF leak. The CSF leak usually happens at this junction of the frontotemporal craniotomy, the question mark. There are two steps one has to be careful. One should not go 5 centimeter behind the pinna when making a large flap. As we make a large flap, if it's more than 5 centimeter, and if one is not very cautious in preserving the superficial temporal artery, then they can have ischemia and necrosis, and there can be wound healing problem and CSF leak. If one has to make a big craniotomy, we modified. We don't do this kind of flap. We do a extend it retro-auricular. We make a L-shaped flap. The incision goes behind the ear and make a big L-shaped flap. In this, the wound healing has been very good because the flap has two vascularities, has three vascularities. In fact, supraorbital, the superficial temporal, as well as from the retroauricular vessel or the occipital artery. So this has very less chance in our experience, no leak, and very good wound healing and reducing the incidence of CSF leak in decompensated craniotomy. In addition to changing the type of flap, we usually harvest a pericranial flap. Like here, once the cranial, while reflecting the scalp flap, we harvest a free, not free, pedicle pericranium, and which is placed onlay on the dura, so that the chances of CSF leak is almost, in our cases, has been less than 1%, almost negligible. We have not seen any CSF leak in the past 5 years in decompensative craniotomies by following retroauricular incision and always having a pedicle pericranial flap onlay on the dura. The fourth commonest cause of complication is external cerebral herniation. If the craniotomy is small, the minimum size, if it's inadequate size, then the veins surrounding the craniotomy site get compressed, and then that causes necrosis, and they again herniate. That causes increase in edema, and then they herniate through that. To reduce this external cerebral herniation, one has to have an adequate craniotomy. The recommended size is at least 12 by 15 centimeter. Ideal will be 15 into 15 centimeter. As if one does not do that, one does not actually do the adequate decompression to reduce the ICP. If one does a 12 centimeter or more, then one adds almost 86 ml of more volume. But if one does less than 8 centimeter, it only adds 23 ml of volume, additional volume, which is not effective in reducing the ICP. So adequate size of the craniotomy reduces the complications of cerebral herniation. The next most common is sinking flap syndrome, which comes later after 1 month or 2 months. The best strategy to reduce the sinking flap syndrome is to do an early cranioplasty, as the chances of sinking flap syndrome is higher as the time is delayed more. The more delay you do, the higher the chance of sinking flap syndrome, like this case. So, but the sinking flap syndrome, as you see in this paper just published in 2018, the incidence of sinking flap syndrome increases after 1 month. In less than 1 month, it is 13%, but after 30 days, it is 20%. And as you wait more and more, it increases. So the precaution, if one does an early cranioplasty, one can reduce the chances of sinking flap syndrome and the complications associated with it. Because in sinking flap syndrome, it also affects the cerebral perfusion, and patients who recover initially, they can worsen, also have a delayed worsening, and that can be prevented by doing an early cranioplasty. So early cranioplasty with post-traumatic decompression, there was a paper where they did perfusion study and neurocognitive outcome before and after cranioplasty, and they demonstrated that after cranioplasty, the cerebral perfusion increased, as well as the cognitive there was a neurocognitive improvement after cranioplasty. Hence, it's recommended that as early as possible, if the wound is healed, one has to do a cranioplasty. The problem of waiting for the cranioplasty, if suppose the wound has not healed and the brain edema has not subsided, is also there. But if you do a delayed cranioplasty, especially in autologous, when you place a bone flap in the subcutaneous pocket in the abdomen, the longer you wait, the higher chance of resorption of bone is there. So this cranioplasty was done almost a year later. One can see here that the bone has thinned, it has become smaller and it doesn't fit. So it cosmetically, it doesn't give a good result. So if it's a late cranioplasty, probably it's better to use an artificial implant rather than the autologous bone, because the resorption rate is very high in autologous bone in late or delayed cranioplasty. The complications of cranioplasty are no less. The commonest complication is bone resorption from 1 to 18%, and surgical site infection is almost 5 to 12%. So one has to take precaution how to reduce the bone resorption rate and surgical site infection, as these are the two things which are preventable. Whereas hydrocephalus, I've already discussed, and seizures, one has to give anticonvulsant. To prevent resorption bone, if it's an autologous, we usually place in the abdominal fat, we do an early cranioplasty, as you can see here. So there is a good cosmetic correction when you do an early cranioplasty with autologous bone. But if it's a late cranioplasty, it's always better to do a fabricated 3D printed titanium mesh, and that gives a good result than doing an autologous bone graft. Once you're having a titanium mesh and autologous, because cranioplasty titanium is quite expensive. Almost it's in India it works out almost $2,000, and this autologous is almost free. So one has to be careful in deciding delayed cranioplasty, because it's quite expensive for the patient. The common myth is that when you use a foreign material, that the chances of infection probably will be higher, and in autologous the infection will be less. But then, contrary to the papers published, it's not true. The complication rate, when this is a paper which came in 2016, they compared whether if you used autologous bone graft, which was stored in minus 20 degrees, and subcutaneous pocket, which is better, the autologous bone graft stored outside and stored inside. In this paper, they said that there is not significant difference between freeze-dried bone graft with a bone which is placed in the subcutaneous plate. But then when the bone is the osteoplasty was done after 1 year, the chance of bone resorption was very high, and especially in diabetic patient, the chances of infection also was higher, and there was a little higher incidence of infection when a bone was used from the freezer. So though they are not statistically significant. But if you have to choose between cryopreservation versus autologous, probably cryopreservation, putting in the subcutaneous pocket in the abdomen is better, because it is cheaper and the chances of infections are less. And especially that we do not have to look at patient is diabetic or non-diabetic. So if one has to choose, especially in developing countries, placing it in the subcutaneous pocket is easier, and the patient need not go to the same hospital to go for the cranioplasty. He can choose to go anywhere where it's he is located at the rehab place. Otherwise, they have to go to the same hospital to go to have the cranioplasty, which is kept in that hospital. Now, which is better? It is though, as I told you, that the cryopreserved is supposed to have a little higher infection rate. So probably it is better to do a subcutaneous pocket than a cryopreserved. Now, which is the best material? Is it titanium, or is it ceramic, or PMMA, or autogenous bone. Now, when this paper which came in 2006, the incidence of infection was least in titanium as compared to the autoclaved autogenous bone graft. But this does not compare with the subcutaneous pocket one. But titanium is in this paper, they say that titanium is best for least infection. So if you want, one has to use a exogenous bone graft, probably it's better to use titanium rather than use an autoclave bone graft or an autogenous bone graft from the freezer or cryopreserved one. So in conclusion, to reduce CSF leak, retroauricular incision with pericranial flap has significantly helps in reducing CSF leak. Hematomas, caution with low molecular weight heparin. And for CSF absorption defects, avoid craniectomy within 2.5 centimeter from midline or remain away from midline. Contralateral subdural effusion and intrahemispheric effusions are indicator of post-traumatic hydrocephalus. So be under constant follow-up of those patients because they can develop hydrocephalus and may need shunt. Perform a contrast scan before planning a shunt to exclude infection-induced hydrocephalus. Early cranioplasty to prevent sinking flag syndrome, and adequate craniotomy to prevent external brain herniation. Thank you for your attention.
See this puppy? It's so cute, right? Yeah.
Thank you, Manas. I'm very glad that you highlighted the complications of decompressive. I would rather say that it's high time to bring microneurosurgery into trauma. And instead of sticking on to a 100-year-old procedure where complications abound and young neurosurgeons learn all the bad things, I would rather that they shift to microneurosurgery. And you will see that the results as well as the complications, everything gets better. This is my perspective on it. Now we will ask Nilesh to call the next speaker.
Yes. Actually, we have one question from one of the participants. Hello.
Yes.
Yeah. Dr. Harshad Parekh is asking, I agree to perform the early cranioplasty for the late cranioplasty cases. How old autologous bone graft you reject? Is there any time frame? This question for the Manas Panegai, sir.
Yeah, I mean, if you're kept in the subcutaneous pocket, you don't have to reject. You can use that. But after 1 year, the size comes down to 50%. So you have to always, again, augment with some bone cement. But if the bone is preserved in the cryo, at minus 20 degrees as cryo, then after 1 year, it is not recommended.
Okay, thank you, sir. The next speaker is Dr. Professor Atul Goyal, but I don't think he has joined yet. Should we move on to the next?
Abida, is Professor Goyal joining in?
I don't think so. If he gets access to this thing, he will join. So if he's not joined, he does not have access to the.
Dr. Deepak Gupta is here. Hey, Deepak, are you there? Hello.
Deepak Gupta.
Deepak Gupta, are you there?
Yes, he says yes, but he needs to be unmuted, I think.
Yeah, I'm trying to unmute him. He's got to mute himself. Deepak, unmute yourself. Oh, not working. Okay, let's move on.
Right. Deepak, whenever you are there, friend, just you can say something on your perspective. Me and Deepak has been associated for many years with respect when it comes to trauma. Okay. Deepak is a professor at Ames, and he's been doing these ANTC meetings, which are world class. So where everything, all kinds of trauma are discussed. So the next talk after Professor Goyal, please let's move on to the next talk, please.
Next talk is from Dr. Raghu. on the imaging in the neurotrauma principles and nuances.
Raghu, are you there?
Dr. Raghu ready?
Raghu, are you there? Raghu had logged in sometime before. I don't know what happened to Raghu.
I have not seen Dr. Raghu.
All right. Well, next talk.
Next talk is from Dr. Hari Chandan on the head injury, the current scenario.
Is Hari around? Hari is here.
He's in the chat box. Should be somewhere.
Hari had come to the chat box. Vlad is here. I will ask Vlad Benesh to talk about his perspective. Vlad Benesh, my good friend.
What should I talk about, Ipe?
Anything, because trauma is one of the biggest problems that you have. And all the stars like you, I mean, you see, Vlad, one of the main criticisms of cystonostomy has been that most people think, especially the young neurosurgeons think it is impossible to get into a tight brain, to the base. This is something that us, skull base and vascular surgeons have to sort this out, because other trauma surgeons are not going to help. Because other trauma surgeons, as I always say, other trauma surgeons are not into this kind of surgery. So one of the common criticisms is that it is difficult, or they say it's almost impossible to get into the tight brain's base. So what do you think about that? I mean, does aneurysm surgery training and trauma surgery training, should it go hand in hand so that you could get into the cisterns in both with the skull-based techniques that we practice and the anatomy that we teach? Should we make it clear how to get into the base in a rather tight brain? And of course, in an ischemic brain where everything is going wrong, it's difficult. But most of the time, you can easily get into the base of the brain, even if it's rather tight.
I do agree with you at all, because it's not really that difficult once you are trained in aneurysm surgery. Because subchoroidal hemorrhage, the fresh patients are exactly the same case as the trauma patients, and the surgery is exactly the same. And actually, once you get somewhere into the CSF space, the most important is usually carotid system. You get some CSF and the brain relaxes. Then you can perform any surgery almost in the same manner as in a normal brain. And the other trick, I don't know whether you do it in your cysternostomies, but in aneurysm surgery, very helpful is opening the lamina terminalis. Once you open the lamina terminalis, you quite frequently, even in a very, very severe subchoroidal hemorrhage, you get a fresh CSF and the brain relaxes after the opening of the lamina terminalis. Do you do it in cysternostomies or not?
I used to do it, Vlad. I mean, I used to do it before, but then now I reserve it in cases only when there is ventricular blood. Otherwise, we open all the cisterns and we get rather good relaxation. The thing is, even when all the cisterns are filled with blood, we keep on washing them out. And once the membrane of Lilliquist is opened, the brain is relaxed. The brain gets relaxed.
Yeah,
the only exception that I find is when there is ischemia, and that correlates with very low motor score. And in the CT scan, if you see a completely hypodense brain with no cisterns, with a GCS score of 3, motor score of 2, things like that is bad. We just had one today morning. So we declined to operate. So other than that, whenever there's a really tight brain, I mean, a couple of days back, we had a very bad aneurysm, WFNS 4, Fishers 4, patient GCS 4, everything 4, and mid-dilated pupils. My consultant is here.
on the panel. He will tell you. So we went ahead and operated. We did a cystonostomy. Brain was, before opening, the brain was really bulging out. Once we opened the cisterns, we could easily go ahead and clip the aneurysm without any events. I was thinking, it is the same thing that we are doing. Everybody that is doing aneurysm surgery should be the people who are teaching this to the young residents. And we just have to tell people that trauma has to be done just like an aneurysm surgery. And it is the biggest problem. It's much, much bigger than aneurysms or anything. So if you talk scale, we're talking about 10:1. So this is one thing. And leaders like you, I mean, Dr. Lawton is also, he's supposed to also come in and then tell us. Yuha is also supposed to log in and tell us that how to get into the into the base. Now Deepak was saying something. Deepak, would you want to comment on something? Would you want to come on video? And he was saying EVD is an adjunct. Would you like to say something, Deepak?
I think he's having a hard time connecting.
Yeah. I think Deepak is difficult. It's difficult for him to talk.
Yeah.
Glad. Yes,
can I say something?
Yes,
there's some comments. One comment said that we have a lot of questions about the previous talks. So maybe if he wants to read some question for the audience. My comment is first that you have to explain that one of the tricks is not to open the dura before to open the cisterns. And this is when I talk about cisternostomy with the other guys, and I explain that the first step is cutting the basal dura, basal frontal dura, to come into the cisterns, and this allow that the brain, also an angry brain, cannot bulge from the dura, and this is more clear, and the people start to understand how to reach the skull base with an angry brain. So for me, I told you everything every time. I don't think that the difference of the scare is to reach the skull base in an angry brain. The main problem is to understand when and who. When to decide for who, for which patient to decide. When we give this more clear information, I'm sure that the people are less scared about the choice of these techniques. And about your comment about the number of complications on decompressive craniectomy, you should take in consideration that there is an honest description of a large experience about these techniques. So I think that Cambridge performed an honest analysis with the rescue ICP, because at the base of the reason to analyze with a randomized clinical trial is because there is a doubt about the effectiveness. So when you read about the complication of the compressive craniectomy, you read about an honest analysis of the problem and the literature. And the previous talks was amazing, was excellent, because the previous talks explained that the main problem of the compressive craniectomy is the open box. And so all the problem about CSF circulation, dynamic CSF, whatever the theories that you want to follow, if you want to follow your theories of lymphatic circulation, or you want to follow the theory of CSF circulation of Marek Czosnika, the problem is the open box. So the complication in compressive craniectomy, it should take in consideration that the compressive craniectomy is not a definitive procedure. The real complication is after cranioplastic is done. So we have to understand which patients are really complicated.
Yeah, thank you, Corrado.
Yes, I agree that, you know, we must look at the complications of cystonostomy as well, for sure. But, you know, for years, I believed the only thing worse than doing a decompressive hemicraniectomy to a patient is probably running him over with a bus or something. This is what I believed. Because, you know, when you have CSF shift edema and you open the brain, allowing that entire brain to bulge, literally herniate out, and then you say about ICP being reduced, and then at 6 months later, you have complete loss of that brain. And when the surgical procedure itself is not based on a sound theory, and we know what it is based on. If you understand what it is based on, it was based on a comment by it was based on a comment that, you know, the CSF pressure is not elevated and the brain pressure is elevated. Because you did a LP, lumbar puncture, and found that the CSF pressure is not elevated in these kind of patients. And there were signs of raised ICP, and that is why they decided the brain must be decompressed. So it is not a sound argument at all. That is what is DC based on. Now, 4 or 5 generations of neurosurgeons have trained and have done this. So it's difficult to change it. It is like something has been ingrained to us and this is the generation that we have to attempt to change. And if I ask you, any other branch, for example, aneurysm surgery, skull-base surgery, pediatric surgery, spine surgery, even spine surgery is moved on to the era of microscope now. Now, if people tell me that trauma surgery, we don't need microscope, everything is well without microscope, and we have a surgical nightmare like decompressive, then, you know, I don't know what to say. I mean, I really don't want to fight it, but I understand that we need evidence and stuff. But, you know, isn't look at it without anything. Look at it with common sense. Isn't it necessary to bring micro neurosurgery to trauma and see? Isn't it necessary to look for sound arguments? Isn't it necessary to look for better physiology? I mean, and when I started off, I understand because of my quirky behavior, I remember, you know, making all the audiences believe that I was one crazy guy and I was doing something crazy. And I started talking about PCP removal and transcavernous approach and all that. I understand because I was primarily, my first love was skull base. And when I started doing this, I found out that this is something that you cannot deny. And there's such a huge difference. My consultants or anybody in this audience who's seen and done proper cystonostomies would, including you, Corrado, will tell me how the difference is when you open the cistern, the ICP, the brain just, you know, just falls down. So, I mean, this requires training. There's no question to it. And you cannot, I mean, there is no question of saying that in a third world country, we cannot afford to do that. But we can afford to do tumors with microscopes, but we cannot afford to do trauma with microscope. What kind of argument is that? I don't understand. A lot of people tell me that in countries like ours, we can do trauma, we can do everything with microscope, but except trauma. Trauma has to go into the emergency theater and there are no microscopes there. What kind of an argument is that? I mean, are these patients any different? So, for sure, trauma has to be given the importance that it deserves. And instead of going to places where these young neurosurgeons go and stand outside for 1 week or 1 month or 1 year, looking at skull-base procedures after doing DZ, instead of that, they should start these procedures, CSF let-out procedures, getting into the skull base by themselves during trauma. And they won't have to go stand in any other operating room watching. They'll have their own experience. I can assure you this is
This is some, yeah.
Take the conversation in a serious level. I mean, do not the problem that to use Microsoft or not in trauma is not a serious argument. I mean, if we have to discuss, we have to discuss if cysternostomy is effectiveness, is effective, if cysternostomy needs for all patients or just for subset of patients, like the same thing, the same consideration, decompressive craniectomy. Decompressive is not for all patients. Cysternostomy is not for all patients. If we have discussed, and I think that we have to leave time for the other speakers, but if we have discussed about indication, consideration, technique. It's totally unuseful to comment people that say that microscope doesn't need in trauma. Microscope should be a tool for all the neurosurgeons, even for young neurosurgeons. And maybe cysternostomy is one of the reasons to increase the microscope skill, microsurgery skill in the young neurosurgeon. It's one of the reasons, of course. It's one of the reasons, not the only reason. But we do not discuss about microscope and young neurosurgeon because it's unuseful, as you know.
Yeah, I agree with you, Corrado. The only thing that I am saying, there's a lot of young neurosurgeons watching. The only thing I'm telling to them is that learn microneurosurgery. I mean, and the trauma is the best way of doing that. And instead of, Shabarish is asking, Shabarish is wanting to talk about his experience with trauma. Shabarish is from United States. We don't have Dr. Goyal, Dr. Hari, Dr. Raghu. So maybe we can give time to Shabarish. Shabarish, would you like to come in and show some videos? And tomorrow, the young neurosurgeons, including Andrea, Prakash, Nilesh, all of them are showing their videos on their experience on cysternostomy. Go ahead, Shabarish, please.
Hi, are you able to see me, hear me?
Yes.
Okay. I think it was a great discussion for the last 10 minutes of, what are we doing with cysternostomy and where we are. And I want to first tell my disclosure. I'm not a trauma surgeon. I'm actually a microsurgeon. Most of my practice is aneurysm surgery and skull-based surgery. But here I am talking about trauma surgery because I think the skill set needed for the next gen trauma surgery is aneurysm surgery and skull-based surgery. And here you have a picture there in my first screen. That's a patient who had 2 aneurysms, an AMC aneurysm and a PCOM aneurysm. Bad hemorrhage, big subarachnoid hemorrhage, a lot of mass effect, tight brain, where we went into the cisterns, clipped both the aneurysms, and you can see the cysternostomy drain down all the way down to the foramen magnum, right? So we do this all the time during aneurysm surgery. So why not in trauma surgery? And I'm going to discuss some of the, I think Corrado brought a lot of very good points. And we're going to discuss some of those as we go through this presentation. I'm going to start with one case. This is a 26-year-old gentleman, had a poor GCS, had multiple brain contusions, has a very thin subdural hematoma on that side, a lot of midline shift, basal cisterns are obliterated, and subarachnoid hemorrhage. He's not moving the left side. He was intubated at scene, brought in. We got him in the OR within an hour or so. And here is a video of what we did. And some of the principles, I'm going to pause this as we go. You can see that I've taken down the orbitomeningeal band there very quick. I've not drilled down, and I did a little bit of a lexal of the superior of the sphenoid being there. I saw the orbitomeningeal band, I coagulated, divided it to kind of unlock the temporal and frontal lobes. And that's it. We're not doing a clinodectomy. We're not doing whatever is needed to separate the temporal and frontal lobes. And when you're there, you get an idea to do that. This is what we do during aneurysm surgery. How much is enough? How much of bone removal is enough to get down to the sisters? And there you can see it's a very tight brain. I'm trying to open the dura. You can see the subdural coming out. And you see, as Corrado pointed out, I do not open the entire thing because it prevents CSF shift edema. You don't want all the edema to come in the brain and get all the side effects of doing a decompression and getting CSF shift edema. You want to get down to the cisterns fast. And you can see there, I'm getting down to the optical carotid cistern, that subarachnoid blood flashing, which says that there's a hole in one of the cisterns is flashing out because there's so much of pressure. And there I'm seeing the optic nerve and the optical carotid cistern. You can see the anterior clinoid process. I'm going in between the optic nerve and carotid nerve to find the pituitary stalk, the membrane of Lilliquist, and to open it and get down to the front of the brainstem and the basilar artery. This was a very tight brain. Continuous irrigation helps dissecting the cisterns. Literally from the time when the dura was opened to the cystonostomy drain going in real time was 11 minutes. So it's a very common thing we do in aneurysm surgery. You can see a little bit of the hint of the pituitary stalk anteriorly, and that is the remnants of the Lilliquist that is left. You can see the front of the clivus there, back of the clivus there, the posterior clinoid process there. And you can see already the brain is so slack. I have a lot more room than where I stored it. And now, now you have all your time, and all your energy, and you can focus and you can do good microsurgery. And you'll see once I do that, I try to now, so I focus on the optical carotid cistern and this opening first. I can already see some of the basilar branches there. There it is, the front of the brainstem. And you can see now, this is a very good part of the thing. The brain is so slack and pulsed out already, and I have not taken the subdural. I've not done anything except opening the cistern, right? The biggest mistake I think used to do in trauma surgery, open the dura wide, the first thing we did, and we caused more brain damage. Now you have all the time. I'm opening the contralateral optical carotid cistern, the chiasmatic cistern. I'm just slackening the brain as much as I can. And now I'm going to put in the cisternal drain. You can see I'm looking in front to see, I can see the back of the clivus and the front of the brainstem. The most important thing is this drain needs to be in front of the basilar vessels, all the vessels, right snugging the back of the clivus. The back of the clivus should be your sliding board for this catheter, and it has to go into the opposite CP angle. And there you are, and that's the end of the cystonostomy. And you can see how the brain is already slack. It is very difficult working in the Western world to say, hey, this is all I'm going to do. I'm not going to do a decompression. So I have to do a decompression as part of what I do. And that's why I think we need to create the evidence. And here he is, this guy is following commands. There is not a lot of brain shift. It's midline. You can see that drain going through the cisterns. All the cisterns are open underneath the tentorium, all the way down to the CP angle. Right. So this case came, and I'm going to talk about some of the scenarios that Corrado said. This case came after I finished a 16-hour skull base case. And I started this case at 10 p.m. in the night, and I finished it at 1 a.m. So this is what a cerebrovascular surgeon would want to do, or a skull base surgeon would want to do. And we'll talk about that part as we go too. Okay, so what evidence do we have for cystonostomy? Do we know it works? But before that, I just put up these 3 points, but I think we had a speaker previously talk about what evidence we have for decompressive hemicraniectomy. It's not great, although the studies were conducted very, very well, very good documentation of complications, problems with decompressive hemicraniectomy. And all it says is when there is no result, the last result is decompressive hemicraniectomy, and do a bigger is better. That's all we know. And that's all we have as evidence for decompressive hemicraniectomy. And what does it do? It prevents mortality. Does it improve functional status of a patient? Maybe not. And that's all we got as the best treatment for trauma. It's best surgical treatment of trauma at this point. Okay. And I'm going to touch on these, what is published about cystostomy. Okay. We have really 2 studies published and 2 case reports, 4 studies published, I would say, in major journals. And this is in the last, since 2007, I have started doing 13 years, 4 publications, very little data. And this is the biggest and the largest report published in 2013. And I have published this, 848 cystostomies, impressive. Big difference in Glasgow outcome score at 6 weeks, decrease in ventilators. But what is the biggest criticism? There is no lack of details, lack of research protocol. We don't know what kind of TBA algorithm was used. There is no clear documentation of complications. And as Corrado pointed out, there's clear documentation of complications and how many complications, even the smallest, in all the BC trials. So this is important for us. Criticism is important, and we need to take it, and we need to see how we can fight it. And this, I think, is better data structured by Roy from Switzerland. This was a single center, still retrospective, not prospective, published in 2013. They screened 150 patients. They thought 50 patients were eligible for a decompression, of which they did it in 40 because they thought 10 patients had already severe brain damage, and of which 22 patients underwent decompressive hemicraniectomy and 18 had decompressive hemicraniectomy along with cystostomy. And they classified these patients into primary patients and secondary patients. I think that is a very important concept here. Primary patients were patients who had a reason to have a decompressive hemicraniectomy the moment they rolled in the door. And the second group of patients were patients who did not have a reason to have a decompressive hemicraniectomy the moment they rolled in the door. So they went into our current trauma ICP management protocols, head of bed elevation, ICP monitoring, Lycox monitoring, mannitol therapy, super salts, do whatever to reduce the thing. And then when the hell broke loose and nothing could be done, take the patient for surgery. So that was the second group. And what was found? Of course, in both groups, the patients who got cystostomy had lesser days of ventilation stay, lesser ICU stay, lesser need for osmotherapy, which I don't think anyone needs to tell me. As a person who has done this so many times for other surgeries where there's tight brain, this is all very logical. And the patients had a higher GCS at discharge. That's all perfect. But was there a difference in outcome at 6 months? There was not in the secondary group. In the primary group, there was a difference in the outcome. What does this say? Are we doing the right thing in the secondary group of patients? Maybe there is a missed opportunity. Should we be doing cystostomy, not decompressive hemicraniectomy, earlier to prevent ICP-related brain damage till the hell breaks loose, till these patients are cooked with high ICP before we do something to these patients? So that is a question to be answered. I think it is a very, very important question to be addressed. And it's very important to separate these two groups. And I think Roy did a great, great job at separating these two categories. Okay. Is cystostomy safe? I have did close to 1,000 cystostomies. There's not a clear documentation of what is the complication rate. I searched through the literature, and this is what I found. I found 3 cases where was done for aneurysm surgery, and there was some vascular injury, perforated-related injury, and it was all technique-related. It was mainly because they put the catheter in between the brainstem and the blood vessels, not using the clivus as the sliding board. So that was the main thing. But is this the tip of the iceberg? Is this something we don't know? If you perform 1,000 cystostomies, are we going to unravel more? We don't know. And I think that's something we need to prospectively look at and we need to understand. and be honest about it. So I think, again, criticism. Peter Hutchinson was the person who did the decompressive hemicraniectomy trial. I think that, as Corrado said, there was a big, honest reporting of complications and everything associated with it. Did it work? Did they say that that was the best thing to do? I don't think so by any of those papers. But what he says is true. The responsibility lies with the proponents of cystinostomy, including me and most of these people, most of our panelists here, to conduct a prospective randomized control study to clarify it is effective or not and where we should do it. What is the complication rate? What are the pros and cons? Okay. So can we do better? Right. So before, this is my thought, and most of what I'm going to talk from now is my thought about cystonostomy. And it is a lot learned from people like Ayub, who has been doing this for a long time, proposed this, has thought about this for years together, decades together, and talking to people and doing this myself and reading and learning. Okay. So we know cystonostomy is prevention of CSF shift edema. So that's why it's very, very important not to do the decompression before you open the cistern, as Corrado pointed out, because there's axonal traction. You are creating brain damage by opening the dura in a tight brain. And I've taken this principle from trauma back to my aneurysm surgery now, right? I don't open the dura. Previously, I would open the dura wide so that I have space to get my hands in. The brain is ballottable. The brain expands. There's a bigger opening. Brain doesn't mushroom out. All that I've changed. I am going for my cistern first in any surgery because I want this fluid out. I don't want to open the dura and push my brain out. I want to keep the brain inside my cranial cavity. The next thing is, we know trauma is an inflammatory, or, a high, high metabolic activity state in the brain. And there's going to be a lot more brain products. There's going to be hyperthermia in the brain. And it makes sense with the theory of CSF cooling and removal of waste products by cystonostomy. There is a potential possible effect of cystonostomy in decreasing secondary injury and traumatic brain injury. It's a hypothesis. I think after proving cystonostomy works, it is the onus of us who are proponents of cystonostomy to prove this too. Okay. The third question is, can we avoid a decompressive hemicraniectomy? But before we get there, we got to prove cystonostomy is better. The next step is can we avoid a decompressive hemicraniectomy? And we know about its complications, costs, and they have been very well documented. Okay. And the next question, which I kind of alluded to earlier, do we need to wait for failure of medical therapy to do cystonostomy? And that question brings the next question: should it be compared against decompressive hemicraniectomy? Or is it going to replace your ICP monitor or your brain tissue oxygen monitor or your EVD? Because if you have a cystonostomy drain and you put the drain at 0 or 5, your ICP is always below 0 or 5. That drain never shuts off. All my patients have done it. Every day we have 400 cc's of CSF out there in very tight drains. So you have a way of treating your ICP. Why do you need an ICP monitor? Why do you need a brain tissue oxygen monitor? Why not just a cystonostomy? Right? Thought-provoking. We got to change what we do, and we may or may not be the right answer, but we got to think about it. Okay, and this is Ayub's diagram, which explains most of what I just talked about, why cystonostomy is different from everything that we did before for trauma. So this is, I think, the roadmap I have thought about of what we should do for cystonostomy, and can we do this? The first step is, where do we start in this roadmap? And that is something I'm going to live up to this panel. I want the panel to give me some feedback. Where do we need to start? So the first thought is, should we do a prospective, non-selective, which means that every single patient is in the base? It's not like, hey, I'm picking and choosing my patients and getting the best patients in the database. Can it be multicentric? Can it be IRB approved? A data registry with a unified algorithmic approach to moderate and severe TBI patients, needing primary, not the secondary. I'm not talking about the patients who have been cooked with ICP, because we know that's a bad category. Let's not start with the bad category. Let's start with the good category, where we can get in the cystostomy day one, okay, with an adjuvant cystostomy. And should we just look about what are the complication rates of cystostomy? Does cystostomy work? Is it something safe to do? Can we do this safely? That may be the first starting step. I don't know. Maybe we can skip the first step and we can go to the second step, which is, can we do a prospective multicenter randomized control study with 3 arms? The first arm being decompressive hemicraniectomy, which is decompressive hemicraniectomy plus cystostomy. And as we advance that trial over a couple of years and we have data, maybe we should add a third arm where we say it's only cystostomy and not decompressive hemicraniectomy with cystostomy, and see, is there a decompressive hemicraniectomy conversion rate? And, you know, as I said, thousands of cystostomies have been done. I think after a lot of cystostomies, the brain flaps have been put back, and I still cannot get a good handle on the number of patients who need a conversion. And even if someone can throw out certain numbers, I don't think that is prospectively adjudicated and documented in the literature yet. And I think the onus lies on all of us to do that. Okay. Then once we go that step, then we come to the secondary management. The secondary management is patients who come who current criteria do not need a decompression, right? These patients are being put in an ICU with you know, ICP probes, Lycox probes, and they're giving mannitol, everything. And those patients can be once, and we cannot do this till we do the first, right? No one is going to let us do the second before we do the first. And can we randomize them to cystostomy, primary cystostomy versus secondary cystostomy, which means, can this replace your ICP monitor or your Lycox monitor? And can this, is CSF drainage more important than ICP monitoring? I tell you, the first time I put in a cystostomy in a trauma patient, all my critical care specialists were right up against me. They're like, I don't have an ICP monitor. I can't keep a drain open. I want continuous ICP monitoring. I want you to put a Lycox monitor and an ICP monitor along with it. I said, there's no need. I have a monitor out here. It's draining. The cisterns are open on the scan. There's air around the frontal lobe and in front of the clivus. It's not necessary, right? But it requires a lot of effort to put up with four critical care specialists who are not surgeons to kind of trying to question this, okay? And we need to try to address it. I think it's an important thing to address, okay? Then comes the questions that, you know, we have been talking about. Do you need an advanced microsurgeon to perform cystostomy? So I think that comes with, I think we should start doing these studies with people who are trained to do skull base and vascular, so that we create the evidence for cystostomy and do not muddle it with training and lack of experience and lack of expertise. And once we do that, then we got to think about, can anyone and everyone do it? Okay, is cystostomy safe in everyone's hands? How many does one need to do before we call he's a safe cystostomy surgeon and he's on his own? And the last thing I talked about is this, where, you know, I told you I finished a 16-hour skull base case. I started this case that I showed you at 10 o'clock. I finished at 1 a.m. At 7 a.m. in the morning next day, I had a 6-centimeter acoustic to go to. You know, yes, I think this is the right thing for these patients, and I did it, and I wanted to do it. But is this going to beat me up as I do this as time continues? Am I going to give up my vascular and skull base practice and do trauma surgery and open the cisterns all the time? It's a question to be answered. It is an issue. It's a real issue. Okay. So we already have this, I think, prospective data registry. So maybe we can skip that first step and we can go to the RCT. And I want the panelists and IEP and Corrado, who is here, to tell me, where do we start with this? Okay. And you know, I call it the CysTBA database, RCT, whatever you guys would like to call it. It could be an online REDCap database. We can do it multicentric. It needs to be IRB approved. It needs to be real science. And we need to document what is our common TBA algorithm. Let's create a survey. Let's create people who are interested. Let's create a survey. Can we come up with a common TBA algorithm? Can we come up with the common specifics of how we do cystostomy? that we all agree upon. And if we agree upon, let's do this. Let's do a registry or a trial. And we have to strictly document TBA characteristics, prospectively, adjudicated with no, berry picking, nothing. ICU management, surgical specific complications, outcomes, and let's put it out there to say this is better or this is not better. Okay, and that's what I got. Thank you.
Thank you very much, Shabarish. Excellent talk and a very good video showing how a fast cystonostomy should be done in an acute subdural. Well, I wish more and more of these videos are shown in these meetings. And I'm glad you took it up, and I'm happy that you are planning to go ahead. And this is something that I could not do in 13, 14 years. And I'm glad that you're going to give the science world a reply in the same coin, in the same way. So I'm glad that you're doing it. And, I'm sure my friends Corrado and Franco will be happy on this. Although I don't know whether I'll be able to help you, but we, at this center, the new center in Krishna, we have a lot of head injuries. And already my consultants have seen the efficacy of cystonostomy in some very bad cases. So we hope to contribute to you at least with the cystonostomy wings. Let's see what happens. Anyway, thank you for an excellent talk. And it was an honor having you here, Shabarish.
Thank you.
So can I put up a question?
Yes.
The rescue ICP trial states that after 1 year, the dependency of the patients undergoing the surgical intervention is more than with the patients who survived with the medical management. So how to go about with this, and what do we think from this, and what message do we get from what decision to be taken? And after 1 year, the dependency of the patients who went for the surgery had a poor functional outcome than those who survived with the medical management.
The surgery is decompressive, Uday. Shabarish,
Yes, sir.
Shabarish, would you like to comment?
Yeah, I think, as Ayap has pointed out, yes, 1 year dependency, is that what our ultra goal for trauma should be? You put someone in a nursing home at the end of a year, they become a little independent, and there's a little p-value, 10% of them are better. Is that a great result? You call it victory? Okay, think about subarachnoid hemorrhage.
Yeah, that's what I'm saying. That's what I was thinking. So
correct. Think about subarachnoid hemorrhage, where we have come, right? There was an out-of-hospital mortality, which we have reduced significantly. The grade 1s and grade 2s, their results are excellent. Grade 3 subarachnoid hemorrhage, I would say in our center, 70% to 75% of people are doing MRS 0 to 1, not 2. Very good, independent, functional back in their lives. Grade 4s, around 40-45% are doing good. Grade 5s are the ones we haven't cracked yet. And even them, I would say, previously I had a grade 5, I would say, hey, I'm going to put an EVD, see if they wake up, then I will do something. No, we have 20 to 30% of grade 5s who do good today, right? So we have come a long way. We have pushed it, right? And we haven't pushed trauma surgery. We just, because there's so much, a lot of people don't want to deal with it. We don't want it in the hands of experts because we want to do aneurysm surgery, skull-based surgery, beautiful brain tumors, and we don't want to do it.
Yes. So thank you, sir. So like here after, hello.
Yes.
Yeah. So we discharged the patient. Suppose we took the decision of operating the patient, and after 6 months, patient's outcome is well. That's okay with us. But he goes back to home in a poor functional outcome with a low MRS, and after, due to the bad care at the where he's going back to his home, probably is not getting adequate nursing care, the patient succumbs to all the assault or the severe head injury. So, but that's what they were saying. If he had kept the patient on the medical management, and the functional outcome of such patients had been better, whom we had not spent the time operating. So would have been that made some any difference?
So some of
That's
these
what the
patients that,
rescue ICP trial told us. 1 year outcome is okay. We are successful we can be successful after operating the patient in the first year. But after the residual years of the patient in subsequent years, that goes down. Those outcomes are going down with the patients.
So I think, what you're pointing out is absolutely correct. I think, once the patient leaves the hospital, you do not have a control of what happens with the patient, right? They go home, nursing home, facility, whatever care is given to them is whatever care they have. If you really need to do an impact on these patients, of how, like, can we get them better, you have to impact what happens in the hospital, which means that when they get out of the hospital, can we make them a better functional status? Okay, can we reduce their ICU stay and ICU related complications? Can we reduce the days they are on ventilators? And I think that CSF shift edema and the concept I said of just cooking patients with ICP, okay, is doing a lot of secondary damage that a lot of us do not acknowledge today. And maybe keeping someone at an ICP of 0 to 5 for the first 5 or 6 days is going to prevent a lot of the secondary damage and have better outcomes in traumatic brain injury.
Thank you. Thank you, sir. Thank you.
Thank you.
Yeah. Thank you, Sabrish. We can move on to the next participants. Nilesh. Is Raghu here? Raghu is here. Is Raghu around? Well, so Raghu doesn't seem to be around. Next participant, please. Next, Nilesh, can you call the next person, please?
So next talk is from Dr. Yong Hong Wang on the cystonostomy in the brain trauma with bone flap replaced.
Wang
Dr.
is a very,
Wang,
and he is the chief at a very, very busy hospital in China. He's got one of the largest series of cystonostomies. And let's enjoy Wang's talk. We are honored to have you here, Wang.
Hello, Wang, are you okay?
Wang, are you there? Hello, Wang.
Sorry.
Okay. You okay?
Okay. Okay.
Yes, ready.
Hey.
Hey, Wang, how you doing?
Yeah, good. Let's begin. Thank you, Professor Art. I'm Yun Hong from Shanxi province of China. And I recently do many cystostomy surgery in brain trauma at pre-hemorrhage, infarction, aneurysm, and so on. So I think most of patients do not need recurrent the bone flap. So I do many patients, most of the bone flap replaced. At this contact my lecture about perception, pathology of cystostomy, and the CSF shift edema, principle of cystostomy, and some clinical data. Cystotomy is a novel technology that incorporates knowledge of skull-based and microvascular surgery by opening the pre-basis to atmospheric pressure. Technique could decrease in intracranial pressure due to backshift of the CSF from swallow breath to the system through the vertebral spaces. This is a new discovery about CSF, the lymphatic system, from 2012. So this is our cleat of waste at the cleat system in the brain that serves the lymphatic-like function. This is lymphatic system physiology. So our CSF is the main fluid that travels throughout brain to remove toxins. So it actually cystotomy uses CSF circulation. We can explain why cystotomy is effective surgery. This is about lymphatic system in human. This is brain-wide lymphatic enhancement and clearance in human. This is assessed with MRI. This is the human brain MRI research about lymphatic circulation. This paper used MR contrast agent gadobutyl administered intrathecally, and then use MR scan were performed at a defined time point. In human, CSF tracer distribution from the brain towards the deep brain structure. This is deep time MRI scan. This is the video about the brain tracer into brain. At a different time, they have different scan. This is human brain lymphatic circulation. And now, the current pathway recognized for the exchange of fluid within the intracranial compartment. This is the fluid between cyst and the brain parenchyma through the perivascular vertebral spaces. It may be of great importance that recognize our fluid within the vertical system and absorption at level of the sinus. Cystotomy use CS shift edema, and when the brain trauma, brain aneurysm, and subarachnoid, there's a lot of hemorrhage. This would result in shift of CSF from cyst to brain parenchyma through the perivascular spaces, follow a pressure gradient, and result in an increase of the water content of the brain. This mechanism of the brain swelling has been termed as CSF shift edema. And this is a model of a CSF in our brain. Subarachnoid space and perivascular space are interconnected fluid compartment. The low resistance pathway for fluid flow to and from the perivascular spaces is shown in green, while the high resistance pathway through a parenchyma is shown in magnet. This is the most model is around. This is the model clinically symmetrical around the penetrating artery. This is our principle of cystotomy, and this is our brain swelling. And after this drainage, the brain swell is done. So perivascular and sister drainage of the salute appear to be an important process in brain health and disease, especially in brain trauma, brain aneurysm. We use basal sister drainage of the salute. It's very important because we have this surgery after surgery, we use ICP modules. The patient ICP is normal. This is research about the perivascular pathway for influx of cerebral spinal fluid are most efficient in the middle brain. That is why we use prepontine sister drainage. It's very efficient. This is the pre-administrator at in different time, 50 minutes, 100 minutes, 150 minutes, 200 minutes. The top row are pre-administration, and the low rows are at a different time administration. These images demonstrate the rapid accumulation of in the middle brain. So this in the middle brain, our sister drainage is more efficient. This is a brain trauma case report. 26 years old male, disturbance of consciousness after head injury caused by traffic accident for more than 6 hours. GCS is 30, and bilateral pupils are equal in size and sensitive to light. Left head CT is left temporal lobe contusion and laceration. Left temporal lobe subdural hematoma. This is a patient CT scan. This our we have surgery. Sorry.
Sorry.
Oh.
You okay there, Wing?
Cannot operation.
Okay, well, keep trying. You'll get it. Maybe reboot or reload it.
Reload it?
Yeah, reload it. Yeah, reload it again.
Okay.
Yeah.
If you have the video separate, you can play that video separate, Van.
Yeah, that's possible.
Okay, because the cystoscopy is a microsurgical neurosurgery, so we use microscope. At every surgery, I will use headset and use ICP monitor. This is pre-operation ICP is 36. This is a bow. This is operation. And after cystoscopy, the ICP is becoming 8 to 8.2. So it's very effective to download, reduce ICP. Cannot. Huh? Sorry.
Okay. Still not working? Okay.
Okay. Okay. This is a video. At first, you cut dura. Then let's bring hemorrhage at the CSF out. And this is our first reduce ICP. So at this time, we can down a part ICP. So at this time, breathe became some soft. And then we at this time CSF come out, breathe hemorrhage also come out. Then we cut the dura at the addio to scope base. And then we lift up the front loop. At this time, we rush out, use sunny rush at the we can suck. This is optical nerve, and then open the chiasm system. At this time, CSF come out and the breathe becoming relaxed. Because this time, this patient ICP is 36. So after chiasm system open, at this time CSF come out, then we can open the integral system, and then open the liquid member. During the surgery, we wash out the subacral and hemorrhage. We dissection the liquid map. This time we see liquid map, and we cut the liquid and until the prepontine. Then we put the tube drainage. At this time, breathe is very relaxed, and ICP is down. After open the liquid, and we put the drainage tube into the second space. We put the tube drainage. This is then finished. After surgery, this is blood gas analysis and post-operative CSF drainage. This is basal cyst drainage. This is a vertical drainage. This is total drainage after surgery. This is post-operative ICP monitor. The ICP is below 40 at normal. After 1 month, the patient MSE scale is 25. The total scale is 30. The patient is very good. They can very good. They can communicate with us normally. Right?
干什么？
没头。
干什么？干什么？还是要干什么？
So we can communicate normally. This is my patient pre-operation. So ICP is more than 25. This patient bone replaced, all the patient bone replaced. At the highest is 38 at 36. So this is ICP changing at the GCF scale. So I think cystoscopy reflects a valuable option for treatment choice in severe TBI. Cystoscopy can be significantly reduced intracranial pressure and harmful metabolism, and can be beneficial to the progress of a traumatic brain injury patient. This surgical approach is gaining acceptance in many centers worldwide, and need to apply this technique and report more outcomes. It could prove to be a promising surgical technique by itself or as a complement to DC. This is my lecture. Thank you.
Thank you very much, Wang, for a fantastic lecture. I mean, I think right now we are not going to be very politically correct, and we would say it would not be a compliment to DC. It would rather completely change the neurotrauma world, and we should take DC out. It's time for DC to go out. Right. Now, Luis Borba is here. And we would like to, Luis Borba being a star of skull-based surgery, we would like to hear something from Luis as well. Luis, are you here?
Yes, sir.
Yes.
All right. Welcome, Louis.
Hello. First, I'd like to apologize that my connection was not okay. As I was watching Dr. Wang's presentation. During my career, I did a lot I treat a lot of patients with trauma. A lot. Always the brain was swollen. Always the brain is very angry. And there is something that you are changing, you are to treat these patients. But I don't think that we treat, from the bottom of the heart. We as a neurosurgeon, we treat the trauma the same way that you treat brain tumors, skull-based tumors, aneurysm, cavernomas. Sometimes the trauma is slipping away. See? And I think we didn't use, I say me include, we never used the microsurgical techniques in trauma. I don't know why. Not the techniques by itself, but the ideas to relax the brain, to perform better understand of the physiology. And I want to say something. When I met Dr. IP many years ago into me, he gave a lecture about cisternostomy. I didn't believe. You know why I didn't believe? Because I trained a lot of trauma and the brain was coming out. But never in trauma, in contusion. I went there and did microsurgical techniques, open the system, communicate the thing. And after that, I started doing some case. Large contusion, went there, the system communicate, take CSF leak, the brain come out, and the blood supply to the brain is coming. Our goal in the trauma is to bring more blood to the brain survive. If you relax the brain, the blood will come. And I used to do skull-based tumors, especially when you're dealing with the temporal lobe, like Antero-Petroso approach. We used to put lumbar drain. But the brain was not always well relaxed. And the temporal bone was, the temporal lobe, not temporal bone, temporal lobe was a big issue. You put lumbar drain and the temporal lobe still was there. And I start to change my approach to reach the frontal lobe, go to the basal system, open the basal system, not take a little bit of CSF leak, not just release a little bit. Went down and released a lot of CSF leak. After that, I come to the middle fossa, do the peeling of the middle fossa, and the temporal lobe is completely relaxed. It's completely different surgery. Professor Vladimir, I think he was online here, he can say to us, Professor Yashargil, I will say, when you do any kind of approach, you should have one system in your approach to release CSF. See? And this idea, the trauma, I think it works. I don't know about the brain that hypoxia severe, that you open, everything come out, is terrible. You cannot see even the skin. But some case that you can relax and give more blood supply to the brain, I think is a great idea. And the people has to start to do it. Before say it doesn't work, let this try. And you see the difference. Now we are doing our case, not in every case, and the patient has severe brain edema, severe brain swelling. We are not doing, because sometimes it's difficult to go down, but if the patient has a subdural hematoma, acute subdural hematoma, you are going there, open the cistern, have the contusion, you go there, open the cistern, take CSF leak, and the brain relax, and the blood supply come to the brain. I think this amount of blood that we gave the opportunity to reach the brain can be one factor to help in the brain. I don't know. It's I see Professor Ben is here. Hello, Vladimir.
Hello, Luis. How are you?
I would like to hear you. You are.
Can I continue?
That you are following during many years.
Yeah. We've known each other for many years, Luis, and I fully agree with you. This was rather nice what you have said. You must remember the old article of Paul Busey, who was resecting uncus in trauma patients. And actually, that was nearly the same procedure. He also had to open the cisterns to resect the uncus. I never understood why this procedure, which was rather straightforward and simple was abandoned. That's one fact. But the other fact is that we all know that in neurosurgery we have 5 big circles. It's tumors, vascular, functional, spine, and trauma. And trauma, brain trauma itself, it hasn't changed too much since mid 20s. No, nothing really happened. We are still decompressing the brain. We are still just doing cosmetics from what was started on the road. You know, we are not doing nothing more but cosmesis. And suddenly there appears a new procedure which might be beneficial. That's an analog to supine hemorrhage, of course. And thanks to Ipe, and I've known him for many years, and I guess that the first thing that when we have met and I said my name, he told me cisternostomy instead of his name, you know, and since that I'm hearing only this from him. A little more, sorry. And I believe that despite all the evidence which is coming from trauma people, despite all the criticism, and if you read the criticism which was attached to Roy's article in ACTA, it was rather severe, but rather centered on technical issues only. It's not technical. I don't know who has said it just before me. It's not about the microscope, no microscope. It's not about anything like that. It's really about the concept. And the concept is bringing, in my mind, something new to neurotraumatology. And we should be the ones to pursue it, and we should be the ones to give it a chance. Luis, would you agree with that?
Yes, 100%. It's
Thank
about physiopathology, not about the surgical technique. It's physiopathology.
Exactly.
To understand different way and approach different way the disease.
Yeah.
You go there, you give to the resident, go there and do decompress. It's very easy to say. Go there and do the junior resident, the junior faculty, go there and do the decompress. Same happen.
Yeah. Trauma is the field where all the youngs are learning their techniques. It's the first thing you do when you come to the department as a young resident. It's trauma. And when you get older, you just leave trauma. You know, only those who are not able to manage, and I'm saying it rather harshly, who are not able to manage in other fields of neurosurgery, in more reconstructive ones, are staying behind in trauma. This is very, very harshly said, but this is my ultimate feeling.
Professor, do you remember the shunt? Many years ago, the DVP shunt was the last surgery in the day. Nobody want to do. Who will do the shunt? Give to the medical student, you see?
Right.
And very high level of infection, very high level of dysfunction, very high level of misposition. And the people, I think from France, Professor Maurice Chou, with his experience in brain tumor, he started to talk about shunt.
Right.
Why shunt? He said that was the first surgery in the morning, that the room was completely clean, few people inside the room, and they changed the way to treat DVP, the hydrocephalus and DVP shunt.
Yeah.
Maybe the trauma,
surgery.
you are still doing the same thing.
Yeah. 18-minute surgery for shunts, if you remember that. But since then, we all are having shunts as number 1 in the ORs. I don't know about you, but we do that.
Yes, for us.
Yeah. And the trauma, you know, in trauma, it's always difficult to prove something because actually we are talking about very heterogeneous degree of concussions, degree of consciousness disturbances, whatever, you know. It's not really one single disease like, let's say, clinoid meningiomas, which are uniform. This is very heterogeneous. So to prove something, you need really huge numbers to be able to prove some idea. And that's something which might be difficult in anything to pursue trauma further.
We need to stimulate. We need to stimulate a cooperative study.
Exactly.
Many people is doing around the world. My people say, and a few people is writing. Maybe you should do more cooperative study around the whole world that you can prove. Maybe not work to every case, but some select case will work. I think so.
You know, quite a few days ago, I had a lady patient with low back pain, severe, unresponsive to any treatment. And the only finding she has had was a Tarlow cyst, you know, a huge one. And I only then realized, talking to her, that the patients themselves do divide us neurosurgeons into two groups, believers and non-believers in Tarlow cyst, if you operate them or not, you know. So in that way, I'm unbeliever. But in cysternostomies, this is now the same situation, that we are believers and non-believers. And it's up to IPE to prove it, to organize some huge study and to prove the concept. You might be famous, IPE.
Thank you, Luis and Vlad. You both are big stars. It's always an honor to have you guys, and you are as close as friends can be as well. So it's always good to have you to come and say something in these kind of meetings. You know, we are in a stage where I remember 2007 when I started talking about cysternostomies, the kind of response that I used to get. I have transformed from, I say, the palace joker to the confuser, people who confuses, somebody who confuses everybody. Then to some people started believing in me. Then I became somebody who fights with everybody, because I thought, you know, I was talking sense and people were, you know, shooting me down for it. So I realized that I will stand up. And when that happened, I was the guy who fought with everybody. Then I started to convince a few people. And now we have come to a stage where, you know, people are talking about a trial and things. I'm happy everything happens slowly, but I'm sure once people do cysternostomies and realize that the change that they see compared to DC, you know, I'm sure people will change. Science has never been my strong point. You know, literature, writing papers, as Sabarish said, in 13 years, 4 papers have come out, and that too because of people like Hira or somebody else who's helped me, who's literally caught my neck and asked me to get all my data out. And, you know, we were never very well prepared. I was busy operating. I could never write. And I guess that's probably why I don't like papers too much, or all these reviewers who used to send me very, very nasty comments. I mean, so nasty that sometimes, you know, if they were not in Europe or something, I would have gone and I would have just walked there, opened the door and kicked their ass, you know, that nasty sometimes. As if, you know, you are some kind of base animal who doesn't deserve anything. And that's the kind of attitude people had. So probably that's why I fought with a lot of people. But now it's coming of age. Now I'm understanding a lot of people who are doing it are understanding the same. So I guess I'm becoming a bit more mature. And people like you, Vlad, Luis, and many more people are understanding and supporting us. And a lot of people like Wang, Roy, they're doing it and they are also understanding. They are turning believers as well. And as Vlad said, it's always about two communities, believers and non-believers. I realized that you cannot convert one to another. You just really don't need to, you know. You just need to do your work and go ahead with it. Of course, I would like to, for the greater benefit, as people say, I would like people to turn to it. But now I've stopped pressing it and pushing it or anybody. If somebody wants to do DC, let them do it. Somebody wants to open the systems, I'll be happy to help. But there's no pushing it on anybody. It's a free world. We are not yet slaves, so it's a free world. Anybody wants to do something, it's as long as we believe we are doing the best for our patient, anything is acceptable. But as I said, as everybody said, microneurosurgery has to come to trauma. There's no other way. It is, as Vlad said, we are still in the 1920s with trauma, and that's not acceptable. So we have to change. Thank you so much. Nilesh, the next person, please. We have Victor Hugo Perez, I guess, with the forensic.
Yes, sir.
That's going to be a very interesting.
Let me say goodbye. I must leave by now. Louis.
Yes.
Yes.
Thank you, Professor.
Thank you, professors. Thank you.
Yeah.
Great.
Hello, Ike.
Hey, Victor. Let's.
How are you?
We are waiting for your talk, Victor.
Yeah, thank you so much for this honored invitation. Let me share my screen. I want to know if you are looking the full screen.
No, not full screen. Not full screen. Now you have to maximize it.
Okay. Okay.
First share it and
now,
then max. Yes.
Now,
yes.
Yeah, there you go.
Okay, let's talk about the forensic issues in brain damage injury. I have been doing dissection in the forensic service in Mexico City for about 32 years. So as I have been there to make dissection, I have seen so many cases of brain trauma. Of course, in cadavers. So more than 50% of all cases of death encountered at forensic autopsy are associated with primary or secondary involvement of the nervous system, especially of the brain. The forensic pathologist must be able to judge or comment on nervous system injuries and or disease in dead, as well as sometimes in living subjects. The importance of forensic neuropathology and associated neurology is reflected in the statement by Kirby, describing his own unhappy experience to learn that all too often a misinterpretation or an erroneous evaluation of a cerebral lesion has led to a gross miscarriage of justice. Official autopsies can be performed at the discretion of a forensic pathologist under the following circumstances. Sudden and unexpected death of persons in apparently good health, cases involving evidence or suspicion of violent death, especially of accident, suicide, or homicide. Deaths resulting from suspected medical malpractice and or negligence. Deaths occurring during incarcerations or while in police or institutional custody. Manner of death. A strict distinction must be made between the manner and the cause of death. The manner of death differentiates between natural and unnatural death and will give further information of the mechanism of deaths, accident, suicide, or homicide. The cause of death also defines the cause of the irreversible cardiac and respiratory arrest or of the respiratory brain, as already mentioned. This is a picture of a man who died of severe subarachnoid hemorrhage secondary to rupture of middle cerebral artery aneurysm. As you can see, he has a big hemorrhage. The most common cause of accident death is in affluent Western societies is traffic accidents. The fatality often caused by mechanical brain injury. Accidental deaths in the workplace are comparatively rare. Such deaths usually involve the sequela of traumatic blunt impact, the death sometimes occurring after lengthy hospitalization and resulting from secondary complications. This is a girl who fell from 3 meters high. She hit herself directly in the skull. As you can see, she had a severe traumatic multifragmentary fracture in the skull, and also a severe brain damage, laceration, and hemorrhage. This is a picture of this poor baby. Skull fractures. Compact bone is more rigid than trabecular bone and can withstand greater pressure, but less tension and stress. Trabecular bone is highly elastic and is well able to store and release energy, whereas the ultimate strain limit of cortical bone is a 2% change in initial dimensions. Trabecular bone can withstand as much as a 75% strain deformation before fracture. This is a skull base made in resin in a scale 1/1, and I show in this skull base the neural elements, the vascular, sinus, arteries, and this is very useful to understand anatomy of the skull base. Skull fractures are the morphological result of contact violence and only exceptionally of non-contact forces. The skull's morphology and biometry and thus its stability to external mechanical forces vary with age. Direct forces generated by local impact can cause cranial fractures, or if they affect the base of the skull, basal skull fractures. Indirect forces released by a bullet can produce burst or teardrop fractures via the transfer of energy. This is a severe fracture in the skull. Here we have an anterior floor fracture, and it's typical view in the people who suffer this kind of fracture. Here we have a severe subarachnoid hemorrhage. The most common feature in traumatic brain damage is subarachnoid hemorrhage, the most frequent. As you can see in here, this is a severe subarachnoid hemorrhage. Basilar skull fractures. Basilar skull fractures are normally bursting fractures, and the causal mechanisms are the same as in linear calvarian fractures, which often extend into the base of conversely start here because of the lower fracture tolerance, which is the result of the numerous local weak points of the structure of the skull base. The causal load can be a fall to the ground or being driven over of the wheel of a vehicle, a blunt impact to the neck, mandibular or facial impact, or an impact to parts of the occiput, and almost any type of diffuse impact to the vertex of the head. Here we have some fractures in the posterior fossa of the skull base in here. If we see this in a closer view, look at this. This fracture is in the location of the longitudinal sinus. So these fractures can cause a tear of the dura of the sinus, and we will have a severe hemorrhage from this location of fractures. This is a transverse fracture in the temporal bone, and a transversal basilar fracture, which involves the petrous bone, frequently leads to bleeding from the external auditory canal and can be manifested by this symptom. This is a severe skull base fracture in the three fossas, anterior, middle, and posterior fossa. This is caused by a severe automobilistic accident. The epidural hemorrhage is most commonly related to traffic accidents, especially rare in children under the age of 2 and in the elderly. usually involves arterial bleeding. The lucid interval between the generation of injury and appearance of the first symptoms is commonly short. In very rare cases, however, the interval can last up to days. It's caused by local impact loading of the head and is thus nearly always associated with contact injury. Extradural hematoma arises from injury of the middle meningeal artery and its branches near the impact sites. This is a very big epidural hematoma located in the right lateral aspect of the skull. Edge of fractures bone can cause laceration of underlying dural arteries and least frequently veins. In rare cases, this kind of hematoma is caused by lacerations of one or more branches of the venous sinuses or emissary veins. Extradural hematoma rarely occurs spontaneously. This is the case that we saw in the anterior slide. As you can see in here, we have a very big epidural hematoma, and this is the fracture that caused this big hematoma, the middle skull base fracture. In this view, this epidural hemorrhage occurs when a fracture crosses the midline, the middle meningeal artery, which adheres tightly to the inner surface of the temporal bone. About 24% of all instances of skull fracture are associated with epidural hematoma. This is the trajectory of the middle meningeal artery, and look at this. This is the fracture. Here we have one fracture, and this is another one. When the edge of this fracture separates at least more than 1 or 2 millimeters, it can tear the dura mater, and we are going to have an arterial bleeding. So this is the skull base to understand the anatomy of the skull base. Epidural hemorrhage, a space occupying this kind of hematomas will displace the brain, resulting in compression of the brain stem. We could have an herniation syndrome. So here we have a small boy that died because this kind of hematoma. He was operated, but could not survive because of the damage and the herniation syndrome. This is the boy. And here we have the craniectomy, the site of the craniectomy. But let me show you the fracture that this little boy had. This is a fracture closing the trajectory of the middle meningeal artery, and let me show you the fracture. In here, we have a separation of the edge of this fracture, maybe 2 or 3 millimeters. So this is the cause of this kind of hematoma. The subdural hemorrhage bleeding is a bleeding into the space between the dura and the arachnoid. Is commonly associated with mechanical brain injury and has a correspondingly high mortality rate, especially the acute subdural hematoma. It is most frequently found in elderly and alcoholics, often in connection with a fall. Subdural hematoma tends to be initially overlooked in the absence of fractures, intracerebral hemorrhage, or early neurological symptoms. These are the features, the forensic features of this subdural hematoma. This is a big acute subdural hematoma. We can see some subarachnoid hemorrhage, and here we have the displacement of this hemisphere, brain hemisphere, and we can see also a laceration in the brain, in the parietal lobe of this brain. This is the skull base, and here we had we saw this hematoma. Cortical lacerations associated with fissures, linear fractures or depressed fractures of the skull can cause subdural hematoma when arteries or veins are torn by sharp bone edge. Attendant lesions of the arachnoid will result in bleeding into the subdural space. In most cases, laceration or contusion injuries of the scalp are found at the site of impact. This is the cause of death was this acute hematoma, which is most of the times combined with brain lacerations, as you can see in this slide. So the source of the bleeding may be arterial or venous, according to Cranial. Survey of his own cases and cases in the literature. The sources of this kind of hematoma are in order of frequency as follows. Cortical hemorrhage between 60 and 70%, tear in a bridging vein in this percentage, arterial injury and sinusoidal injury. In this dissection, I want to show you the relations between the bridging veins and the superior longitudinal sinus. I am separating, I am putting the Pacchioni arachnoid corpuscles we can see also some lacunae venous. I am dissecting the arachnoid, and we can see the bridging veins. This is important cause of subdural hematoma, especially the chronic subdural hematoma. Secondary lesion, herniation syndrome. Supratentorial brain herniation exhibits the following major patterns: subfalcine, central transterrial, oncal, and tonsillar. If untreated, it can culminate in total intracerebral circulatory arrest, brain death syndrome. So here we have a scheme showing this kind of hematoma, and this is the oncos of the temporal bone. Let me show you in this person. Look at this. The oncus was very edematous and also with a small hemorrhage. So oncal herniation results from lesion expanding in the lateral middle fossa or temporal lobe, displacing the medial edge of the oncus and hippocampal gyrus, medially and over the ipsilateral edge of the tentorium cerebelli. Compression of the midbrain occurs, as well as compression or stretching of the contralateral or ipsilateral third cranial nerve. In its classic form, oncal herniation syndrome entails compression of the posterior cerebral artery and ipsilateral cerebral peduncle and stretching of the ipsilateral oculomotor nerve. Look at this. Here we have the temporal lobe, the oncus, and the resulting symptoms include diminished consciousness, contralateral hemiparesis, and a dilated ipsilateral pupil that is unreactive to light. Compression of the opposite cerebral peduncle against the contralateral edge of the tentorium, Kernohan notch, will induce hemiplegia ipsilaterally to the mass lesion. Progression to coma then rapidly follows pupillary dilation. In this picture, we can see the subarachnoid hemorrhage that is the most frequent feature in brain damage, in traumatic brain damage. So in these pictures, I am showing the Duret hemorrhage in the brain stem because of the herniation of the uncus of the temporal lobe. These are known as Duret's hemorrhage. Such secondary changes, which are common to all types of intracranial space occupying process, can produce focal hemorrhage in the corpus callosum, cingulate gyri, hippocampal gyrus, and the brain stem. Here we have an hemorrhage in the oncus. Look the close relation between the brain stem, the third cranial nerve, and also the posterior cerebral artery. So in this, if we know these anatomical relations, we can imagine the clinical features in a patient who had this kind of hematoma. I want to give my acknowledgements to the Forensic Medical Service of Mexico City and the state of Mexico. In this picture, I am showing you this Duret's hemorrhage in the brain stem. So thank you very much, dear friend Ipe, for giving me the opportunity to talk about my experience in the forensic field here in Mexico. So hope the COVID pass away and we can see in Mexico to enjoy several places that are really, really beautiful. Thank you to all of you.
Okay, very good, Victor. Thank you very much for this presentation, as well as all the ones you've done throughout the years in neuroanatomy. You're one of the tops. Nilesh, you want to have something to say? Are you there, Nilesh? Perhaps he stepped away.
Hello.
Oh,
Hello.
okay. Any parting
Yes,
words? Any parting words, Nilesh?
Yeah. Dr. Ipe has to leave for some important meeting with the chairman. So I'm here on behalf of the organizing committee. I wanted to thank to all the eminent professors and faculties to sharing all this time and enlightening us with this all this information. We would like to participate you in the tomorrow's dissection and afternoon webinar as well. And we will like to all of you to participate in for the tomorrow's webinar also. Thank you, and I wish you all the happy Diwali also.
Okay, very good. Okay, here's the schedule for tomorrow. The program for tomorrow,
Yes.
dissections start. You can see this
At
okay?
9.
You can see this okay?
Yep.
Yes.
Oh, yeah, 9 o'clock, dissections start. And it's the same schedule. We have a spine symposium, a lot of spine talks tomorrow, as well as cranium. So we hope to see everyone tomorrow. And thanks once again. Thanks everybody for coming. Chandra, thanks. Louis, Barbara, Joanna, Young Hong, all you. It's great for you, all you guys to come out.
Luis Borba, nice to see you.
Hola, Víctor, ¿cómo está la cosa? ¿Todo bien?
Bien, sufriendo el COVID.
Bueno,